Good morning, everybody. Nice to see you this morning. I'm glad you're all here. We are in the home stretch, right? Day 3 of a 3-day conference. Today's going to be light work. We finish at 3 o'clock today versus 6:30 the previous 2 days. So I am so excited to have this group on board. This is the 3rd year with us, consistently the highest rated session. So I'm sure this year will be no less than that. I have Dr. Mehdi Shishabor, president of Harrington Heart and Vascular Institute, University Hospital. Is Dr. Lee here yet? Nope, Dr. Lee will be on, clinical assistant professor at Case Western University School of Medicine and affiliated with University Hospital. Dr. Ben Kovard, assistant professor of surgery at Case Western University School of Medicine. and vascular endovascular surgeon at University Hospitals. And we're happy to welcome Dr. Yolanda Castro Dominguez, interventional cardiologist and vascular medicine specialist with University Hospital at Harrington Heart and Vascular Institute. So I am immediately going to turn it over to you. You all, once again, really happy to have you on board, and I know the attendees are as well.
Rich, thank you so much. Good morning, everyone. Dr. Lee is trying to get in. We're having a bit of a firewall issue, so she'll be in momentarily. Listen, this is the highlight of our year, to be honest with you. This is a great meeting. We were just discussing it with Rich earlier days, a few years ago. We used to do this in person, and now with the Zoom. And here's Dr. Lee. She just joined us. We see you, June. Thank you so much. And I was just telling Rich yesterday, we had a long day. We have our meeting, the American College of Cardiology in New Orleans. So Dr. Castro is joining us from New Orleans. She's there. And June and I, we had some live cases yesterday from UH that were transmitted to New Orleans. So that was fantastic. And we are now here this morning with you. And yesterday, June presented did a nice limb salvage case, and I did a case of a PAD patient, so it was all great. Today, what we are hoping and what we've done in the last few years with you guys is to give you an overview of first perfusion assessment in PAD. So I will start the session with a perfusion assessment for PAD. We'll have maybe a 5 or 10 minute discussion and questions, Q&A. And then we'll follow that with Dr. Yolanda Castro Dominguez, one of my partners. She will be discussing disparities in PAD and CLI. And this is something that we are very passionate about. We believe that we need to address the fact that if you're African American and you walk into a hospital, you are 4 times more likely to get amputated and 3 to 4 times less likely to get revascularized. So we are really want to address this, and Yolanda has been at the forefront of this. We followed that with Dr. Ben Covart, who is another partner of mine, a vascular surgeon, and he's going to discuss kind of a hybrid approach. One of the beauties of our program is our interdisciplinary kind of work together and our ability to leverage each other, as interventional cardiologists, vascular medicine experts, and vascular surgeons, really checking our egos at the door and working together, learning from each other, elevating each other's game, but most importantly, taking care of the patient, saving limbs. And we are very fortunate, I am very fortunate to have colleagues like Ben and Dr. Castro and Dr. Lee. And then, as usual, we're going to end it with Dr. Lee, and she's going to show you some extreme cases, so extreme limb salvage, including some cases of DVA, deep venous arterization, and some complex endovascular cases for limb salvage. And like I said, let's keep it interactive. After each talk, let's have 5 to 10 minutes to discuss and have some Q&A, and we go from there. So with that, I'm going to get started my first presentation. So let me share the screen. This was a little. Let me do this. Okay. No, 1 second. Cancel. Let me try this one more time. I apologize. I was having a problem with this earlier too. And I have the slides here, but when I try to do it, let me do this. Maybe this will work. Can you see my slides?
No. Click the share screen in the lower left. Can you see me, or can you see us?
Yes, I can.
Okay, click the share screen in the lower left.
Yes.
Then hit entire screen. Then click the screen and then hit the blue share.
Okay, you got it.
And then on there, see, now just click your PowerPoint on your computer
Yes.
and then hit full screen or presentation mode.
Yes.
Perfect. Click it again. There we go. Okay, great.
All right. Well, good morning. Good morning again. Thank you so much, Rich. So we're going to discuss perfusion assessment, and I think this is the foundation of how and why we get into trouble with patients with PAD and specifically CLTI or CLI. The fundamental issue is that what they taught us in medical school and podiatry school and in vascular medicine rotations was that ABI is the test that we do to assess perfusion, and we were told that if it's 1 to 1.4 is normal, 0.91 to 1 is borderline, and so on and so forth. It turns out that the ABI, if it's abnormal, is very helpful, but if it's normal or borderline, is not very accurate, and it could get you into trouble when you're dealing with patients with CLTI. ABI was specifically identified as a screening test for patients with PAD, not necessarily to assess perfusion for CLTI. And I will explain this today in this presentation. Now, I don't want you to think that I'm saying ABI is bad, and that's why I'm showing you this case. This is the case from my former institution. He's a 68-year-old man who had ischemic cardiomyopathy, congestive heart failure, history of myocardial infarction, atrial fibrillation, coronary artery disease, prior CABG, and so on and so forth. You can see all the issues that this poor man was dealing with. He had these ulcers for 2 years. 2 years he was dealing with these full-thickness ulcers. And in the chart, these ulcers were attributed to basically non-compliance, lower extremity edema, and they had documented on multiple occasions that the pulses were intact. And because he had heart failure, they believed that he had edema, and they keep telling him, raise your legs to control the edema, and he wouldn't do it because he said, I have pain, I can't do it. So they referred him to me for wound evaluation, like, do you have any ideas? Do you think he has venous insufficiency, or what do you think is going on? So I saw the patient, I was like, man, I can't just rely on my fingers. I mean, why don't I just get an ABI, in this case, a PVR, and see what's going on? And you don't really need to be a cardiologist or a vascular surgeon to understand this. This is all flat lines, and these flat lines indicate that this patient has significant PAD. You can see that there is significant disease all the way in the high thigh and all the way down to the toes. So the way we do the PVRs is that we have cuffs at the brachial level, and then there are cuffs at the high thigh, high calf, low calf, and at the metatarsal and the toe. And when I saw this, I was like, oh my goodness, this man has significant vascular disease. How could this have been missed for 2 years? And why didn't we just get an ABI? It's such a simple test to obtain. So based on that, I took the patient to the cath lab to see what was going on. And let me walk you through this. Hopefully you can see my mouse here. So we normally enter these arteries from the groin. So here we are, this is my needle here, and I'm entering the right groin. And when we enter the groin and we get some blood back, we pass a wire through the needle to try to get access to the artery. And when I was passing my wire, the wire wasn't going up. So I was like, oh my God, something is not right. The wire is not going. So tried it a bit harder, couldn't get through it. So at this point, I decided to convert to the arm and go from the wrist and come up from the arm down into the aorta and take a picture with what we call a pigtail, which is the device I'm showing you with the mouse here. And when we took the picture, we saw, lo and behold, the aorta was 100% occluded, and this patient had significant vascular disease with a total occlusion of the aorta that was causing significant ischemia and the inability for him to raise his legs. So when he said I have pain, he really had pain because he had no blood flow to his legs. The sad thing about this story, honestly, is that this is a patient we can treat right there in the cath lab within 45 minutes. And this is a man that was suffering for 2 years with PAD and CLI without any treatment. And it really bothered me that, we are dealing with patients out there that have significant PAD, ulcers, suffering, and that even a simple test that could identify the problem was not being performed. So after revascularizing him, you see this was the picture before, and this was after revascularization. Again, significant amount of occlusion. We had a total reconstruction of the aorta and the iliac system. Now the man has flow to his leg, and suddenly he became compliant. And we were able to heal his wounds in a 4 to 6 weeks period. The sad thing about this story about this patient was that because he was wheelchair bound for 2 years, he couldn't even barely walk. We had to send him to extensive physical therapy to teach him how to walk using a walker and being able to enjoy his life. So again, ABI can be very helpful if it is abnormal, like the case I just showed you. So I would say that the first thing we should do, if you have a patient with an ulcer or gangrene, or if you're concerned because you're going to do a bunionectomy or you're going to do some kind of a revision in the foot, and the patient has diabetes, history of smoking, hyperlipidemia, has some history of claudication, I would start with an ABI at the minimum. Now, when we go into CLI, that's where things change. So here is where the ABI doesn't work very well. So this is a 52-year-old male who came in with severe diabetes. He actually had a hemoglobin A1C of 13, hypertension, and hyperlipidemia. You can see that he had a number of ulcers, well-defined, full thickness with necrotic base. And there were a few of these, and these all had healed across his leg, except this one. Actually, there was a lot of controversy as to what the etiology of these were. We thought maybe they were necrobiosis diabetica lipoidica, and that he had good perfusion and he had healed those ulcers, but this one maybe didn't heal. So what we did, what I'm suggesting to you is that we obtain an ABI. And when we obtained the ABI, look what we found. He said the ABI was 1.19. We then said, well, look at the waveform, and the waveform even looked good. So we said, well, ABI is 1.19, waveform looks good, maybe this patient is okay. But then we said, well, where is the ulcer located? The whole concept of the angiosome, meaning that if the ulcer is on top of the foot, should we be looking at the PT or the DP? And if the ulcer is on the bottom of the foot, should we be looking at the PT or the AT? And because of this, we went back a little bit higher and we looked to see what's going on. If you look at the PT, you see that it says, if you look at the DP, you see that it says non-compressible, non-compressible. This is very concerning. And I will show you some data from our own patients that shows that 80% of the time, when you see an artery that says non-compressible, is either severely diseased or occluded. So non-compressible should raise a red flag. So right off the bat, I was concerned. I was like, well, this wound is on top of the foot and we need the DP, and the DP is non-compressible. Well, then where does the 1.19 come from? It turns out that the way ABI is reported as the higher of the two numbers, of the PT and the DP. So when you order an ABI, they don't know where the ulcer is. They don't even care. They report it based on what the higher of the two ABIs are. So in this situation, since DP was non-compressible and PT was 1.19, they gave us the 1.19. The more important thing is that the wound is in the distal foot. And what is the TBI look like? And when we saw the TBI, we saw that the TBI was 0.36, and a normal TBI, based on the guidelines, is anything above 0.71. So with a non-compressible DP, a TBI that was abnormal, I said we need to take this patient to the cath lab for an angiogram. And we took the patient to the angiogram, and as you recall, here on the left panel, this is the popliteal artery, right? The first branch is the AT, and lo and behold, look at this. The AT is totally occluded. So when we did this angiogram, my fellows were very excited. They're like, man, Dr. Shishabur, you're incredible. How did you know that that, this is going to be the case, and this artery is going to be occluded. So I said, well, wait, there are still two more arteries. There is the PT and the peroneal. Maybe there is enough flow in the foot. And then when we took the picture in the foot, we saw that there was no collateral blood flow into the wound, which was at the top of the foot, at the dorsum of the foot. And this is an indication that this patient has significant diabetes mellitus, significant endothelial dysfunction, and lack of collateral formation. So in this situation, we came and we fixed the AT. And after we fixed the AT and the DP, look what happened. We were able to manage the wound. And in short time, we were able to heal the wound. So the teaching point from this for us was that when you see a normal ABI, be careful, because you need to understand the angiosome, where the wound is located, and you need to understand, are you looking at the DP or the PT? And more importantly, maybe we should look at the toe brachial index, especially many of these patients which have disease in the distal foot, meaning that their wounds and their ulcers and their gangrenes are in their toes or the distal foot. So that was the patient that came in with a normal ABI. How about in patients that we treat? Let me share with you this case. It's an 82-year-old patient with diabetes mellitus, a female with a history of charcot arthropathy and prior great toe amputation. You can see the patient has a full thickness midfoot ulceration. And in this patient, when we did the ABI was abnormal. It was 0.56. So we said, okay, well, this patient has PAD. We need to do an angiogram. So this was relatively straightforward. So we took the patient to the cath lab, and we found out that the patient had significant disease in the popliteal area. This middle panel is basically popliteal disease. There's some calcification here, and there's some disease here, about 80% more distally in the P2, P3 segment of the pop. And you see that first branch on the right panel, that is the anterior tibial. Now, you all know that there should be 3 tibial arteries going to the foot. And as you can see here, the patient has a totally occluded TP trunk. PT is 100% occluded. Peroneal is 100% occluded. And the AT is severely calcified and tapers at the level of the ankle. So in this situation, we said, well, let's fix the popliteal artery and see what happens. And this is what gets a lot of us into trouble. So we fixed the popliteal artery. It looks beautiful on the left panel. You can see we fixed this area with some atherectomy and at that time, angioplasty. The AT and the below the knee, we left it alone. And this is where the problem is, that in these patients, you have to fix the outflow. You have to fix the outflow. Look what happened. Here at that time, this case is from 12 years ago, we stopped the case. We said, well, let's check the hemodynamics, the ABI, and see maybe it's enough. Maybe fixing the popliteal is enough to heal the wound. And when we check the ABI, look at the ABI. ABI now is 1.12. So ABI is normal. And the way this study was read by the vascular technologist was that the ABI is normal, no evidence of PAD, could not rule out microvascular disease versus spasm because the waveform in the digitals were not normal. Even though we know based on the angiogram that this patient has significant below knee vascular disease. The below knee vascular disease is a very, very important concept that you as podiatrists and us as vascular experts need to understand, because this is how you guys get into trouble and we get in trouble, because you send the patient to us, we fix the inflow, and we send them back to you, and we tell you everything is great. And look at the ABI. ABI is now normal. You're all good. You guys go ahead, do your toe amputation, your partial ray amputation, but then the patient doesn't heal and ends up with more proximal amputation, and then everybody doesn't know what's going on. Well, if we don't fix the tibial disease, if we don't fix the outflow and the inframalleolar foot disease, you won't be able to heal the wound. And look what happened in this patient. Patient came back, the distal foot was looking a little bit better, but lo and behold, look what happened. Because we had told the patient, stay off your foot, she started having a pressure ulcer in her heel. And we thought that the ABI was normal, things are going to be okay. But look what happened. The wound was getting bigger and bigger. And we said, you know what, we got to take this patient back to the lab. Now we took the patient back to the lab, and we were much more aggressive with the outflow, with the tibial disease. with an inframalleolar disease. And look what we did. We were able to cross the arch, come down the PT, and through some maneuvering and technical dexterity, we were able to revascularize this patient in this way. Now you see there is a blush, there is flow to the heel, there is flow to the distal foot. Now we can heal this patient and we can save the limb of this patient. You can see that a little bit more delay, a little bit more not committing would have probably led to an amputation of this leg in this diabetic patient. So because of these patients, we went back to our data and we wanted to understand what portion of the patients that come into us with CLTI, with wounds and gangrene, have normal or near normal ABI. So with one of my former fellows, Dr. Bunty, we looked at our patients and we saw that 29% of the time, patients that come to us have a normal or near normal ABI. This was a single center study. We then said, well, that single center, can we apply this more generally, more globally across the United States and more internationally? So we went to a database of international patients of about 400 patients who had core lab adjudicated angiograms and ABIs. And in that study, we asked a simple question. What portion of the patients that had CLTI, these are patients all with ulcers and gangrene, had normal ABI that was non-compressible greater than 1.4, borderline ABI, or severe ABI? And then we looked at their angiogram. We said if they had 3 severe vessel disease, meaning that all of the tibials were either diseased or occluded. That means there was no inline flow versus 2 tibial disease versus 1 tibial disease. And we were dumbfounded with what we found. What we found was that amongst the most severe situation, meaning that patients that had severe disease in all tibial vessels, either 100% occluded or severely diseased more than 80%, with no inline flow, 28%, 14% were non-compressible, 14% were normal ABI. 28% ABI was not interpretable. So if you just relied on the ABI, you would have misdiagnosed the patients. Remember, we previously showed 29%. So please, if you see a patient that comes to you with an ulcer or gangrene, if you have an ingrown toenail and the patient needs to be evaluated for vascular disease, getting an ABI alone, you're going to miss the diagnosis 1/3 of the time. Every patient that needs to be evaluated for distal foot perfusion needs an ABI with a TBI, toe brachial index. You got to look at the toe TBI and the toe pressure. If the TBI is less than 0.65, 0.71, that indicates there is vascular disease. If the toe pressure is less than 65 or 70, that indicates there is vascular disease. And this was another study that came afterwards from another group confirming our findings we showed for the first time in the first 2 publications. And this was a study that came out in 2018, confirming what we showed, that in 25% of the patients, ABI is going to be normal even though they have CLTI. That was another study from Michigan. Now, so far I've shown you patients coming in with normal ABI. I've shown you that if we don't do complete revascularization and fix the tibia, the tibial vessels and the inframalleolar arteries, we can be fooled by normal ABI, that we need to monitor these patients with their TBI. Now I want to show you that even if you do the tibial vessels, even if you fix the outflow, still we have a problem with microvascular disease. And let me show you that with this case. This is a 65-year-old male with end-stage renal disease, diabetes, hypertension, hyperlipidemia, and severe PAD. He had a prior angiogram of his right lower extremity. And now he came to see me with this avulsion of his great toenail, with the necrosis at the tip of the toe. And what you can see is a dependent rubor. So we did the ABI in this patient, and ABI was abnormal. So we said, okay, patient has PAD, we need to do something. We took the patient to the cath lab, and we did an angiogram. And lo and behold, we found that the patient has a desert foot, meaning that there is no named artery in the foot. This is another patient that's a candidate for bypass. There is no DP, there is no PT, there's nothing here. And then we looked at the tibial arteries on the left panel, and you can see that there is severe disease of the arteries. So we took this patient in and we said, okay, we need to fix the outflow. We need to try to do our best. And through extensive work, we were able to open these arteries up and to get it to this point. Honestly, I was so excited. This is from 12, 13 years ago. I thought we did an incredible job of fixing this to this level. But look what happened. The patient came back 2 weeks later, and lo and behold, he had a demarcation and significant necrosis of the distal foot. At the time, I was very worried. Now I know that this is not uncommon when you revascularize patients with severe disease. There is a demarcation that happens at the level where there is perfusion and there's no perfusion. So this is part of the physiology of the disease that we deal with when we do revascularization. But I was also worried that what went wrong here? Like, why did this? I was expecting this to do better than this. So I went back to our hemodynamics. I looked at the ABI before the study. I looked at the ABI after the study. So it went from 0.55 to 1.04. It went to normal ABI. But I knew that ABI is not accurate. So I said, I got to look at the TBI. The TBI before the procedure was 0.24, which is severe, as we discussed. The TBI after the procedure was 0.16. And this brings us to this issue of microvascular disease. So it turns out that CLTI or CLI, patients that you and I treat with diabetes, with CKD, with end-stage renal disease, they have macrovascular disease. That's the tibial disease. That's the inframalleolar DP and PT disease. But they also have microvascular disease. And it turns out that despite aggressive revascularization of the tibial vessels and the pedal vessels, we're rarely able to normalize the TBI. You can see here in this figure that pre-procedure to post-procedure, over 90%, 95% of the patients, we were not able to improve or normalize the TBI. Yes, TBI improved if you look at the median, but it didn't get to normal. So what do we do in these patients? That's where we need to do aggressive work with guideline-directed medical therapy, high-dose statin therapy, smoking cessation, antiplatelet therapy, anticoagulation therapy, and those kind of things. And that's the beauty of this multidisciplinary team. When we work together as podiatrists and as vascular experts, we can communicate, we can relay information to each other, we can really help these patients, both from a standpoint of macrovascular disease, microvascular disease, wound care with your expertise, and ultimately limb salvage. Now, this is almost my last slide. Remember I told you, when you see non-compressible, you should think of it as either severely diseased or occluded. And this is a study that we published kind of proving what I told you already earlier, that if you see a vessel here, for example, anterior tibial, and the reading says non-compressible, just assume that 80% of the time, 60% it was occluded, another 20% it was severely diseased. So non-compressible, basically, to me, it means that that artery is occluded. That patient needs an angiogram. So if you have a wound on the dorsum of the foot and the wound is not healing, and you see on the reading it says non-compressible, know that that vessel is occluded and that patient needs evaluation. I highly recommend that you actually look at these ABIs and TBIs, the waveforms yourself. Don't just rely on the report, because unfortunately, as I told you, ABI is reported as the higher of the two numbers, and sometimes you can get tricked. So yes, CLI is much more complicated. We wrote an editorial a few years ago saying that it's time to redefine CLI. And the reason what we mean by that is that we can't rely anymore on just our fingers and whether the pulse is good or bad. We can't just rely on ABI. In 30% of the patients, we need to get the TBI. And if the wound is not healing, we need to get an angiogram. We need to work together, podiatrists, vascular experts, working together in trying to heal patients. So in conclusion, in approximately 30% of patients with CLI or CLTI, ABI is normal or non-compressible. In greater than 80% of the times, if you see a vessel that says non-compressible, that vessel is most likely occluded or severely diseased. And in the presence of a non-healing ulcer, angiogram is the only sure way to assess proper perfusion to the wound. In these patients with end-stage renal disease, diabetes, CT scan doesn't work very well in the tibial and the inframalleolar region because of significant calcification. Thank you so much. I'm happy to take questions for 5 minutes, maybe 10 minutes. We can have a good discussion with the panel, and then we move on to Dr. Castro's presentation. Thank you again for the opportunity. Let me stop sharing here. And any questions we have?
We have several questions on the comment box, Mehdi.
Okay, Yolanka, do you want to moderate the questions for a moment? And I'm happy to entertain, or maybe a few of them. If you guys answer some of them, it's okay. But if you see any good ones, please.
There's a question about, somebody mentioning they always get based on ABIs, TBIs in diabetic patients over the age of 55. And the question is, if there's evidence of non-compressibility, what should they do next? Should they get CT imaging, MRA? What else should we do if we see in screening test a non-compressible ABI?
Yeah, that's why I really showed that slide, Yolanka, with the data that we published. Is that if you see non-compressible, just assume that artery is occluded. I will move to the angiogram. What we are learning is that, and Yolanka, please, you comment too, and I don't know if Ben and June are also on, but what we are learning is that when in doubt, we should get an angiogram on these patients. These are patients with diabetes. These are patients with end-stage renal disease and CKD. If the wound is healing and the TBI is good, fine. Listen, we don't want to do unnecessary procedures. But I'll be honest with you, if you, as podiatrists, you tell me, if one of you call me and say that, listen, the wound is not healing, something is not going forward, I don't care what the ABI and TBI shows, I'm going to angiogram the patient. And we are learning that with our skills and with our understanding of the tibial disease and the inframalleolar disease, that we are able to improve the blood flow to the wound and heal these patients faster. Because, we focus a lot on limb salvage, which is great and is the most important, right? We want to not have amputation. But we also want to focus on timely wound healing, right? It's not just about amputation-free survival or not getting amputated. It's also about being able to go to a restaurant without your foot smelling. Go to a restaurant wearing a tennis shoes versus wearing a surgical boot. Go to, be able to sleep in bed, go to work. I don't know, Ben, what are your thoughts? Do you agree with more aggressive evaluation in these patients nowadays?
Thanks, Mehdi. I just wanted to also comment on this question. I think the specific case here was that she's getting ABIs and TBIs on all diabetic patients over 55. And then, when one comes back abnormal, the question is, what do you do from there? I think if you're screening all of your patients with diabetes, obviously that means they're not all patients with wounds. So when you have a patient who maybe has no symptoms, or they just come for routine care of their feet because they have diabetes, if they don't have a wound or a symptom, then an abnormal ABI and TBI should prompt aggressive medical therapy to prevent them from getting wounds and from progressing. There's not really a need to get more imaging to figure out exactly which tibial vessel is diseased if we're not going to treat them. And if they don't have a wound or a rest pain or some kind of symptom from that, then we don't need to chase down, using expensive workup. That abnormal test should be a prompt to send them to their cardiologist, family doctor, vascular medicine doctor, to make sure that they're medically optimized, meaning they're on a statin, they're on aspirin, their diabetic medications are optimized. So that's what I would think of with an abnormal ABI in a otherwise asymptomatic patient.
That's a great point, Ben, and I really appreciate you mentioning that. So what we are saying here, like, let me reiterate that if you don't mind, because I think it's a very important point. We are not suggesting that we should go to an angiogram in people that don't have ulcers or gangrene. Please, we are not saying that at all. What we're saying is that if a patient has an ulcer or gangrene, or you're going to do some kind of operation like a bunionectomy in a patient with diabetes or a patient with end-stage renal disease, those are the patients you want to understand more what's going on. In other patients that don't have anything and they're just diabetic, and you're managing them, and let's say you get an ABI and TBI and they're abnormal, in those patients, you have a very important role. And the role is that to make sure, as Dr. Kovar just mentioned, that they're getting risk factor modification, meaning that you're referring them to the right person to manage their lipid, get their hemoglobin A1C to less than 6.5, get their blood pressure under control. For example, at UH, we have a program called Cinema specifically for these patients. Any patient with PAD and diabetes can be referred to the Cinema program, and the Cinema program is a multidisciplinary program dedicated to patients with diabetes and vascular disease, either the ones that have heart disease or PAD, vascular disease. So there's a lot that can be done in those patients, but not an angiogram. Obviously, we reserve angiogram and revascularization for patients that have ulcers, gangrene, wounds, or you tell us that, listen, I'm going to do a bunionectomy, or I'm going to do some kind of a surgery, and we do an ABI and the TBI is 0.2. And then we are like, well, don't do surgery, because once you cut the patient, there's going to be a wound, and that may not heal. Maybe we need to optimize the patient before you do your surgery, but not routinely, as Dr. Kovar mentioned. Thank you so much, Ben. Any comments from you, Yolanka, in regards to some of the questions or anything you want to mention?
Yeah, some of the questions, I'm just going through some of them too. There was one question regarding if we should order PVRs routinely with ABIs. If we're just screening, if we're trying to do widespread screening in patients with diabetes or in patients that don't have wounds or not symptomatic from a PAD standpoint, if we just want to know do they have PAD or not, just the ABIs. Just a simple ABI may be enough to screen, but if we're looking to establish the location of the disease, the lesion, the location of the stenosis in symptomatic patients, or we have patients with ulcers that we're trying to identify more clearly if they have disease or not, PVRs are very helpful. So that's when we go the kind of additional, the extra mile. So if you're seeing patients in the office where you want to be more specific, recommend that you also order PVRs with ABIs.
Absolutely. And
Mehdi, there's another question in the chat regarding how long post-angiogram is it safe to stop some of your anticoagulants or antiplatelet therapy so that an amputation can be undertaken?
Yeah. One of the things thank you, June, and that's a great question. I think that one of the things that we highly recommend is that we try not to disrupt the antiplatelet therapy and anticoagulation as much as we can, because as you know, these vessels are very small. When we do angioplasty on them, we create inflammation, and inflammation, is a milieu for thrombosis. So it's like a vicious cycle, right? So we commonly ask, please don't stop aspirin, don't stop Plavix, clopidogrel. Some of these patients now, we're putting them on anticoagulation. We call them DOACs, right? Like Xarelto. You may have seen some patients coming on with a low dose Xarelto. So if possible, I encourage that if you can, please consider doing these amputations, especially if they're minor amputations, right? If you're doing a TMA, I can see that being a problematic, and we may want to stop the Plavix or the Xarelto. But for toe or partial ray, if there is a way to not interrupt the anticoagulation, I think would be helpful. We typically like to continue the anticoagulation until the wounds heal. Once the wounds heal, we then tailor down and then just keep people on aspirin alone or Plavix alone, things like that. The other thing that we look at, and maybe, June, you want to comment on this, in regards to the complexity of the case. And so having a good communication with the vascular expert who did the procedure regarding the anticoagulation maybe also be helpful. Any comments you want to make about that?
Yeah, I agree. And every procedure is a little bit different, right? So when Dr. Kovar talks about the hybrid procedures, that's going to be a different milieu than when we do endovascular. And then depending on the complexity of the case, there may have been complete reconstruction of the entire leg from the hip to the ankle, in which case we really want at least something on board. Interruptions sometimes are okay. So if you talk to us, and then we can work as a team to give feedback as to what could and could not be done. Something else to keep in mind, so many of these patients also have concomitant coronary artery disease, such that sometimes you can't even stop aspirin in patients with, for example, multiple stents in their coronaries. The last thing we want is for these patients to end up with an MI during the operation. So it's important to work with your cardiovascular colleagues to determine the antiplatelet and anticoagulation strategy.
I think one. Oh, go ahead,
One
Mehdi.
last question. Go ahead, Ben, please. One last question.
I just wanted to comment, on the timing of amputation. It's not uncommon, and I guess one benefit of doing some of these revascularizations in a hybrid room or kind of an OR type setting is that we can do a big multi-level revascularization procedure, and then we can have the podiatrist come in at the end of that procedure in the sterile OR environment and do the amputation then and there. So that's something we consider as well, as trying to combine our services to make things more efficient.
Absolutely. Well, thank you so much. And we're going to continue to answer these questions. So please send more questions, because it's going to get even better. So we're going to go to Dr. Castro. And like I said, there is an area of extreme passion for all of us, the four of us, and I know many, many of you, if not all of you, around disparities in CLTI and what can be done. How can we work together to take care of these complex patients? Thank you, Yolanka.
Thank you for the opportunity to talk this morning. Very happy to be with all of you. And please, if you have any questions, just make sure you put them on the chat. So I'll be talking about how can we address disparities in PAD and care for patients with chronic limb-threatening ischemia. So first, we should talk about how PAD is a marker for increased morbidity and mortality in many patients. And lately, over the last couple decades, there's been data showing that there's an increasing prevalence of PAD. And the data that we have is that over 200 million people worldwide have peripheral artery disease. And it's estimated that around 8 million people over the age of 40 in the US have peripheral artery disease. And with an increasingly older population, its prevalence is only rising. And it reflects to a higher morbidity and mortality in our populations. We know that patients with peripheral artery disease have a higher risk of subclinical, that means without symptoms or without events of ischemic cardiovascular disease, and higher rates of cardiovascular events compared to other healthy patients. And we know the prevalence of myocardial infarction is 2.5 times higher, and the risk of that is also higher in patients with peripheral artery disease. And we know that what we're trying to prevent is major limb amputations. And the reason why is not just it's not just to prevent the limb loss, but also because when patients with CLI face major amputations, they also face a higher risk of mortality, up to 40% at 5 years. And that risk of mortality is higher with older age. And following major amputation, less than 50% of patients are ambulatory. And this is adversely affected by high BMI, frailty, and perfunctional status. And we know that amputation can be potentially delayed and or prevented by timely and aggressive medical and behavioral change therapies, as well as revascularization. However, some of our patients may face limitations in terms of access to care in order to get the correct evaluation and care to prevent amputations. And we see higher prevalence of peripheral artery disease in some vulnerable populations, such as African Americans, which face 2 times higher prevalence of PAD compared to whites and Hispanics, and a higher risk of losing a limb from PAD. And we see that the distribution all across the US, especially in areas of lower socioeconomic status in rural areas. And this is because many PAD risk factors are higher in African American patients. Now, some other studies have shown that patients are Black and Hispanic have higher rates of primary amputation without an actual revascularization attempt. And we see that in these graphs that are listed, that's showing higher rates of primary amputation in Black and Hispanics compared to white patients, and also high rates of amputations in Black, Hispanic, and Native American patients coming in with CLTI. And now this graph, what we see is a map of the US zip codes with amputation rates by 100,000 Medicare beneficiaries. And we see in the darkest area that has the highest quartile of major amputations from 450 to up to 7,000 amputations per 100,000 Medicare beneficiary, Medicare residents. And we notice it's in areas of the country that are more rural, or have more Black residents or more low or residents of a lower income, which unfortunately have higher rates of amputations. And this is partly explained by a lack of enough vascular specialists in these areas, where patients have to travel long distances to be evaluated or to get care. And we also see this in areas that are lowest income and majority Black zip codes. And although rural zip codes have higher rates of amputation than metropolitan zip codes, the vast majority of patients undergoing primary amputations actually live in metropolitan areas. And we see that in this graph, in these major cities. First, in this first graph, we see the colocalization of majority Black race and high amputation rate zip codes. You see, for example, in the city of Philadelphia, in the blue, we see the higher rates, highest quartile of primary amputations correlates with areas that are majority Black. And we see that as well in other cities like Miami, Detroit, and Atlanta. In addition to that, this study also showed that in other cities, this correlates as well. The rates of major amputation correlate as well with areas with lower median income. And we notice this with the darkest blue. Those are the areas with highest quartile of major amputation. And in the green, we see the areas with lower median income for the household. Now, what are the stages of treatment and prevention of PAD and CLTI? Which areas can we intervene in order to prevent major amputations? And it all starts in patients from the primordial prevention, patients who are asymptomatic, the exercise, healthy diet, but also in terms of primary prevention, once the patients have been identified, that involves the medical therapy, antiplatelet therapy, cholesterol lowering therapy, diabetes control, smoking cessation. And then once the patients are symptomatic with wounds and developing limb ischemia, it's important to have aggressive antithrombotic therapy, wound care, and surgical percutaneous revascularization in order to prevent amputations. And the thing is that PAD progresses slowly, and there are a lot of opportunities here where we can intervene in order to prevent limb loss, and also to prevent the end stage where revascularization is not possible. We know that among patients undergoing perivascular intervention, Black patients often have more advanced disease. And although they similarly undergo complex intervention, they get the same amount of drug-eluting therapy, stents, type of surgeries. However, they're more likely to undergo amputation in the year after intervention. Now, why are these disparities in revascularization and limb salvage? And there are at least potentially and significantly due to racism and discrimination. This authors listed here have actually pointed out, and also the American Heart Association has pointed out, how discrimination and racism leads to increased stress, increased inflammation, which can lead to increased vascular aging, like increased arterial calcification, increased oxidative stress, which can lead to progression and rapid progression of PAD. In addition, cultural racism is a big factor that involves into this disparities in health outcomes. That is from stereotyping, which can lead to individual level unconscious bias, and then lead to inferior care, such as not performing revascularization due to concerns with adherence to medications. And next is the structural racism, which affects health outcomes by creating residential racial segregation. And this happens, and the reason why this happens is we notice that a disproportionate proportion of Black and other non-white people living in areas of concentrated poverty, and this leads to less investment by government and private sector, fewer jobs and educational opportunities, and in turn, that population have difficulty practicing healthy behaviors, such as having healthy meals because they have poor access to grocery stores with healthy meals, with healthy foods. and also leads to difficulty accessing primary and subspecialty care. They often have to travel out of their town in order to see specialists or primary care. And we know that residential racial segregation ultimately leads to inadequate treatment of chronic illnesses and disparities in health outcomes. And we see that across pregnancy, outcomes after heart attacks, and now we see it in outcomes from peripheral vascular disease and amputations. And looking at this progression of peripheral artery disease to critical limb ischemia and major amputation, there are multiple areas where we can attack. And this is the graph that I was showing before. We know that there are barriers in low communities with low socioeconomic status. And one of the things that happens is that chronic stress, environmental toxins, and living in food deserts with no safe places to exercise limits the primordial prevention of trying to have healthy meals and trying to have engage in healthy exercise in those patients who are asymptomatic. Now, in those that need primary prevention, lack of access to primary care, lack of access to pharmacy, or insufficient funds to have co-payments limits their treatment once they're symptomatic with their PAD. And then, and furthermore, since they have limitations in referral to or access to PAD subspecialists, that can lead to further progression of the critical limb ischemia or hourly wage jobs without flexibility for them to actually go to the visits for if they had a wound. They often have to go, to weekly or multiple times a month visits. And, if they have jobs that limit their flexibility in order to get the care, that's going to hinder their recovery. Other barriers to care is lack of awareness. And at the patient level, we know the low rates of knowledge and screening for PAD is a major barrier in order to increase it, that we need to attack in order to increase awareness of PAD. And this also translates to lack of awareness regarding the risk and consequences of amputation and low levels of physician trust. At the level of the provider, there's also low disease awareness of PAD among primary care providers. There's inadequate knowledge of physical and diagnostic methods for PAD, and also an inadequate knowledge for treating asymptomatic and symptomatic patients. We've noticed that often primary care providers know that patients with coronary disease need to be on aspirin and statins, but we often see that patients with peripheral artery disease, which is an equivalent to coronary artery disease, are often not on just a basic medical therapy, and that is antiplatelet therapy and lipid-lowering therapy. So there's an inadequate knowledge at the provider level for treating patients who are symptomatic or asymptomatic. We also see gender disparities, and although the gender and age-specific prevalence of PAD has not clearly been defined, the data that we have that is more recent from 20 years ago has shown that women are more likely than men to have PAD. And although the cardiovascular morbidity and mortality has not been well defined, we do know that females are less likely to be referred to a vascular specialist. And we know that when they undergo interventions, they're less likely to be prescribed the guideline-directed medical therapy for those patients. And that is antiplatelet therapy, antiplatelet therapies, and statins, as well as ACE inhibitors in those that have hypertension. And the gender gap increases more among patients with CLI, which is kind of that high-risk paradox. Those patients who are at high risk of actually losing a limb often do not get the best treatments. And looking at different factors among women compared to men, we know that in terms of smoking, there's more smoking-related diseases in women, and those who are non-smokers, often they have high risk of developing PAD. In patients who have diabetes, is double the risk of symptomatic PAD in women. Women who have our older age will likely have more PAD as well. Women often have more atypical symptoms. And when they present with in the latent phase, that tends to be longer, which can potentially lead to a great risk of CLTI presentation, but their CLTI presentation is often more common. Now, what are the potential solutions? At that individual operator level, individual physician level, we need to recognize interpersonal racism and discrimination in ourselves in order to work to counteract biases. Consciously recognizing our biases can help us overcome it. So if we don't know that there's a problem, we won't be able to overcome it. And recognizing the presence of these disparities can hopefully help us recognize and prevent us from perpetuating them. At the level of the At the level of the operator, we should also know that when we're faced with a poor, rural, or Black patient, we need to ask ourselves if we're treating the same as if it was a white or rich patient, in order for us to stop perpetuating the same biases. At the level of the health system and government, we need to recognize that current system causes inequities. We need to invest in building systems that bring Black and low patients from low socioeconomic status into care earlier, before they need complex revascularization or before they need a major amputation. And that would involve better interface with primary care doctors, perhaps ABI testing at the PCP offices, ABI screening in urban and rural communities that we know have high amputation rates. Also educating patients and primary care doctors about PAD diagnosis and management, and potentially improving home-based PAD exercise programs for patients that have limitations to go to supervised exercise programs. Now, what are the ways that we can improve awareness and treatment? We need to engage with community leaders in order to involve more of the communities in transmitting messages and training them in order to screen our patients to self-screen for PAD. We need to empower patients and to identify a self-exam guide in order for them to recognize wounds or recognize if they have symptoms for PAD. And also develop provider education programs to raise PAD awareness and focus on improving the diagnosis and initial treatment for African American, Hispanic, and Native American patients living with PAD. And one of the things that is being done with legislation, and this is going to be my last slide, is actually something that's been going for legislation now, is the Amputation Reduction and Compassion Act, or ARC Act. And the proposal with this legislation is to require Medicare, Medicaid, and group health insurance plans to cover preventative screenings for high-risk individuals so that PAD can be caught and treated early before it leads to amputation. And also to disallow payments for non-traumatic amputations if anatomical testing is not performed first. And then establish a PAD education program at the HHS so that doctors are more aware of PAD symptoms and required to implement quality payment measures that will reduce avoidable amputations. Thank you.
That's a great presentation. Thank you, Lenka. I think the topic of disparities is very hot in our field, not just in peripheral vascular disease, but in cardiology in general. Certainly, we want to do our best to treat the patients that are underserved. What can we do as kind of the primary podiatry, for example? What can we do to raise awareness? If you were a podiatrist, how can we do more outreach? How can we expand our knowledge to the populations out there?
Yeah, so there's different ways that we can, I think we need to engage at the community level overall, understand, using this data. When I first looked at this data, I was like, oh, I need to know what's happening at my community level, understand exactly the rates of amputations, and understand the care of the community in order to see what the community needs, and engaging with them. Engaging with the primary care providers, engaging with everyone that sees these patients first line. And that even goes for emergency room doctors as well, that sometimes see these patients presenting with symptoms and don't recognize them. It's all about education, increasing awareness of PAD and increasing recognition. So, I think that's where it all has to start. But we need to identify which are the populations that are vulnerable in order to decrease the disparities.
Ben, any comments?
No, I mean, I think it's really. I made this comment earlier in the chat here. I think it's just kind of a cop out and too easy to say that our treatment failed because the patient is non-compliant, and we've been saying that in the medical field for decades, right? That's kind of like, oh, well, they're non-compliant. So I think it is incumbent on us as the medical, providers, doctors, podiatrists to try to figure out why, what is the barrier here? Is it a lack of understanding? I mean, I think there's a lot of times where you sit in the office with someone and you can end the visit and just kind of say, well, they're non-compliant, they're not, it's not going to work or whatever. But if you spend pretty that being compliant, and you might be able to help that person. So I think you just have to think about that and not take the easy route, which is to, let them be non-compliant.
I think you hit that right on the nail. Sometimes you have to really understand from the patient's perspective, why are they not taking the medications that you have advised? Sometimes it's a cost issue. There are patients that tell me the Xarelto is costing them $400 a month to pay for. And obviously, if I were that patient, I probably wouldn't be taking Xarelto myself. So you have to really dig deeper and understand and just spend time with each patient individually to, from their perspective, put yourself in their shoes, to know what's preventing them from doing the things that we believe would be helpful for them. I think as cardiovascular physicians, we're trying to do that. And then I think from a podiatry standpoint as well, I know everyone's limited on time, but I think it's important.
There's a good question here about if there is a genetic component to the increased amputation rates. That's kind of twofold. We know that there's in some populations, there are higher rates of, because of genetic composition, there's high risk of hypertension or diabetes. But looking at it, it does not solely explain the lack of vascular evaluation or the higher rates of major amputation. And it's, looking just from the genetic standpoint can also be a little fatalistic because, we can't do much about genetics. And what we need to look at is at factors that we can actually affect. And that is trying to address those populations and that have limited access to care, which is kind of the major limitation overall for a lot of the patients. And, one of the things that are important, especially in those maps that I was showing of even in those metropolitan areas that are not rural, where patients should have more access to facilities with vascular specialists, with better like more and more podiatric care. Those patients still have a higher risk of amputations, and that is majority due to lower socioeconomic status. And it's those patients who have potentially underinsured, who have limitations in order to get their co-pays, that have issues with transportation in order to go to visits. Those are the patients that we need to potentially pay more attention to and be able to facilitate their care.
Great. I think in the interest of time, we'll move on to Dr. Kovart's presentation. Thank you, Dr. Castro. I know you have to hop off soon for ACC. Thank you for the excellent presentation. Ben, do you want to go ahead?
Yes. Let's see here. Hold on one second. There we go. Okay, can you guys see that?
Yes.
Okay, thank you. Okay, so I just wanted to thank Rich and the organizers and everyone for coming and for inviting me back this year. It's really a great pleasure for me to present this talk for you today. As a vascular surgeon, my job is to, in this topic for PAD, is to save limbs using various techniques, including open surgical revascularization, as well as endovascular techniques. And that's where, when we combine the two, we talk about hybrid revascularization. So there's been a big push to increase the use of endovascular techniques for lower extremity revascularization because of the minimally invasive nature. It's fast. I mean, opening up an SFA can maybe be done in 30 minutes or an hour, and the patient goes home the same day, versus if we were still if we were still limited to doing a bypass, that's, can be a 3-hour operation that requires a couple of days in the hospital. So it's very, there's great reasons why we do endovascular techniques for revascularizing people with wounds. There are a few areas in the body that are still kind of tricky and not optimal places to use endovascular techniques, specifically the common femoral artery and the femoral bifurcation. The popliteal artery is a tricky area, especially the TP trunk and the trifurcation, as well as tibial occlusions that extend into the plantar or tarsal branches. Although newer techniques are getting us to the point where we can treat these pretty effectively. Open surgical revascularization for the femoral artery is the first line of treatment still today, which helps us ensure a nice durable outcome and that the profunda is maintained. Because as I'll explain later, we need inline flow through the femoral artery into the SFA and all the way down to the foot for wound healing. But once a wound is healed, the profunda is what keeps the leg alive in the long term. So like I mentioned, the good aspects of open surgical revascularization is that it's very durable and we protect important arterial bifurcations. Unfortunately, in some areas such as the aorta and the iliac arteries, there can be significant morbidity for open revascularization. You have to open the abdomen, you have to clamp the aorta, and we can have wound complications in the groin, especially in active smokers or obese patients. And a lot of these procedures do require general anesthesia, especially if there's going to be extensive surgical exposure and work required to revascularize them. So a hybrid approach kind of takes the pain out of the aortoiliac revascularization. It's the first line for most of these patients, and it combines open surgical techniques and endovascular interventions. And it's especially useful, or pretty much the use of it is for multi-level occlusive disease. For example, a person who has a femoral artery occlusion, but also has iliac or aortic occlusive disease. So instead of doing an aortobiofem where we open the abdomen and open the groin and do a bypass to get around the aorto and iliac blockages, we do a groin incision and then we do aorto and iliac stents, so we don't have to open the abdomen. In certain cases, we can do these under local anesthesia with just sedation, so they don't need a full anesthetic. And again, the extent of the revascularization that we do is going to vary based on the symptom. So most of my patients have critical limb ischemia, and that's kind of the main topic of the session today. So patients with rest pain or an ischemic wound. So in a patient with rest pain, we don't necessarily need inline flow to the foot. We really, in that case, will often just focus on getting the profunda open so that they can get some blood flow down to the leg through collaterals. And that is almost always enough to get them out of rest pain. For a patient with an ischemic wound, we may be doing 2 or 3 level revascularization to get a wide open highway, from the heart to the toe, is what I tell the patients. There can't be a blockage in order to heal a wound. This is just a couple of examples of the difference between the two approaches. Sorry. So on the left side of the screen, you can see, I'm treating the blocked aorta and iliacs as well as femoral arteries through an incision in each groin, versus the same type of disease and revascularization in a patient who's getting a retroperitoneal incision all the way, from their left flank down to the pubis, as well as groin incisions. So a big difference, and there's a variety of reasons. We still do aortobifemoral bypasses, but I would say the majority of patients with aortoiliac and femoral disease do get this hybrid approach. This is a case where we did multi-level revascularization for a patient who presented with wet gangrene of the right hallux. She has kind of multiple hits causing her severe PAD. Her A1C was over 13. She had a recent MI with PCI in the last 6 months. She was an active smoker with hypertension and COPD, basically all of the bad comorbidities that lead to this type of problem. My partner was on call when she presented, and she was actually having pedal sepsis. So she was hypotensive, she was requiring systemic antibiotics, and she was taken to the operating room on an emergency basis to do a drainage and amputation of that toe. So she was left with quite a big and nasty operation here to drain the infection. So this is how I met her on Monday morning. We ended up getting ABIs, and you can see here, actually the femoral waveforms are not bad, but on my clinical examination, her femoral pulses were quite weak, and she's a thin lady. I would expect to feel them very easily. And then you can see the waveforms are very blunted as we go down beyond the femoral arteries. And once you get down to the toe, looking especially for this diabetic, we need to get toe pressures. On the right side, the toe pressure was 0. Looking at her CT scan, you can see extensive aortoiliac calcifications. You can see here on the left side, the aorta is patent but severely calcified, and then the iliac arteries are nearly occluded, at least from what we can see on the CT scan. On the right side, you see that the SFA has multifocal stenotic lesions and is heavily calcified. So these are some examples of how we revascularize and the techniques we use to open the femoral artery. So the femoral artery in the groin, it splits into the profunda and the SFA, and we need to, especially in a patient with a wound, we need to get both of these open. The profunda for long-term survival of the leg, and the SFA for the short-term healing of the wound. So in patients with occlusive disease extending into both of these arteries, we can do what's called a bifurcated patch. So we cut the end of the patch down the middle, and we sew one part of it down onto the profunda and one part of it down onto the SFA. And that actually, if the rest of the SFA is diseased, that gives us a kind of a runway to get into the SFA to be able to put in stents or, do an angioplasty. Most patients have what we see here on the left, which is a very focal patch extending from the iliac onto the profunda. So we make sure that the profunda gets wide open flow. Like I showed earlier, we have these bifurcated techniques, or we can resect the entire femoral artery and do a bifurcated graft that's pre-made, and we pull this graft off the shelf and sew it into each of the vessels. Usually that's done in reoperative surgery where it's not possible to retain the native femoral artery because it's already been endarterectomized and it reoccluded. So in that case, we may just replace the whole artery. Once we have the femoral artery revascularized through a groin incision, then we move on to fixing the aortoiliac segment. And what's important here is that when we put in the stents in the iliac arteries, I will often extend the stent into the patch of the femoral artery. So that's going right up to the inguinal ligament, and the patch is going beyond the inguinal ligament into the iliac artery. That way there's overlap between the areas that I've treated, and there's no diseased segment left behind. And then we can often, depending on how extensive the disease is, sometimes we're able to stick to one side and just do unilateral stents. Occasionally, the disease spills over into the other side, and we'll have to raise the bifurcation and put stents from both sides to get up to where there's a normal flow lumen. In this case, we did continuous coverage of the diseased common iliac artery into the proximal external iliac artery. And actually the distal external iliac, you can see here down in the sort of to the corner, was not very diseased. So once we cleaned out the femoral artery, we really only had to put stents in the common iliac artery and the proximal external iliac. And by using an uncovered stent where the blood can flow through the holes of the stent, I was able to preserve the internal iliac artery. So in this patient, we know she had multi-level, so iliac disease, femoral disease, and SFA. So once I punctured the patch and went up and treated the iliac disease, then I pulled out my sheath and punctured it going the other way to treat the SFA. And you can see in this case, kind of what we saw on the scan, kind of a ratty, multifocal, stenotic lesions of the SFA, but pretty nice popliteal artery and preserved tibial arteries. So in this case, I treated the SFA and into the popliteal artery with drug-coated balloon angioplasty. And again, this treatment here is what I'm doing to basically avoid spending another few hours doing a fem-pop bypass in addition to the femoral endarterectomy to the iliac stents. So a lot of time savings here. And even though the durability of a SFA angioplasty is not lifelong, it's almost always enough to heal a wound. So after that, we can see we have nice flow, brisk flow through the SFA down into the pop and the tibial vessels. And the main thing I always tell my trainees is that if a patient has a wound on their foot, you have to take a shot of the foot to see what blood flow is getting to the wound. In this case, great angiogram here. She has really nice flow all the way down into the foot. So this patient took about 5 months to heal, but finally she came to my clinic in follow-up and she was completely healed. And actually this whole episode was quite traumatic for her. We ended up she had an ulcer a smaller ulcer on the left foot. And so during that admission, we did both sides. And the whole, 2-week or so admission for her was traumatic enough that she stopped smoking. You can see the ABIs improved to basically normal. They didn't do a toe pressure on the right side in this case, but on the left side, you see the toe pressure the TBI increased to a normal value of 0.84. Looking down the road, we see that the SFA probably is becoming occluded in her. This is, I think, at the 1-year follow-up visit. You can see the ABI has dropped a little bit on both sides and the waveforms aren't as good. She's re-stenosing her SFA probably, but in this case, her wounds are healed. She's walking. You don't need the SFA once the wound is healed. So in focusing on getting her profunda online, we've given her a nice long-term durable outcome. So I always say, the SFA gives you a pretty picture and heals a wound, but the profunda is the junkyard dog that kind of guards the leg in the long run. And that's why we still focus on open revascularization of the femoral artery to make sure that profunda stays open to keep the leg on the body as long as possible. So hybrid revascularization, it is a safe and durable option in well-selected patients. There's a lot of creativity that we can come up with for treating the femoral artery with bifurcated patches, grafts, bovine patches, which allows for patient-specific reconstruction of the femoral arteries. It's important that we ensure that there's no diseased segment left behind, which is why we often will stent into the patch that we put on. And a foot angiogram, in my opinion, is mandatory if the patient has a wound. So, and the last thing I'll say once again is always respect the profunda because it keeps the leg alive. Thank you.
Awesome. Thank you. Great talk, Ben, as usual. What makes when you get a referral for a patient, obviously you have multiple skill sets in your toolbox. So deciding when the patient is appropriate for hybrid, when the patient is more appropriate for open surgery or complete endo revascularization. How do you make that decision? What goes into your algorithm when you're seeing these types of patients?
That's a great question. So it really, you have to look at the patient as a whole and see, is this so, first of all, what are we treating? If we're treating a wound, we're not looking for, gold standard 10-year durability of whatever we're revascularizing, right? We're looking to get blood flow to the wound for, maybe 1 year maximum is what we need. And then we just need, like I said, Profunda to keep them out of rest pain. So in a patient with multi-level disease, to do full open revascularization for aortoiliac and SFA, that's an aortobiofemoral bypass and then a FemPop bypass. So you're looking at, potentially 6 to 8 hours of surgery in some cases. If you need an extensive femoral endarterectomy, then you're doing aortobiofem, then you're doing a FemPop with vein harvest. That's a huge operation. So doing a hybrid approach for someone with 3-level disease really, really cuts down on the operative time, especially these patients have coronary artery disease, they've got COPD. So we really want to try to limit the amount of time that they're under general anesthesia and try to, frankly, get them back on their feet as quickly as possible. When I do an aortobiofem, that patient is really feeling like they got hit by a truck for at least a month. So it really limits the recovery by doing this kind of less invasive approach.
Dr. Castro and Dr. Covart actually work very closely together on the west side of Cleveland here. Dr. Castro, can you speak a little bit as to how the collaboration has been, and perhaps talking a little bit about the LSAC community that we have?
Yeah, no, thank you for the question. So, we try our best to try to, work with the communities and get involvement with primary care providers, with podiatrists in our area, and specifically on the west side. And I'll be working a lot more with Ben at Elyria as well. And one of the things that one of the systems that we've developed in order to try to prevent major amputations is our Limb Salvage Advisory Council, where we try to present any patient that before they get a major amputation, within amongst our group and within our system, we try to present those patients to try to evaluate them to see, we get kind of our own second opinions within our group, to see if there's any other avenues in terms of revascularization, wound care, or medical optimization that can be done for that patient before they get a major amputation. Because as our limb salvage team, our main goal is to make sure, no stone goes unturned before somebody has to get the decision to get a major amputation, and that's our goal. And that's where we work very collaboratively with our primary care doctors, infectious disease doctors, surgeon, vascular medicine, and cardiologists together. Great.
Then oftentimes, and we alluded to this a little bit earlier, in terms of anticoagulation strategy, and how do you deal with patients with extensive bypass surgery? Say you do an aortobiofem, does that change how you treat these patients afterwards versus doing endo? Are you more liberal? Are you more conservative about how you treat these patients in terms of, can you give less anticoagulants if you were to do an aortobiofem?
Yeah, actually, that's a great point. For an aortobiofemoral bypass, what we typically do is just aspirin afterwards. It's such a large caliber bypass that you don't really need dual antiplatelet therapy. So really any aortic reconstruction that we do open, for the most part, we're just giving them aspirin, baby aspirin, 81 milligrams postoperatively. Now I've started adding PAD dose Xarelto, but that is something that's kind of, we do that for their long-term risk factor modification to prevent thrombotic events based for PAD and CAD, but that, PAD Xarelto dose can be stopped anytime as needed, just because it's kind of a long-term therapy type of medication. So it's true, if I do a FemPop, if I were to do an aortobiofem and a FemPop instead of iliac stents and SFA angioplasty, the patient would go home just on aspirin, depending on the distal target. So, that's one thing to think about when we're dealing with these patients, if they've totally shown an intolerance to Plavix, they're allergic to it, they've had GI bleeds, it might be better to consider something where they won't need dual antiplatelet therapy.
Yeah, that's an excellent point. And it's part of the kind of something that we moved from the heart team concept as well for patients that have significant coronary artery disease that might need stenting versus bypass. And there's clinical equipoise in terms of which route you can go. If a patient really is intolerant of anticoagulation or aspirin completely, those patients typically get then referred for bypass. So in a similar fashion, you might want to make that consideration in those specific kind of patients where if they cannot be anticoagulated at all, that perhaps bypass may be the better route. All right. Any other questions before we move on to the last presentation here?
I think no, I just have to hop off because I have another conference, but very nice to be with all of you this morning, and we'll see you guys next year.
Thanks.
Thanks, Yolanda.
Mm-hmm.
Okay. So share. No, that's not it. Share screen. All right. That's visible.
Yes.
Thanks, Ben. All right. So last but not least, extreme cases, aka the fun files. Oh, that really went fast. Okay, I'm gonna go all the way back to the beginning. I don't know why it's doing that. All right, let me escape here. All right, let me try that again. Share screen. Okay, here we go. Wow, that's weird.
What's happening, June?
I wish I could tell you.
PowerPoint just kind of moving it on its own, kind of?
Yeah. Okay, I'm gonna try this again.
Okay.
Maybe I do entire screen rather than the app.
It's gonna. Oh, there you go.
Okay, better. All right,
Awesome.
great. Thank God. These are my disclosures. So we'll start with the first case. 51-year-old man with hypertension has known peripheral artery disease. He actually underwent intervention of his posterior tibial artery back in 2019 for a heel ulcer that subsequently did heal successfully. And he was doing great for a long time. He also has CKD with a baseline creatinine of 1.6, diabetes, and pyoderma gangrenosum. He's on Cellcept and prednisone chronically, so he's immunocompromised. He presented with right lower extremity ischemic changes for 1 week. So same leg that was revascularized in 2019. He had intact motor and sensation, but it was cool to the touch. His home cardiovascular medications included baby aspirin, statin. He was also on clopidogrel as well as a diuretic and some antihypertensives. So when we did our preliminary ABI, TBI, you can see there's essentially nothing happening at the ankle or the toes on the right side. Interestingly enough, on his left side, he has a intact ankle brachial index, but a 0.00 in terms of the toe. So we know that he has small vessel disease on the left side as well. But our interest today was on the right lower extremity. So we took him relatively urgently to the cath lab because of the symptoms lasting a week. And we kind of suspected that this would be thrombotic given the duration of symptoms. When we took our initial picture, this is of the popliteal artery. Everything else proximal to the popliteal artery was fine. And you can see a flush occlusion here right at the middle, at the P2 segment at the mid portion of the popliteal artery. And there's some reconstitution via collaterals, and then probably an anterior tibial artery that reconstitutes distally. So we first tried across from the top, and this wire actually found its way into the posterior tibial artery, and it seemed to be moving relatively freely. Unfortunately, stops kind of right at the end of the posterior tibial artery before it becomes the common plantar. So I aborted that path, and I instead went retrograde right into that little hint of an artery. Under ultrasound, we can actually see a lot of this very clearly. You can see the vessel, and you can see calcium. You can see whether or not the vessel is occluded chronically, or if there's a potential kind of small lumen that's still filling through collaterals. So we used an ultrasound guided access. We went retrograde through the anterior tibial artery. You can see this is the wire going up. And then we were able to then connect into the popliteal artery. You can see this wire traveling all the way up, and it's going to connect with where our antegrade wire from the top is. And then we ended up reversing the system, took a angiogram of the foot to confirm that the pedal arch was patent. And you can see a little bit of disease within the dorsalis pedis here. Some of this might have been from spasm from us accessing distally. And then because we thought this was a thrombotic milieu, we proceeded with something called JET-I, which is one of our newest thrombectomy systems. This is a cartoon animation of what happens with a JET-I. Essentially, there's a tube that sucks, has a mechanical sucking, and then on top of it, there's actually a water jet. This video is going to restart to show the water jet. This water jet helps break up the clot, especially in a more kind of subacute setting, which we thought this clot was based on the symptom duration. And it helps theoretically more efficiently bring the clot into the catheter itself. So we did a JET-I, and this was after the JET-I. Still a lot of clot residual despite doing the JET-I. At this point, I started giving some additional anticoagulation called integralin, which is a slight variation on antiplatelet therapy. So we started integralin as an additional bolus as to what we normally do with heparin anticoagulation on the table. Lots of ballooning then preceded that. And then we took an angiogram, and we see the popliteal filling into the anterior tibial artery, which then does fill the pedal arch. And at this point, I was relatively happy. You know, there's still a little bit of clot left in there. I was trying not to leave a stent behind in him if we could avoid it. I actually thought this was a clot that perhaps came from the venous system. So I was trying not to stent this area if we can avoid it. So I left him alone. We high-fived each other, started him on anticoagulation, so using integralin and heparin overnight, and he improved, actually. We proceeded with a hypercoagulable workup as well because he had a concomitant DVT. We excluded the PFO just to make sure that there was no evidence of paradoxical embolus, which was negative, actually. But 2 days later, he started to have recurrent rest pain on the right side. We repeated the duplex, and they actually showed that the anterior tibial artery had gone down. So we did take him back to the cath lab. And here you can see the popliteal artery still has some of that, we call it schmutz, but some clot in there. And the anterior tibial artery here, you can see all of the hard work that we put into it is now occluded again. And similar to when he first started, the distal reconstitutes. There's a hint of a pedal arch here. So the question then is, what can we do? That's a little bit different than last time. So I chose a different type of atherectomy device. So given that perhaps this clot may have been a little bit older than a week, maybe that's why the thrombectomy didn't work as well. So changing then our method, this is using a laser atherectomy. So although it's called an atherectomy, I have used it in more chronic clot or more subacute clot that's been there for several weeks. And what it does is using photoablative therapy, it actually essentially pulses that clot to make a lumen. So we crossed anterior tibial, we did a laser into the anterior tibial, and fortunately we were able to connect through the pedal arch, place the wire into the posterior tibial artery as well. Lots and lots of ballooning. And I did leave a stent into the anterior tibial artery as well, really to secure this inflow, just because there was ongoing residual thrombus even after the laser and ballooning. We did a cutting balloon across into the TP trunk, complete reconstruction of the pedal arch. And here you can see the final results. And he still has a little bit of clot. Here you can see, for example, in the mid AT, there's still a little flapping clot in there. But we kept him on anticoagulation. I believe this patient was kept on rivaroxaban, full dose, in addition to Plavix, to help him essentially dissolve the rest of the residual small clots that he has. And you can see late filling of the PT, but it's actually complete pedal arch here. And when he came back about a month later, this was his most recent ABI-TBI, you can see even the toe brachial index is 1.12. So we were able to save his limb, and he's doing great. Case 2 presentation. So 53-year-old obese woman. She has hypertension, diabetes, dyslipidemia, has CKD, had COVID 1 month prior. She actually presented initially to a different hospital with right foot pain. She was kind of blown off at the time, unfortunately. She didn't have these gangrenous toes that you see here, but she had severe rest pain at that time. And she was told to follow up as an outpatient, but she actually just came back like a week later with significant gangrene changes in all of her digits. In the setting of her COVID, I kind of suspected that this was more of a thrombotic milieu as well. So we did our ABI-TBI. Here you can see, again, the TBI is essentially 0. The ABI is 0.93. We took her to the cath lab, and similar to the last patient, actually, all of her inflow was great. Even her tibials were good, and really she only had a pedal arch that was completely thrombosed. So you can see actually the negative defect of the clot. Contrast is black, and you can see the clot just sitting in that pedal arch. So I was initially up and over. So typically when we first start with any patient that's never had any pictures before, we go from the opposite side so that we can start taking pictures from the iliac to make sure there is no other deficiencies angiographically. So we were up and over. I was able to get a balloon down there and a wire down there, but a lot of our equipment doesn't reach because we're up and over. I tried intra-arterial TPA, tissue plasminogen, to help lyse the clot, but there was no improvement at all. So then what are our options? Again, none of my equipment really reaches. So what I did was I left a wire across the pedal arch, and I directly accessed the anterior tibial artery distally. And then we snuck a wire again across the pedal arch, tracing what we had built first. And then we did the laser atherectomy. So again, this clot at this point is probably closer to a few weeks old, given that her COVID history was about a month ago. Typically, these clots tend to form after about 2 weeks. So I thought a photoablative mechanism would be better for the pedal arch. When we do laser of the pedal arch, not something that we usually recommend. It's not really for the faint of heart. We had to be very careful and use a very small laser and use very small energy levels so that we don't damage the pedal arch. So we did that, and then we did a cutting balloon to help make more lumen, and you can see the pedal arch is now widely patent. And there's still, again, a little bit of clot, but that can be treated with anticoagulation alone. The important thing is that we have a complete pedal arch to heal a TMA. So she underwent her TMA successfully, and she healed up nicely. Unfortunately, she has not followed up with me for her cardiac perspective. She actually has a little bit of mildly reduced ejection fraction that eventually we'll need to work on as well. Third case, this is a 71-year-old gentleman who has a coronary artery disease, had a prior bypass, has asymptomatic carotid stenosis, dyslipidemia, hypertension, diabetes, and end-stage renal. He's on peritoneal dialysis. So he presented to us initially with gangrene of the toes on the left side with osteomyelitis. He was actually previously quite active despite all of his comorbidities. He used to live part-time in Vegas and was really hoping to get back there. He has some, his brother is in Ohio, so he was visiting when he developed all of this. And he was referred to us to the limb salvage advisory council, essentially for endovascular salvage. This is his toes when he first came to see us. You can see significant gangrene of the third and fourth digits mummified. And actually, in both of his feet, they were essentially flatlined in the posterior tibial as well as dorsalis pedis waveforms here. So we went in and, because of his end-stage renal disease, we expected this. He was completely calcified, essentially from head to toe. So you can see multiple areas of calcific lesions is completely occluded in the distal SFA here, as you can see, and really nothing happening below the knee. There's some reconstitution distally, which may be the peroneal here, and you can see a hint of the anterior tibial artery here. So we accessed the, actually that would have been probably the anterior tibial artery distally. So we accessed the anterior tibial artery from the bottom. We were antegrade from the top. Sometimes when we have trouble crossing a complete occlusion, we just attack it from the bottom and the top, and this is the case. And we ended up stenting across the popliteal artery, essentially to make some lumen against all these chunks of calcium that you can see here. And at the end, we got a pretty decent result. There's a little AV fistula here, but it's excluded by the stent, and usually those don't cause any issues. There were a couple of bleeding spots still from where we were accessing the anterior tibial distally. Those were held with manual compression, and hemostasis is usually relatively easily achieved in that situation. His ABI waveform improved, although his digital pressures were still a little bit down. But he did actually proceed with an amputation of those digits. He had involvement of his second digit while we were trying to do all of this revascularization for him. So he underwent amputation of 2 through 4, did well, but the story continues because you remember his other foot was also flat. While he was on bed rest for the left leg, he develops a right heel ulcer in the same month that we were working on his left leg. So now we're in big trouble. So the right leg similarly has significant occlusive disease in the popliteal segment. You can see here multiple areas that were calcified and occlusive. And then within the tibials, his posterior tibial artery was actually the true culprit in this side. And unfortunately, that's exactly where the angiosome needed to be. So we crossed into the distal popliteal. This is a selective injection into the tibial arteries. And you can see the multiple areas within the posterior tibial artery. We tried to cross the posterior tibial artery. Our wire does not reach all the way. So we ballooned it a little bit. We worked on the SFA pop. Then we went into the anterior tibial artery with the hopes of getting the pedal arch open. But this was essentially as far as we could get with the pedal arch. So the rest of the vessels we were able to balloon and open. But you can see the heel still hurting a little bit. Such a very minimal flow through the posterior tibial artery. So, you know, at this point, I was not 100% hopeful that we were going to be able to heal this heel. And then he steps on it. So as he was going to the bathroom, he fractures his heel. And you can see this huge wound as well associated with the heel ulcer and the osteomyelitis that ensued. So we took him back to the cath lab again, really for a more dedicated revascularization of rebuilding that pedal arch. So we were able to traverse with a very small wire through the pedal arch, and this was as far as our wire got, but it does actually go into the calcaneal area. So we were able to revascularize with very small balloons and rebuild his pedal arch here, as you can see. And after this, he underwent a key. And let me show you. The blood flow did improve, as you can see by the waveforms. The toe brachial index was 0.10 here. And after this, he underwent a keystone and a rotational flap procedure with partial calculolengthectomy. And he actually proceeded to heal relatively nicely. He actually only has a pinhole residual wound right now. I actually just talked to him this past week. He said he's hoping to go back to Vegas in April now that we're all done with both of his legs. So he's actually starting to walk now, and he's recovering really well from all of this. So incredible save along with our colleagues in podiatry. Last case, 55-year-old man with Berger's disease. He had a prior BKA on the left side, has tobacco use, and was referred for evaluation of his second and third toe ulcers. You can see a little bit of ischemic changes in his second and third toe. On exam, he was cool to the touch without a palpable pedal pulse, adequately treated in terms of cardiovascular medications. This is our preceding angiogram. So you can see the inflow actually doesn't look that bad, a little bit of disease in the P2 segment, but truly he has a desert foot. There's nothing happening in this foot at all. So this picture was taken by one of our partners, and then he was subsequently, he attempted revascularization, but was unsuccessful. He was discussed in the Limb Salvage Advisory Council, and we talked about percutaneous deep vein arterialization. So the concept of percutaneous DVA is to connect the artery, which is occluded, as you can see here, to the venous system. So using the venous architecture as the conduit to make it into the artery of the foot. It's a pretty extensive procedure, so we typically reserve this truly for the patients with no option critical limb ischemia. The patients with true desert foot that don't have anything else that we can offer from an endovascular or surgical perspective, short of major amputation. So the way we typically do it is we get arterial access from the top, and then we get venous access from the bottom. This is actually a venogram. You can see some of the valves in the vein here. And typically, if we were to use this system, we have two ultrasounds that essentially, one from either side, that talk to each other. We locate the area where they're closest together. A needle punctures from the arterial side into the venous side, and then we can start ballooning and breaking open some of those venous valves, and then we lay cover stents all across. That's usually the mechanism of how we do the deep vein arterialization using this specific device. However, this device is still undergoing, at this time, was still undergoing investigation as an IDE trial. And given his Berger's disease, he was actually turned down for the trial. So we had to do an off-the-shelf DVA. So using the equipment that we have, there's actually a method that we sometimes use in the arterial system where we are trying to connect two different planes. So what we do is we put a balloon in the venous system. So we have access in the vein. We put a balloon in. We inflate the balloon. And then we take a device from the top that has a needle attached. It's called an outback. The needle then penetrates into the balloon. And essentially, we've accomplished what this system does with ultrasound, but we do it visually. Using a balloon and a needle from the top, we puncture the balloon, and then we put a wire into the balloon itself. And then as we're dragging the balloon back to come out of the body, the wire from the top gets pushed down. And then that way you body flossed a system from the top to the bottom. So we call it facilitated reentry using an outback system. After that, then we can do a valvulotome to break up some of the valves within the venous system. This is a blood pressure cuff that was on to help us get venous access. After the valvulotome, we do a lot of ballooning to break up some of these venous valves, and then we lay the cover stents. Here you can see the cover stent, and there's flow into the venous system. In this specific patient, you can actually see there's a little bit of tributary that is going to shunt blood up. So he ended up getting, in a staged fashion, he ended up getting these coiled so that most of the blood ends up towards the foot. And he did great, actually. Underwent TMA and healed successfully. A lot of patience is needed with deep vein arterialization, specifically because this is a low pressure. This was a low pressure bed, right? So we cannot put tourniquets around it. If you do, the entire lymph flow actually goes down. So oftentimes during these TMAs, we ask that tourniquets not be applied to these patients. Essentially, we have to wait a month before you can do anything. And the wound oftentimes looks worse than before it becomes better. So because we've taken over the vein, there's more swelling. And we have to allow the veins to grow to become arteries. So we usually allow a month for this venous conduit to mature. And during that month of time, we usually have to educate the patients a lot about compliance regarding 1 hour down to develop the veins into arteries, and then 1 hour up with the leg to decompress. So they really have to keep doing that so that we, A, don't overwhelm the venous system, and B, allow it to mature. And the patients are typically kept on anticoagulant along with an antiplatelet therapy. Right now, our regimen is using Xarelto 2.5 twice a day, along with Plavix, for example. Back when we first started doing this, we were using full dose blood thinners like Eliquis full dose, but we've really titrated down to using only rivaroxaban 2.5 along with Plavix. So regardless, it's a very tedious method of revascularization, very selective patient population for this because of the involvement of requiring kind of dangling and elevation, and really a lot of involvement of the podiatrist along with the patient and us. So really selective patient cohort for percutaneous DVA for it to be successful. Just a little bit of data on this. Promise 1 was the very first trial. It was a single arm study looking at 10 patients, and they had an amputation-free survival at 30 days and 30 days as well as 6 months of 100%. Primary PNC was noted to be 90% at 1 month, and then down to 40% at 6 months. Interestingly enough, and more and more research is going to go into this, but even when the graph goes down, most of the time, these patients actually remain fine. They don't have a re-breakdown, essentially. What we think is that the vessels themselves actually get primed as a result of the revascularization, and they actually end up doing well even after the graft closes down. So there's actually little tiny collaterals that they start building on their own that allow them to stay patent or wound-free despite the graft closing down. Promise 2, again, was the IDE trial, was recently just finished. So the manuscript is being placed together. But they had 99% immediate procedural success. This was performed in 105 patients, multi-center trial. The limb salvage rate was 76% with an amputation-free survival rate of 66% at 6 months. When the investigators dug a little bit deeper into this, the patients that were non-hemodialysis patients had a higher amputation-free survival rate of 75%. So the patients that were dialysis patients actually had a lower amputation-free survival rate. And Dr. Mehdi Shishabor is one of the national PIs for this trial. Promise 3 is upcoming. We're actually starting the IRB process for Promise 3 in our own institution as well. So we will be studying this more and more to really select the type of patient who is appropriate for percutaneous DVA so that we can offer some alternative therapy for the truly no option CLI patients. So just to touch a little bit on the Limb Salvage Advisory Council to finish up the presentation, in your university hospitals, we actually conceptualized the LSAC in 2019. It's a real-time multidisciplinary team approach with vascular surgery, with endovascular practitioners, podiatry, vascular medicine. And we really discuss patients who are referred for probably amputation, and we want to really stop that. So we're injecting the LSAC right before the amputation occurs to try to see if there's a way that we can salvage the limb to prevent a BKA. As we know, there's There's quality of life issues with BKA, and sometimes morbidity also increases with BKA or AKA. So we're trying to prevent that from happening for patient quality of life improvement as well as outcomes overall. So what we found when we looked at our data in 2019 is that we had 19 patients that were discussed. 3 were deemed truly to be non-salvageable. 1 underwent an unsuccessful revascularization, but 15 of them underwent successful revascularization. And of those, 9 limbs were saved with survival at up to 6 months. I don't have more recent data on this, but this was very positive from our regard. Of 19 patients, almost half of them had still their legs up to 6 months and were surviving. So we're very passionate, as you can see in the last 2 hours, about limb salvage at UH. And this is a graph from a couple of years ago, but it really shows that our major amputation rate has tremendously decreased despite the rise in CLTI. And interestingly enough, and this may be reflective of COVID, just because patients are probably not coming out to see us as often. The rates of claudication is actually decreasing, but the rates of CLTI is increasing in our system. But the positive sign is that the major amputation rate overall is decreasing as well. So CLTI truly takes a village. I love showing this slide. Really, it's not just about us. It's about you guys. It's about partnership. It's about multidisciplinary care. It's about the patient investment in themselves and their lives as well. Really to make a difference in their outcomes. Thank you.
That's a great talk. Yeah. We only have a couple minutes left, but during your talk that the interventions, arterial interventions below the ankle are kind of a new frontier. And I was just wondering if you could maybe quickly comment, like in the desert foot, how do you decide if you're going to do like a deep venous arterialization that you showed, or if this is like a pedal loop revascularization type of case?
That's a good question. We always try the pedal loop first. And we really anticipate needing a pedal loop, especially if the patient's going for a planned TMA. Because deep vein arterialization takes so much investment from the patient to heal, sometimes they get frustrated waiting that 1 month because there's just so much that they have to do. So we usually try the native artery first, always. And sometimes we try it even a couple of times before we refer the patient for deep vein arterialization. I think DVA is exciting, but it really has to be a very selective cohort of patients that are referred to it.
I think we have Charles Burke here with the mic.
Go ahead, Charles. Dr. Burke.
Did that work? Or maybe not. Oh, here we go. With Rich. Someone asked for the mic, so I gave it to them.
Oh, you did? Yeah. They have to accept it when you give it to them. I mean, that's fine. It doesn't typically, when they grab it, they think they're just going to jump up on the stage. But I just want to say another spectacular session. Really, really great. You guys are the best. I'm getting text messages that they want more events with you guys. So there's obviously a lot that you bring to the table, and I truly appreciate everything that I'll bring Burke up. Everything that you contribute to podiatry and your support of the no nonsense, just everything very, very, very positive. So I don't know, he's not able to do it. Plus the time we've come to a close anyway. Dr. Earhart is in the other room. I just want to once again say thank you so much. Appreciate all of you. Mehdi and Yolanda were amazing. You guys are obviously spectacular, which and I just really, really am grateful, very grateful. And I know the audience is as well. So thank you so much.
Thank you,
Thanks,
Rich.
everyone.
Thanks,
Thanks.
everyone.
All right, take care.
Take care. Bye.
Have a good one. Bye.
Or,
Sure.
uh,
Lower left-hand corner,
yeah.
the monitor. Yep. Okay.
Oh, okay. I see.
Go to window. Click the screen.
There we go.
Beautiful.
You see them all?
Yep, you're good to go.
You still see me? I haven't been on the this conference here at
Yeah.
all yet.
We'll see you and then your PowerPoint.
Okay.
So just rock and roll. Take it away.
All right. Very good. Well, thank you for having me here. I apologize. My voice a little raspy this morning. Last week I was down in Dallas doing some training with my Navy buddies and doing a lot of yelling and whatnot, and so my voice is a little rough. But I'm going to talk to you guys about endoscopic calcaneoplasty here. Kind of what it is, why we'd want to use it, and how to actually utilize it. I have no disclosures whatsoever. Period. This particular talk, anyway. There's absolutely no implants, no companies, no nothing. So what I'll tell you is the unbiased truth of the matter. So as I mentioned, right, what are the goals of this particular topic? How do we figure out how to do it, right? Why would you even want to consider doing something like this? And I'll share with you my experiences that I've had over the last 10 years or so. So if you look, right, if you go to PubMed and look up endoscopic calcaneoplasty, what you're going to notice first and foremost is that this is fairly new, right? As the last 10 years or so have gone on, there has been an increased interest in this particular topic, but it's a relatively new technique. Ironically, despite us being, in my opinion, the experts in foot and ankle surgery, there has not been a single podiatrist to publish on this particular technique. I noticed this a few years ago. I knew that I had some cases under my belt to review, and me and a couple colleagues took a look at this. And so I'll share with you my data and my experiences later on in the talk. But what I'll tell you right off the bat is it is safe and it is effective to do in the right patient. Okay. So the goals, right? So what are we treating first and foremost, right? It's really the Haglund's triad, but primarily Haglund's deformity, right? Which we all know is truly the Haglund syndrome, which is a triad of issues centered around insertional tendinopathy, retrocalcaneal exostosis, and retrocalcaneal bursitis. Now, this is it's endoscopic, right? Well, arthroscopic, endoscopic, whatever you want to call it. With all those techniques, right, there are limitations, right? And what I'll tell you first and foremost is that the endoscopic calcaneoplasty is not a panacea for all Haglund's deformity cases, okay? I do not do this on every single case. In fact, the vast majority of them I do still open because they're fairly severe. And I'll try and educate you here today on the right patients, how to pick the right patients for this. But I still love doing them open. There's plenty of reasons why to do them open, and there's a lot of different techniques. People have various incisional approaches and lots of very efficient and fast techniques in an open fashion. And I'm not telling you to abandon those whatsoever. I'm just here to let you know about a different approach. I still like to do them open. If I see significant tendinopathy specifically, and I'll explain why here later on, greater than 50% tendinopathy of the Achilles tendon, I'm transferring the FHL. I like to do this open. There are some people that do this in an endoscopic fashion. I haven't found that to be very efficient yet, and people do very well. It's a very well documented procedure. And of course, when you open them, there's plenty of fixation methods that you can utilize. I think probably one of the most impressive aspects of doing a Haglund's open is how well you can make it look on the X-ray. I know obviously we treat patients, not X-rays, but we're all surgeons, which kind of makes us artists, and we like to look at nice, smooth surfaces when we're done with everything. And as you will see, when you do this in an endoscopic fashion, it's not, it's very hard to make it look nice and smooth. So this is a benefit of the open, right? So how do scopes fit, right? How do you utilize this in both figuratively and literally? I mean, how does a scope fit in treating tendon problems, particularly of the Achilles tendon? Well, first and foremost, you can't scope a tendon. I know there are people that do tendoscopies and things like that, but you can't put a camera inside a tendon, at least not yet. What we're targeting is the retrocalcaneal space, right? So the area just in front of the Achilles tendon, the Haglund's prominence itself, the osseous prominence, and the bursitis. So right off the bat, endoscopic calcaneoplasty in and of itself is not designed to treat Achilles tendinopathy. Okay, the indications are retrocalcaneal cystosis and possibly bursitis. I'll show you how I try and stretch the indications a little bit, utilizing gastrocnemius recession in combination with this. But this is by and large for fairly moderate deformities, right? Which are primarily osseous in structure. So, I think another thing people think about is, well, why would anybody even consider doing this off the get-go? Well, I'm a younger guy. I'm a video gaming guy, and that's what I grew up doing. And so having a scope in my hand and a camera and tools is kind of something natural that comes to me. It can really happen for anyone. I mean, obviously, it may take a little effort if you are someone who didn't grow up doing those kinds of things. It may take a little bit more effort to do, but there's no doubt about it. There's a need for minimally invasive procedure. I mean, we see this all over, foot and ankle surgery nowadays. And for a lot of obvious reasons, right? I've done pretty much every, open procedure, incisional approaches, closure techniques, all that. And there still are cases of, even in best case scenarios, right, of hypertrophic scars, right? Or you take this individual here, right? Many reasons why this would give you a heart attack, right? Post-operatively, right? So you can obviously appreciate here in this particular case, right? She had wound problems and scarring and issues and whatnot. With Achilles incisions, there's a lot of complications, right? It just a fact of doing the surgery back there. It's a fact of the angiosomes. It's a fact of just the blood flow period in folks. Again, lots of atrophy that can occur from being off it for a prolonged period of time. We know that there's a slight increase in DVT risk with open Achilles procedures and all those issues, right? Which bring, surgeons to kind of a crossroads really with everything we do. But in this particular case, thinking about, when should I make that switch? When should I consider techniques that may allow me to provide my patients with something a little bit better, right? And this is the classic split of any procedure, open versus, minimally invasive or endoscopic, is that obviously the open cases are pretty well documented. We know what we're going to get with the newer techniques. We don't necessarily know, and so it makes people, a little hesitant to want to do them, rightfully so. Of course, there's always the theoretical benefit of saving time, right? And we all want to save time in the office and in the OR. What I'll tell you is that that's a theoretical, thing. When you first start doing these, just like an MIS bunion, right? You can do a chevron pretty quickly. You do a MIS case, and the first few may take you a little longer than you're used to because you're not used to how to do it. This is exactly the same way, right? So sure, you save time on the closure, but until you kind of get through that learning curve, it may actually take you about the same time or maybe even a little bit more time. Certainly, though, there can be less complications, smaller incisions, smaller complications, and potentially the decreased risk of blood clots and other issues that people get, right? And again, it's a natural progression. It doesn't matter where the surgery is. People are starting to do things in a much minimally invasive way. And right now, we see this all through foot and ankle surgery. And it is certainly true in Haglund's procedures as well. So where does this idea come from, right? This idea did not come from me. It did not come from anybody in the United States, as a matter of fact. It came from folks in Europe, right? And so this is the first published paper known on this particular topic. If you see the name Van Dyck, that's kind of the top expert globally in this particular topic, and really in arthroscopy, period. And he's got many publications on this. And actually, if you look closely, it's a lot of the same data that's being stretched out, which is a good thing. But anyway, they first did this back in 95 and collected cases up, for about 6 years or so, and noted, good to excellent results in their patient population. Right. This is the first picture that we have and what this technique looks like. As time went on, they did more cases, noted, some technical refinements, as well as they specifically noted that their cases weren't as successful when they started chasing legitimate bone spurs, right? So legitimate enthesopathy. They had good scores whenever they targeted specifically the bursitis and the Haglund's prominence, but as they tried to attack insertional tendinopathy, it wasn't as successful. And obviously, mid-substance tendinopathy wasn't going to be successful either. So they also looked at radiographic parameters. So as people had increased Fowler-Phillip angles, they were more successful in their procedure, right? Because this is indicative of a true Haglund's prominence, which you can see here. Here's a case of theirs where they were really chasing insertional enthesopathy, right, and tendinopathy. They had a suboptimal result and required later formal open repair and implant fixation. Again, more evidence here. A lot of the same authors, as I mentioned. Again, you'll see fairly good outcome scores for these folks. Here's another. This is an interesting case, or an interesting French study, I should say, where they actually did the procedure specifically for tendinopathy, right, to see could it actually provide some benefit. They noted. Again, their Dutch colleagues had these results, so they actually wanted to look at specifically insertional tendinopathy. And when you look at the comparative data here, it can be of benefit, right? So there are some patients who actually do benefit doing this endoscopically for insertional tendinopathy, but it's about a coin toss, right? I mean, I don't know. I kind of strive for good or better results, at least 20% of these patients had to return for a second procedure. So it's something to be considered, right? So there is some possibility that can help, but maybe adjunctive procedures may be done in association with it, or otherwise you'll need revisional open surgery. So I already talked about that. How about specifically on athletes, right? So this here's a Turkish study. Now, they look specifically at athletic population. They had 30 cases of Haglund's disease. I think these were soccer players. And they have very, very good, obviously it's a highly, competitive and driven cohort, but very high AOFS scores. But I think what's most important that we gather from this data is that they were able to return to sport within 12 weeks, right? When we do Haglund's cases, the vast majority of them are not athletes necessarily, but we think about them getting back to work, right? And if you're a professional athlete, and your job is to play your sport, that's 12-week return to work. Not too bad, especially for somebody that's highly functional. So I'm not sure why this is coming up twice for everything, but anyway, again, just more data. Again, Van Dyck, another good study, 5-year follow-up. Very high response, or very high outcome scores. However, something to note of this particular study is a lower than ideal response rate. That, we don't know what those patients did. Maybe they ended up somewhere else and with open procedures, but still. Very good data to follow up with. Here's the only known comparative study, which is important, right? To look to see, open versus endoscopic. Is there any benefits or downfalls one way or the other? And what was noted here was that there was a significant difference in their postoperative score, right? In the return to daily activities. In the open group, upwards of 16, 17 weeks return to surgery. Whereas in the endoscopic cohort, they had an average around 5 weeks return to surgery, or 5 weeks return to work. We had in my particular cohort of patients, I think it was around 7 weeks return to work. Again, it does depend on what they do for a living, but certainly there's something to be said about getting people back and getting them more productive once again. Return to sport, again, significantly quicker for the endoscopic cohort. And again, in our case, these not athletes or anything, but folks that just regular working folks, and return to work on average about 7 weeks or so. I think one thing that people do consider is, well, what is the strength of the Achilles tendon afterwards, right? So, you're not using implants necessarily. Now, there are companies that are coming out with some endoscopic fixation devices and things for this particular product, and we'll see what that data looks like. But you're just leaving the Achilles tendon alone. The studies clearly show that it's actually still stronger, right? So the native insertion of the Achilles tendon is much stronger than any commercially available, reattachment device or suture, tape, whatever you want to call it. The native attachment is still stronger. And it's important to note, you're not detaching it when you're doing it endoscopically, right? You're actually keeping it intact as it wraps around the heel and turns into the plantar fascia. It's still intact. You're not detaching it. And so it is much stronger, and you don't have to worry necessarily about that. And again, I got people walking, off the operating room table essentially, and they're completely fine. Complications, or at least documented complications of doing this, very low complication rate outside of any possible wound issue or whatever like that, which I'll share my experience with. Significant injuries, tibial nerve injury. I'm not sure how you would do this. You'd have to really not know your anatomy. You're extremely superficial in the retrocalcaneal space. To be this deep doesn't make a lot of sense to me, but I guess it's possible. And same, right? So FHL tendon rupture, I guess it's possible, but you'd have to significantly, severely have a lack of anatomical knowledge to do such a thing. At least I would think. So, in my opinion, there's not a whole lot of bridges to be burned when doing this. I guess short of perhaps the wrong patient, lack of efficacy by trying to stretch the indications. And for me, this is analogous to like the cheilectomy. Doing a cheilectomy for hallux rigidus. You don't, quote unquote, don't burn any bridges. You can still fuse it later or whatever. It's kind of the same thing. If you have the right patient, you can do this and feel confident that you're not really causing a lot of problems. There's no implant or scar tissue or anything you got to deal with in the event that you have to go back in for a second approach. So how do we do it, right? First and foremost, I like to position the patient prone. I like to have their operative extremity elevated, right? So using bone foam or towels or whatever it is you want to do, tuck the other leg in. And have the ankle or the foot dangling off the edge of the bed, right? So it's very critical to have the patient elevated here because obviously we do still take X-ray. I use mini C-arm for this, and it's important to be able to visualize and have a good lateral for your resection. Here's what it looked like from the top down. I usually try to map out. Again, I personally do gastroc recessions on almost every patient. So we map that out, do your technique of of choice. Me personally, I like to do it in a kind of an MIS fashion, using a speculum, either a pediatric vaginal speculum or, and actually what I use now is a nasal speculum. But the reason why I do this is that there is some predicate, right, for the use of gastroc recession for insertional Achilles tendinopathy, right? There may be some benefit to it. I know it's somewhat controversial, but I think that it does provide us some benefit, and there's, and again, in my opinion, very little risk in doing it. And the technique I like to use is Greenhagen and colleagues' published technique. I think this is very slick. Again, using a speculum, you can do this fairly MIS fashion, without the need of any expensive equipment, and you can protect the neurovascular structures and everything back there quite well. As you can see here, you can actually visualize the gastrocnemius aponeurosis. Now, I actually tend to do this a little different than Greenhagen and colleagues. I find the peritoneum, and I get my speculum under the peritoneum, and I cut down towards the muscle belly. They actually do it the other way around and try to separate the gastrocnemius aponeurosis from the soleal component. I do kind of more of a standard open strayer procedure and really cut both and stay away from the neurovascular bundle. But anyway, it's not a very large incision, and you can get the entire aponeurosis resected quite well. Now you might be thinking, why don't you do it endoscopically? I mean, you got the scope there. You can do it even using endoscopic equipment and whatnot. And what I found when I've done these is, first off, I don't get the greatest visualization, and it doesn't really provide me that much smaller of an incision than it does when I use a nasal speculum. Just me personally. Additionally, these things are really expensive. As a matter of fact, I actually saw, for whatever reason, there was a price on this particular model, and it was $1,200. Like, I'm not, gonna have the hospital waste $1,200 on this simple little procedure when I can do it, with some cheap instrumentation and a 15 blade on a long handle. So that's just not for me. You can do it if you like it, but it's just not for me. All right, so we've done our gastrocnemius recession. What's the next step? Patient's prone. They've done our gastroc recession. Now we need to set our level of resection, right? And I got this idea from these colleagues. All right, what they do is they use basically a K-wire, 6-2 K-wire, right, under fluoroscopy, and you set your level of resection, right, under X-ray right off the get-go, right? And this is how you do it, right? You have just standard lateral X-ray, and I like to do it live, and just set my level of resection, put the pin straight midline with the Achilles tendon, and just breach the dorsal cortex of the calcaneus. You can do two if you wish. It's hard to get them parallel, so I tend to just do one nowadays, but this is what you want it to look like, right? You want to be able to see this, so you don't have to take a bunch of X-ray during your procedure, because remember, you're doing this endoscopically. You don't necessarily know how much bone you're taking. Having a guide wire in there for you really helps speed the process up, and certainly is less X-ray exposure for everybody. How do you make your portals, right? What's the anatomy for the portals? I'll tell you, there's a lot of techniques that are published. There's folks who use some complicated trigonometry depending on the calcaneal inclination angle and everything like that. For me, that's too complicated. The last thing I want to do necessarily is math in the OR. So what I do is I just find that little sulcus where the Achilles tendon is just, you can kind of pinch it, right? There's a pinch point back there. And I take a K-wire and, 6-2 K-wire, whatever size you got, and I want to run it across just in front of the Achilles tendon, and I want to feel just it graze the bone, not in the bone, not in the tendon, but just graze the bone. And if I can pass that perfectly straight across, I found that this is the ideal spot for the portals. And this is actually important because if you're a little too distal, you can't fit anything in. And if you're a little too proximal, it's actually kind of far away from where you want to be, and you got to make accessory portals. And at that point, then you're just making a bunch of poke holes. So this seems to be the ideal location. I like to dilate it, right? So scope that I use is a 2.7 30-degree scope. short arm, and I, just, standard arthroscopy technique here. I'm going to use an obturator to just kind of clear out that area so I can easily get my equipment in. One note to make, this incision needs to be very, very small. I like a 15 blade, and I'm not a big on using 11 blades. I just don't like them, but I use 15 blade and just barely poke through the skin with this, because you need the camera to have an airtight seal around, or the skin to have an airtight seal around the camera, because if you don't, you're going to get a lot of bubbles in that get in your view, and you won't be able to see much of anything. It is of note that some people do this supine, and it can be done. My colleague, Dr. Rosante, who was on the paper with me, likes to do it supine. Obviously, that saves some hassle in the OR, and it may be better for larger individuals, various body habitus individuals or whatever. They can't be prone for whatever reason, so it can be done. I just don't like that. Anytime I can just keep myself looking straight ahead, I try to do that, but it certainly is a potential option. Back to this particular case here. Again, it doesn't really matter which side your camera is on, medial or lateral. I like to have my camera in my left hand when I start with anything. That's not in an ankle, right? Obviously, it depends on the side, because you're going to probably start with the anterior medial portal. But in the Haglund space, it doesn't really matter. So I always have my camera in my left hand. Why do I do that? Because it takes me back to my video gaming roots. Like, I'm used to controlling the point of view with my left hand. But certainly you can start with your right hand or whatever. It doesn't matter. Once we get the camera in, you're going to immediately start off with some sort of dissector. I like a 3.5 or 3.0 full radius aggressive dissector. And you get in the camera, you get that in place, and it's going to be just like an ankle scope. Like when you have a pretty synovitic ankle, it's kind of hard to see at first because there's a lot of debris and disease in your way. In a diseased retrocalcaneal space, right, there's going to be bursitis and inflammation, and you need to clear that out. And so I use, again, a full radius dissector on suction that you can toggle with my thumb on and off. And I just clear that debris away so I can get visualization. And I'm going to clear it all away until I can see that wire again, right? So here is the little tip of the K-wire that I put in. That's my most superior aspect of my level of resection. That's where I don't need to go any deeper than that, right? And that prevents me from getting into the neurovascular bundle or the FHL tendon or whatever. I keep my instrumentation there. I know that I'm not going to necessarily have any issues going deeper than that. So here's an example. I mentioned keeping your scope portals very small and tight against the instrumentation. Here, we made it probably a little bit too big. And what happens with that is air bubbles are going to get sucked in, right, into your space, and it's going to make it hard to visualize. And actually, as you can see here, pretty much turn the fluid off. This is basically a dry scope just so we can see what we're doing, which isn't ideal because we're eventually going to be debriding bone, and bone chips and things are going to be flying all over the place. And it's better if you have fluid actively flushing that out and not just leaving it behind. Additionally, again, anytime you're scoping things, you can get little pieces of metal or whatever that could potentially happen. And if you got some fluid flowing, it's going to help flush that stuff out of there. So that's an example of a bad entry. Here's an example of a good entry, right? We got plenty of fluid flowing, crystal clear visualization, and all we're doing is using our dissector to clear away the debris. You can put this against the Achilles tendon, by the way. People get concerned about causing damage to that. It's fine, probably needs a little debridement anyway, and I routinely do debride it with the dissector only, and very gently, right, with the use of suction. The only thing you need to worry about with the Achilles really is when you start using the burr, right? When you start burring bone down, because that will tear the Achilles up and obviously, could cause you to have to open and repair it. One thing I should mention here, which I haven't mentioned yet, is the fluid that I use. I like normal saline. You can use lactated ringers or whatever, but the amount of pressure that I use is very low. In the ankle, I like to use 30 millimeters of mercury, to distend the ankle and get good visualization. I don't really want a lot of fluid back here flowing into that posterior crural space because this is not a joint. This is just a space, right? And you can get a lot of extravasization of fluids into the soft tissues, theoretically a compartment syndrome or something like that. So I keep the pressures very low. I still like controlling it with a mechanical pump, and I keep it at 15 millimeters of mercury. You can hang it to gravity if that's your, thing. I don't love doing that because I just feel like I can't really control it as well. So I keep mine on a mechanical pump at 15 millimeters of mercury. Anyway, once you have the soft tissues debris away, you can certainly use a cool cut or arthro wand or something too to just kind of fine tune everything and get some hemostasis if you have any of those issues. And there's no issue with that back there. And this is what you want to see, right? So what we have here on the left is the posterior aspect, the calcaneus, and then to the right here's these bands of collagen. That's the Achilles tendon and the insertion. You want to clear that all the way out as much as you can. So you have plenty of space to get a good resection, and really you should be able to fit, something back there, right? Like a probe or whatever you got to be able to get your instrumentation between the two. All right, so now we're cleared out. We're ready to go. Now's the time to burr. I like to use either a 4-0 or 5-0 burr if I can, full radius burr, aggressive. Now, this needs to have a protective sheath on it, right? Because again, you can definitely tear up the Achilles tendon, so you're going to want to make sure that you use something with a sheath on it to protect that. I start up top. I find that wire, right, and I start superficially and work deep towards the wire. Now you got to be careful because this will tear through the wire too if you're not careful with it. Once I see the wire underneath, even just a little bit, even if there's like a little sliver of bone, I'm stopping, right? I'm not going any further. And then I'm going to go a little distal and trying to work superficial to deep in that fashion. So it's kind of like I'm taking layers of an onion off as I work my way down. I found this to be better. Instead of following the wire, I used, when you first start doing this, I just kind of followed the wire because it made me feel comfortable. And if you do that, it kind of creates a cavernous type effect, and it's hard to get that totally smoothed off, and then you end up kind of cutting corners and leaving it, and it just doesn't look great, and I don't like doing that, so don't do that. Another thing that I found beneficial, and this is something that has yet to be published to my knowledge, is using a power rasp. Say you get to a stage like this, or you just don't feel comfortable with the burr as you get closer to the insertion. Use a power rasp. You can use an arthroscopic rasp if you wish, or just a standard reciprocal bell rasp actually works very well. You do need to be careful again with this. Again, little metallic shards and things can still happen if you're hitting the wire. So be very, very careful with that. But I found that this makes a much smoother resection. It's not going to necessarily cut through the wire. At least it's a little bit more forgiving, and it's certainly not going to cut through the Achilles tendon. And at this point, really, it's not even arthroscopic anymore. It's almost just MIS, with the use of fluoroscopy, take a couple shots to see where I'm at. Once I'm at this stage too, I usually take my wire out because I know that I've resected enough. I'm just kind of fine tuning, and I can make it look a little better on the x-ray. And this is kind of, what makes the x-ray look a little bit better. It's still not great, right? I mean, it's not what it looks like when it's open. It kind of looks like maybe a mouse chewed on it back there or something like that. But it is very effective, and it tends to do better than trying to just use the burr. When you just use the burr, it's just really hard to get a nice, perfect resection. And so I like to use that rasp and rasp things down as the final touch, right? Then we flush things out, simple closure, and we move on to post-op. So if you want to put them in a splint or whatever, you certainly can. And I've done that in certain patients, but they can walk on this really almost right away, right? So you get them in a cam boot with crutch assist for 7 to 10 days. This obviously, as long as they're in a cam boot, they're not going to have any issues with, rupturing the Achilles. Again, we did the gastroc recession anyway, so it's a little weakened. And so, it's very safe to do. In about 2 weeks, they should be 100% weight bearing. Most people just gradually get to that point. And then we start doing physical therapy, right? Formal physical therapy for 6 to 8 weeks. I like aqua therapy. People just like doing it. It's very good. Takes off the ground reactive forces and lowers the G forces and everything. And later on down in the road, you can do eccentric loading training too, if you wish. Return to work obviously depends on the patient's job. If they work behind a desk, they're back to work on Monday. Obviously, if they're driving or whatever, you got to worry about the cam boots. That's something to be said. But what I've noticed is people get back to work in about 7 weeks on average. Return to sport, depends on the sport. You've seen anywhere in the literature is between 6 to 12 weeks, and it's certainly something that can be safely accomplished. From a billing and coding perspective, this is how there's no code for this to my knowledge. I'm not necessarily a coding expert. But these are the ones that work for me. Obviously, you're still going to make use of your cam boot. Night splint, another thing to consider post-operatively. They don't, once they're in the boot and you've changed the surgical dressing at a week or whenever, they don't need to be in the boot in bed, but it is still nice to keep things stretched out with your gastroc recession. So use a night splint for that. I've never tried the unlisted arthroscopy code or tried to fight for that, but it's certainly something that you could do. Now, in my particular patient cohort, and I added this mostly because I know this is an hour-long lecture, and it usually doesn't take me that long, but just to go into some of my data, I looked at 19 patients, 14 were ultimately included in our review. And basically what I looked at was patients who had endoscopic calcaneoplasty, what their pain, their outcome measures were before and after surgery, and how quick they return to work. That's basically what I want to know. And complications, right? What kind of complications will we have? And so, pretty standard statistics here. Here was the raw data from the study. And the big thing to note right off the bat is the AOFS scores before and after surgery were markedly improved. So it is effective, right? Average age of patients, 52, mostly females. This is pretty consistent with Haglund's demographics, and some smokers and diabetics, and a little on the heavier side. Again, all to be expected. But again, big thing, the big change post-operatively in the outcomes measures, right, which is good, right? It shows it is effective. But then also I looked at X-rays, right? So Philip Fowler angle was markedly improved. Interestingly to note, though, it wasn't, abnormally high on average for our patients. So I did have some patients with insertional tendinopathy, is what I'm trying to say. But the range was 50 to 85. So there were certainly some with significantly higher Fowler filler angles. But anyway, it clearly resects it in an appropriate fashion and works. Again, average return to work, 7.5 weeks. There was, so the range you see there's pretty significant. There was one patient who had, significant issue. She said she had a blood clot is what she had. She had a DVT and, wound healing problems and sural nerve paresthesia, which resolved. But that outside that one patient, which skewed the data quite a bit, people do very well. So to my knowledge, it's the first midterm study looking at the outcomes of endoscopic calcaneoplasty paired with a gastric recession. And it was safe and effective. Here's a case presentation to wrap things up. So it's, pretty standard patient for this, middle-aged woman, has chief complaint, 8 out of 10 pain in the back of the right heel, has done conservative therapies and stretching and Epsom salt soaks, tapings, PT, all that kind of stuff. The big thing with her, it was that she had a traumatic left forearm amputation from a motorcycle accident. So she was really worried. She's actually been putting this off because she's seen a number of people. They've all said, "Oh, you're going to be in crutches and all this and that," and it's very hard for her to be on crutches. So she was curious about options for immediate weight bearing. Here's her preoperative X-ray. Slightly elevated Haglund's fallow Phillip angle. Here's the ideal resection line for that. I like to get MRIs for my patients and for all of these. And the reason why is I want to see how much tendinosis there is in the tendon itself, right? So she's got a little bit, right? And most people do. But if it's greater than 50% of the girth of the tendon, I start getting a little concerned that doing it open is not going to help, because you got to debride the tendon, right? You got to get rid of that diseased tendinopathy and possibly do an FHL tendon transfer. In her case, she had a little bit, it was definitely on a mild side, but clearly there was some inflammation at the insertion in the Haglund's prominence itself. So the surgical technique, we've already mentioned, right? Prone position, elevated. I like to do the gastroc recession with a speculum. This here is a pediatric vaginal speculum. I've been using recently nasal speculum, which works just as well. And again, post-operatively, nice small incisions and everything. That's what she looked like. But anyway, we've already been through this, so I like to set my level of resection with a K-wire. Again, this is kind of predetermined preoperatively, but, you're able to set that line the way you want it, with laparoscopy. So, again, I've mentioned this already, but going through using a 2.7 scope, 30-degree angle. I like to use normal saline on 50 millimeters of mercury on an active pump and a full radius dissector and to clear out the soft tissue, and a 4.0 or 5.0 full an aggressive burr with a sheath, right, and a protective cover to resect the actual Haglund's prominence. Again, fine tuning. If you want to make it look better, use a power rasp. It'll definitely look better, and it'll also put your mind at ease that you're not going to blow through the Achilles or blow through the wire. And this can just be done at the very end of the case. You just kind of smooth things up like we normally do. At this point, like I mentioned, it's basically just you're just eyeballing it, right? Using the X-ray, just feeling back there. We do this type of technique with all of our other procedures, or lots of other procedures, so it's nothing that's new to anybody. Here's a before and after. One thing to note, right? You do want to try and flush out the bone and everything afterwards, right? And I don't have any formal data on this quite yet. I've not noticed any residual bone growth or anything of that sort. I like to use Toradol here. OR, anesthesiologists always ask, can we use Toradol and everything? I'm definitely okay with that here. I think it may help reduce some of the possibility of heterotopic bone formation or something like that. But at least out of the majority of my patients, I haven't seen any significant re-spurring or anything of that sort. Here's the same lady 2 years post-op. She does some, scarification or calcification here, but it's nothing that's, prominent. It's nothing that is palpable. And I think it's just from, that residual periosteum back there, just like you would see like with MIS bunions and stuff. It's just, there's no, movement of bone back there. So it does work. Again, before and after, a lot smaller incisions, and can be very effective, right? So to wrap things up, I have noticed that doing this in combination with gastrocnemius recession provides significant improvements. Early weight bearing can be safely achieved, and it is effective as well. So appreciate it. I'm not sure what we do at this point. I think there's about 15 minutes left or so. And what do I?
Back on. Stop screen sharing.
Okay.
Just stop screen. Perfect. Awesome. Great job, Dr. Eric. Appreciate it. So we'll get right into some questions here. Dr. Holt asked.
How do I, if I click on comments here?
Yeah, can you see him over there?
Okay. Yeah. Let me see this here.
Where
do I, is this all just my room? Oh, okay. All right. Do I just start at the top or? The first question is what orthotic modification should be considered before performing this? I mean, the standard, I would consider again, heel lifts, right? Of course, with these patients. I can't think of anything much different outside of that. I don't know if anybody else has any recommendations. You know,
Any accommodative orthotics or anything of that nature? It's got to be something a little bit soft, right? Or no?
well, not necessarily back. I mean, a lot of these folks, again, if they possibly, right? So a lot of these folks have a higher calcaneal inclination angle, right? And so they have a cavus foot type, if you will. Accommodative insoles are definitely helpful in that regard. But if they have insertional, the Haglund's triad, which is usually some level of insertional tendinopathy, I think some level of heel lift is probably helpful.
Okay. Can you see the questions, or you want me to read them to you?
Yeah. When was the last time I got a $1,200 bonus from the hospital? Never. However, so that's an interesting point, right? Right. The good question. The question brings up, why do you care about the hospital? Well, at the time of that particular picture taken, I was at St. Vincent Charity Medical Center, and as if you live around here, I guess the majority of people live around here. It closed, right? And it sucks. Trust me, the last 4 or 5 months have been really miserable. I cared deeply about that place, and so they paid me well. And it was a great place for our students to go. So I'm a school guy, right? I work here at Kent State, and here in Cleveland, we've lost really 2 podiatry-friendly hospitals, and they were definitely one of them. So I tried my best to do what I could to save them. So because I knew somebody was counting the beans, and then it would give us that opportunity. But yeah, it's a good point. Now I'm at the doing cases here and there, Cleveland Clinic or UH or whatever. If I worked for them, I certainly would care. But we'll see. That's a good point, though. Would I use 10X in conjunction? You can. I'm not a huge fan of 10X. I don't have a lot of experience with it. I just, I think if I'm going to do that, I'm probably going to open it up anyway and debride it. But you certainly could. I don't have any experience doing it with this particular procedure. One thing that you can do, and I do sometimes, right? So when somebody has legit insertional tendinopathy, I'll kind of do a cheap 10X. And going back to the St. Vincent thing, I'll poke the Achilles tendon with an 18 gauge needle, and I'll inject PRP and that kind of thing there. So it's kind of like the same thing as a 10X. So I think it's a good idea. Okay, we got a couple. Let's see here. James Flood, curious to know if I have experience with EPAT to region of tendinosis, watershed region of Achilles. Yeah, so if somebody has tendinosis of the mid substance, you're not really doing a Haglund's, it's not really a Haglund's problem necessarily. It's mid substance tendinopathy. I'll tell you what I've done for those folks. I actually have a nice little series of them. I don't necessarily transfer the FHL tendon. What I've been doing is a little mini open repair, debriding that diseased tissue, and then doing a PARS, right? Percutaneous Achilles repair. It's an arthrex thing, but doing a PARS or some sort of MIS Achilles repair and basically bracing it. And it worked really well, at least anecdotally. How do you remove the calcifications of the Achilles tendon? You don't. As I mentioned, it's hard, or it's very hard to do that, right? If you got significant tendinopathy, you got to open it up. That's the limitation. Like I said, this is not for every single Haglund's patient, right? You got to find the right patient.
Yep. Scroll down.
Yep. Go Navy. It's always good. Clear. Thank you. Let's see here. Flat rear post on orthotic with no motion can be used. Okay, that's noted. Not sure. I'm not. Shamefully, right? Us youngsters, we get sent out there and we're told we're surgeons and we forget some of these things. I'm not familiar with what a flat rear post is necessarily. But I agree. Certainly, there can be things that can be of benefit with orthotic modification. Lower top lacing. Yeah, that's a great point, right? Especially in our runners and stuff. To be quite honest, right, the majority of our athletes, it's not necessarily surgery that they need. They need some sort of small adjustment. And in this case, the recommendation for keep the not to lock in the heel. Yeah, I mean, that's a good point, right? Little teeny things that make a big difference sometimes. What else? Thank you for your service.
Yeah.
Go Navy.
Do we have any? Here we go. Have used this procedure in the fairly small bump pump that just rubs from the back counter to the shoes in the female patient.
Yes, it just depending on whether or not it's that bump is from an enthesopathy or not, but it certainly can be done.
Yeah.
I'm looking mostly at the lateral X-ray and an MRI. That's what's determining what direction I want to go. I look at that lateral X-ray. If there is little to no Achilles spurring, and the MRI is showing less than 50% of tendinosis, I'm probably going to do it endoscopically. Doesn't matter if male, female, what shoes they wear, or whatever. Equine brace, yes. I agree 100%. As I mentioned, the use of a night splint is something I do after. I mean, they may have gotten it before surgery. A lot of these folks are getting sent to me from my colleagues here at the school. They've already done other things for it. But I don't necessarily want patients to wear their cam boot to bed. It's kind of gross, but I'll definitely give them a night splint that they can use, particularly for bedtime, just to help keep things splinted after surgery.
Do we have any other questions coming up for Dr. Ehret? An old pillowcase works well. Okay.
Yeah, I think I could see that. If you're familiar with root functional orthotic, apply a post on rear foot. So if you are familiar with the root functional orthotic, apply a post on the rear foot of the orthotic. Motion can be created by grinding 3 degrees of lateral. Sorry, things.
Yeah.
Yeah. Keeps every time I scroll down, it covers up with something. I can't see it.
Okay. So I'll read them.
Yeah.
If you're familiar with a root functional orthotic, apply a post on the rear foot of the orthotic. Motion can be created by grinding a 3 degree on the lateral half of the bottom of this rear post. Don't do this if you want no motion. So if you don't want motion, then obviously have it be flat with no degrees.
Right.
They don't teach a lot of biomechanics now in the schools.
Well, that's not necessarily true. They certainly do. I mean, it is the foundation of everything that we do surgical as well. It's I think it's not. It's taught in the school. Where it's not taught, I don't want to get too political, is residency training, right? I mean, like we are pumped out, we're pushed out to be surgeons, and I know there's a big rift and divide in what we are and who to belong to and everything. I don't necessarily think we all should be surgeons, but that's just my opinion. I think we are starting to lose certainly some of the things that make us podiatrists. So the point here is noted. There's still a need for all these, I think some people think lower or conservative or what do you want to call it, issues in techniques. Yeah, I agree, right? Be physicians first, of course.
Yeah, we've been toying with the idea of doing a biomechanics event, pre and post surgical biomechanics, because it's not, again, there's not as much out there on it.
Yeah.
I think the more education we could bring, the better. How long do you keep the patients in the night splint?
Upwards of 4 months or so. It really, they start using it about the week one. Once the post-operative dressing is off, because I do leave that alone. I still worry about the soft tissue envelope and all that. After, 7 to 10 days, they start using it, and they probably use it for about 4 months or so. On on average.
Mm-hmm. And that's a good statement there, Bart. In my opinion, if you don't know how to fabricate, you shouldn't be prescribing one. So it's an interesting point. You know, I was just having a conversation recently with a group of clinicians, and they say that they leave the decision of what device to use up to the lab. And a lot of times, I think the power is in the hands of the clinician. That you guys know what might be best for the patient because they're your patient, versus leaving the decision up to the lab to make their adjustments or their fabricating the device that they might think would be the best for the patient. I think you guys know better.
Yeah, I agree with the last comment, right? I mean, you're dangerous as a physician when you think you know something, right? When you know, and when you don't know, you send it to somebody else who does know. Fortunately, here at the school, maybe I use them as a crutch. I got people like Scott Spencer and who does a lot of this stuff, right? So I can run these things off of him. I still feel pretty comfortable, prescribing them. I don't necessarily let the lab decide what they're going to use. I actually like the maximal arch supination support technique, that the soul support. I don't necessarily use soul supports, but that that's my thought process from a biomechanical perspective. It makes a lot more sense. But no, I agree. It's nice to have people that you can rely on to refer, even if it's orthotic. I mean, because these make a big difference. And if you're just kind of doing the same thing for everybody, you're obviously missing the boat.
Mm-hmm. Yeah, we're actually, to your point, we're putting together an event now, which is going to bring together different orthotic theories. Because that you mentioned one mass, you have the root theory. There's several of others, and we're going to bring together a full panel of experts to talk about different orthotic theories, because not every one works for every person. There's a little bit of everything that might work better when it comes to orthotics. So I think there's a need for some more of this conversation to go a little bit deeper. Listen, man, I appreciate what you brought to the table today, and thanks for being a part of the No Nonsense, man. I really I value your presentation. And
here's one final thought. So I agree. All these things are very thought provoking. If we let other people do what it is that we do, no matter what it is, right? It's a nail procedure, or orthotics, or surgery, or whatever. They're going to do it, and they're going to take it away from us, right? So we can't let that happen. I actually just saw, I think it's podiatry management, whatever. There was recently, one of these emails that gets sent out, and there was a survey, the most recent one. I just saw it last night. If a PA program was willing to give you, an online degree for 18 months as a DPM, would you do it? And I was like, and I couldn't believe, like 33% of people said yes, they would do it. Huh. Somebody's got to put their foot in the ground here eventually. And I think we got to get together, this big rift between the two big boards and everything. We got to, again, I belong to both of them, but I'm not, running the show. Those people need to get together. We need to figure it out because we got, a lot of snakes out there trying to take things away from us. So we certainly can't let that happen.
Mm-hmm. Agreed. Once again, my friend, thank you so much. Have a wonderful rest of your Sunday, and I'm sure we'll be speaking again soon.
All right. Thank you.
Take care.
All right. Take care.
how are you?
I'm very well, Rich. How are you?
I'm wonderful. I'm wonderful. Thanks for coming here all the way from Australia. It's about, what, 3 a.m. over there right now?
Yeah, I'm up before the kookaburras.
Well, we greatly appreciate it. Paul Graham's an Australian podiatrist with a special interest in musculoskeletal conditions. Dr. Graham is also the CEO of Step Force Training, and he's going to bring together some really great information on pressure and orthotics and the whole biomechanics, gait, everything. So I'm really looking forward to your presentation. I want to thank Extensor specifically for their sponsorship of this session and for their participation and sponsorship for the No Nonsense seminar. So I'm going to turn it over to you, my friend. Take it away.
Thanks, Rich. Let me share my screen. Hopefully you can see my screen now.
You're ready to go, buddy.
Thank you.
I like the bow tie.
Thank you. I've been in practice for over 35 years, and I've always loved the biomechanical side of podiatry. When I began my career, measuring and addressing excessive pronation was the key to good outcomes. But with the research over this period, when we see how the kinetics is affecting the foot, the kinematics or angles, measuring or force pronation and its relationship become much. However, it is also very clear in research associated with excessive pronation, but it can result in a number of common function and presentation that we as practitioners see in our clinics daily, as well as the intrinsic function of the mechanics of the lower leg and foot. So an understanding of pronation and the associated effects on function is still important, and so is finding a way to quantify any dysfunction caused by this. Traditionally, we measure pronation by comparing a bisection of the calcaneus to the distal third of the tibia above, measuring the difference between that angulation in quite standing, the resting calcaneal stance position, compared to the angulation in which the foot is in this neutral position. This kinematic of subtalar joint function has been challenged over many years, both in the veracity of the measurement and what is a safe and unsafe range of pronation. In the 2019 paper by Nig et al., they noted that there is no clinical definition of overpronation, and that, quote, the normal degree of pronation is unknown. Therefore, it is impossible to determine what is in excess of normal, end quote. They also note the difference between rear foot pronation and pronation involving the midfoot joint complex. Pronation at the midfoot joint complex further modifies the pronation, translating it into sagittal and transverse plane movement also. Much research has been done to measure this, resulting in the navicular drop and drift assessment to assess the lowering of the medial longitudinal arch in the sagittal plane and the forefoot abduction in the transverse plane. This obviously relates to our pronation measurement, so we need to take this into account too. But there's also been a key focus on the role of the windlass mechanism and its importance in stabilization of the medial column from mid-stance through terminal stance. The sagittal plane theory introduced the concept of functional helix limit, which by restricting sagittal plane motion of the forefoot rocker at its terminal stance, caused the foot to pronate to compensate. Continued dysfunction of this sort would often result in soft tissue adaptations, such as dorsiflex first metatarsals and forefoot supinatus adaptations, requiring further compensation. So this function would also need to be taken into account with our measurement. And while the measurement of pronation is mostly the work on seeing the leg and act as a spring dynamic mechanics continue to develop understanding of the complexity of the interaction between joints, muscle develop our power and complexity, and in all manner of activities, how the intrinsic soft tissue elasticity, musculature, working together with the elasticity of the soft tissue, maintains the stability of the midfoot joint complex, particularly medial longitudinal arch. We only have to think about how the foot functions in ballet, basketball, and football, to name a few, to see how all these systems interact and allow normal function to occur. So measuring pronation has become more difficult because of the combination of different systems in different parts of the foot and their interactions during all activities, from walking to playing on the sports field. Then, if we take into account the structural anomalies, asymmetries, as well as the adaptations that occur through repeated and dysfunction, looking at just one particular, gaining a particular number may not tell the whole story or structure. And one solution then is the posture of the foot. By looking at the possible and the shape of medial longitudinal arch to describe dysfunction coordination. The shape is not a new endeavor. There have been many methods offered through research. Recent examples include the arch index, described in Cabana's 1987 paper, and the development of this being the modified arch index described in Chin's 1995 paper.
Hi, Paul. Paul,
Yeah?
can you hear me? The audio's a bit choppy.
Yes.
Friend.
Yes.
The audio's a bit choppy.
Yes, I can.
Yeah, can you hear me? The audio's a bit choppy. Can you?
Yes, I can hear you.
Yeah, the audio's a bit choppy. The audio's a bit choppy. Can you stop sharing for 1 minute?
Yes.
Stop sharing for 1 minute. I think there's something going on with the connection, with your connection. Okay. Can you leave? Just leave.
Okay.
Hit the little red door. Hit the little red door, leave, and then come back in.
The little red door. Okay.
Left-hand corner, lower left-hand corner. Yeah, I was sensing that too. I thought for a moment when I left the room and came back that would resolve it, which it usually does. But I think it might be something in his connection. So he's going to come back on momentarily and see if we can't get his audio back up and running. He's a great guy, by the way. I've worked with him numerous times, and just a tremendous wealth of knowledge when it comes to pressure and gait and orthotics. So let's get him up and running. You can all hear me, correct? Everybody can hear me? Okay, good. All right. Okay, great. Okay, good. That's good. Thank you. All right.
Awesome. So where do you want me to start from again?
Start from the same slide that you were on. See if that works.
Okay, let's do this. Okay, can you see the slide now?
Yes, I can. Go ahead.
Awesome. Okay, so measuring arch height and shape, as I said, is not a new endeavor. There's been many methods prescribed and offered through research. Recent examples include the arch index described in Cavana's 1987 paper, and the development of this being the modified arch index described in Chin's 1995 paper. The arch index provides a mechanism of describing a high normal, and flat arch through measurements, while the modified arch index took that a step further by including plantar pressure mapping. While these were highly useful methods of defining the static posture of the foot, the information was obtained using a static position. So what we needed was something that defined the foot posture in dynamic stance. In 2006, Redmond et al. Published a paper describing a new system for defining standing foot posture called the Foot Posture Index. And in 2008, Redmond published normative values for this new system of measurement. It has become the default method of describing foot posture and is focused on an index of 6 features of standing foot posture to define a supinated foot, one of normal posture, and a pronated foot. The original research noted, quote, "The foot posture index has been shown to predict 64% of the variance in static standing posture and 41% of the variance in mid-stance posture during 3-dimensional analysis of normal walking, and, as such, provides a more complete description of foot type than most currently available static clinical measures," end quote. This was based on the finding of McFoyle and Hunt's 1995 paper that instead of the foot being in the neutral calcaneal stance position at mid-stance, it was in the resting calcaneal stance position. That is the same position in which the foot posture index was being measured from, and so should replicate function. However, there's been papers subsequently in 2012 and 2014 that note the variability of foot function analysed by plantar pressures that occur particularly in the heel and midfoot during dynamic gait. These variations in dynamic function are not well described in the posture index. The finding of the dynamic nature of weight distribution under the foot during weight-bearing function is easily seen when analysing the plantar pressure of a person walking. This alteration of the weight-bearing pathway ensures that, ideally, no particular tissue is significantly overloaded with each step, moving the pressure gradients around the area where possible. If this is the case in walking, how much more is it the case with a person participating in sports? In 1996, Song et al. Song presented a paper describing what he defined as the Centre of Pressure Excursion Index, or CPEI. The centre of pressure is a calculated line of pressure that describes the trajectory of body weight combined with the reflective ground reaction forces as it moves through the foot. It has been very well researched and validated, and is one of the key indices used to describe function in research in the papers. Some believe that the foot posture during dynamic weight bearing could be defined using the lateral displacement of the centre of pressure from a reference line. And through this reference line is between the start and end of the centre of pressure line or value, normalised by the foot width at the anterior third of the foot. The results of his paper confirm that this could be achieved. The concept of the centre of pressure, or COP, having a defined trajectory is not new. In 1978, Finn, Bolch and Moeller described the ideal centre of pressure trajectory as moving from the lateral heel, which he defined as low gear, to assist efficient progression of weight bearing, then moving medially across the parabola of the metatarsals to the first and second MTP joint, which he described as high gear, to facilitate the increased speed required for propulsion. A normative data set for the CPEI was developed as part of a research paper by Menz et al. As they analysed the posture and pronated foot function with foot pain in 2013. This paper, based on the Framingham Foot Study, was one of 4 research papers using the Framingham Foot Study dataset, and all used the CPEI which they defined as a measure of dynamic foot function. The results provided by the CPEI have been shown to be sensitive enough to quantify the differences between plantar pressures in feet from healthy volunteers and patients with stage 2 PTTD in Ringleg's 2006 paper. In Golotti's 2014 paper, it was found that individuals having feet functioning in the supinated posture range, defined by the CPEI, were 1.5 to 2.5 times more likely to have plantar heel pain. This was not in agreement with most of the other results, which found the foot functioning as a pronated foot described by other methods. It was in agreement with the 1999 paper by Payne et al., which focused on the function of the plantar fascia. They found that subjects with a flexible inverted forefoot did not demonstrate a functioning windlass mechanism, commonly found in mechanical heel pain. This indicates that the CPEI has the potential of measuring pronation and supination, taking into account both function and posture of the foot in different circumstances. Since the Framingham foot studies in 2013-14, there have been many other studies that have used the CPEI to describe dynamic foot function, and others looking at the function of pressure excursion in other areas, from balance in older people to gymnastics. Could the CPEI provide a dynamic measurement available in clinical practice that could help the practitioner understand the intricacies of function, how that relates to the symptoms that our patients present with, and to know whether any treatment strategy, or particularly surgery, has made a beneficial or other outcome? The CPEI feature is available in a number of plantar pressure systems. However, these often rely on the data only being available after the analysis is done and is presented in their reports. Exsensa's intelligent in-tube pressure system provides the information both visually and numerically during the actual playback of the recording. Here we can see the features of the CPEI being calculated visually and the results being presented in the statistics window. The benefit of having this information presented in real time is that we can see other information simultaneously to help in our understanding of foot function, such as the pressure mapping, the force versus time graphs, and other key indices. In this slide, we see that the right foot shows a presentation that the CPEI has defined in the range of functioning as a supinated foot. Here, the CPEI presentation is that of a foot functioning within a normal range. And here, the presentation shows the right foot functioning within the pronated range of the CPEI. Again, this is augmented by other key indices available through plantar pressure analysis. When we place the pressure mapping of the different CPEI ranges alongside each other, the differences become easy to see. If we compare the center of pressure, the white line, against the reference line in black, we can see that in black, in the supinated right foot, there is a large deviation of the center of pressure laterally. This is less so in the normal presentation, and in the left foot of the pronated measurement, we can see that the center of pressure almost mirrors the pressure reference line. This information is objective and calculated automatically. So long as a standard protocol of data acquisition and preparation is utilized and prioritized, the data should be dependable and the practitioner can be confident in its presentation. But due to the complexities of foot function and the interactions of the many different biological systems in that function, it is unlikely that no one measurement will provide an absolutely full explanation of all foot dysfunction. However, we may consider that the CPEI provides a reliable and objective measurement of functional pronation, from the results of the research. The use of the CPEI in research to inform our clinical practice is vital, giving clinicians a consistent measure of dynamic foot function. The CPEI is also very important in objectively measuring pronation in our patient's dynamic function to assist us in developing an accurate diagnosis quickly. However, this is just one of the possible uses of this technology, especially if the data is immediately available during analysis, as it is in the Extremity in-tube system. In one consultation, we can make a baseline recording and analyze it within 5 to 7 minutes, and then using an intervention, such as taping, wedging, or padding, we can attempt to improve the dysfunction. With the intervention in situ, we take a further recording to examine whether or not the change has the expected outcome. Here we can see a situation where on the left pair of footprints, a female patient has a pronated left foot, which we feel is interfering with the windlass mechanism. And following the previously quoted research on the windlass mechanism by Payne et al., we added a 5 degrees rear foot varus wedge correction. The further recording with this intervention is shown in the right pair of footprints. It shows that the CPEI moved from a pronated range to a normal range. However, it did not change the poor function of the forefoot, particularly the medial column. This information, as with any plantar pressure analysis, shows us what is actually happening to the foot at the time of recording. It doesn't explain exactly why. This is why a physical examination of key indices is so important to give us the reason behind the dysfunction. In this case, a substantially reduced range of motion of hallux dorsiflexion due to soft tissue contractions. What it does provide us is how the foot will respond to different treatment options, and that is incredibly important for both our patients as well as for our own confidence in selecting a treatment strategy. As we know, the foot is a highly complex structure with so many interacting factors that combine for efficient function, so to allow us to have the remarkable ability of movement that we have. As Da Vinci remarked, the human foot is a masterpiece of engineering and has been a work of art. Expecting one measurement to describe all facets of pronation, foot posture, and all foot function currently seems to be very difficult, highly complex, and requiring equipment certainly out of the reach of the clinical podiatrist and specialist in daily practice. While the CPEI does provide research-validated dynamic foot function information and gives us a reference point for supinated, normal, and pronated function, sometimes this is not sufficient to explain the whole story. This was found in the results of Bolt's 2018 paper, where they found that the CPEI did not provide statistically significant differences in their research, but found that the velocity of the center of pressure did. One of the key benefits of plantar pressure technology and its analysis is that it provides many parameters that can be examined. The center of pressure, its trajectory, and its velocity are just some. Extensor has been working with the results of such research in developing features to augment the CPEI measurement. Here we see a combination of analysis using the CPEI with the center of pressure velocity being measured in its speed and efficiency, noted by the hesitations and stoppages within the pathway. These stoppages in the center of pressure, particularly the major blockage seen in the left foot, where the center of pressure comes to a stop, moves proximally, and then finds an alternative pathway, can cause significant frontal plane compensation in the midfoot complex and the subtalar joint, as well as sagittal plane compensations in joints proximal to the foot. This dysfunction happens so fast that it can be almost impossible to see by eye. Again, this is in real time, so it is immediately able to be analysed by the practitioner and compared with other indices, such as the pressure loading of the tissues, the force versus time graph information, and all areas of loading within specific anatomical areas, fully reported in numerical values in the statistics window. The development of these diagnostic tools is hugely important to not only help us with our diagnosis, but also in assessing the efficacy of our proposed treatment strategies and to monitor improvement of function of those strategies. Of course, these changes have to work in concert with the available research. However, these tools also have to be practitioner-friendly, time-efficient, and relatively easy to use for them to make an impact in our daily clinical practice. Having the information to hand, being able to cross-check this information with other measurements and indices in real time is part of the solution. Exsensor is one company that's doing this, and the development of these connected measurements and indices that aid the CPEI measurement is a good example. Going forward, no doubt further development and integration with other systems such as EMG, IMU angular measurements, and high-speed video analysis will continue the goal to achieve systems that provide the measurements we need so that we can more fully make sense of what we see. Thank you so much.
Nice job, Paul. Appreciate that. You can, yep. I was going to pop something up there as well. I put a link. If you go to comments in the upper right, there's the exhibit hall actually where the Exsensor booth is in there. You could stop screen sharing, Paul. We'll get to a couple questions. Yep. And then I'm going to put up a quick poll. Exsensor reach out to you. And then, that'll be good. That'll be on the screen. Okay, so, Exsensor, I've been working with them for a while. The technology's phenomenal. Dr. Daniel, I think we should have 3 major points of contact on the foot: the heel, fifth MPJ, first MPJ area, no lesser Mets, and no IPJ hallux either. Those would be abnormal. Pronated would be a diffuse distribution all over the foot in the IPJ of the hallux. And supination will be showing a fifth Met base as well. Again, my take on this. Any thoughts?
It's difficult to actually be too descriptive of exactly what structures will load and when, because of the differences between, for example, a person with a high arch that has a neuromuscular origin or a structural origin, or the same high arch with hypermobile joints that collapses when the person weight bears. This is part of the complexity of the foot. And when you then throw in the spring-like features that is modified by the central nervous system managing the tension of the soft tissues by the intrinsic musculature, it gets really complicated to just come up with a very simple way of suggesting a pronated position.
That's why we need data, more data, right?
Yes.
Do we have any additional questions? Again, the poll's up on the screen. If you'd like someone from Exsensor to reach out, they're great people. I work with them. We talk every 2 weeks. Click yes on the screen. If not, click no. If you use pressure measurement in your office and you want to learn more about what their technology can do for you or help with your patients, feel free, again, click on the screen, yes or no. Either way, it's fine. And if you have any other questions for Paul, I'd love to get to those. We do have a couple of more minutes before the next session. And the next session is with Zhang Lai, which I think you'll all enjoy as well. It's going into lifestyle medicine. So a lot of what we've spoken about is holistic. Let's talk about it holistically. This is also leads to that as well, this technology. So please, if you have any questions for Paul, pop them up on the screen. We talked a lot about wound care today and yesterday, and so I think basic questions: are measurements made with the patient walking barefoot? Paul?
The measurements can be made with the person walking barefoot, with orthotics in situ or shoes, depending on the systems. Like the Exsensor system is an in-shoe system. So we use a neutral shoe to gain barefoot measurements. Then the next step is to look at how the shoe causes any changes to the barefoot measurements. And then we can introduce an orthotic or interventions such as low-dye taping, J-taping, felt padding, rear foot varices, heel lifts, etc., to see how that changes things. So that's one of the incredible powers of plantar pressure analysis with this sort of software that gives you the opportunity to, like an MRI, see exactly what's going on, but then actually test a diagnostic hypothesis to say, okay, if I think the foot is not functioning well, do I place a felt pad on the lateral border of the foot in a very high arched foot to try and move that supinated CPEI reference line more towards a normal CPI reference line. And if that works, you can then have a level of confidence to say, well, if I make a shoe modification or I make an orthotic that does that actual movement, that actual correction, then I can be confident that it's going to have that effect on the foot. The other thing is that the extensor in-shoe sensor pressure system has the ability to record up to 7 hours of data of the person walking or running or playing sport or doing their occupation, so that you can get real-time data for this information, so that you're not just getting a clinical measurement with the limitations of what you can find in a clinical situation, but you can then test that idea if it's proving worthwhile in the clinic by having the patient then go into their workplace or in their sports that they participate in and see if it still works in that environment. And that's incredibly important when you consider that some people come in to see us and they don't have pain normally, but they only get pain when they run through the mountains or being on a sports field or climb ladders at work. So that's where we need the data from. Mm-hmm. And combining the CPEI with things like the center of pressure, velocity, its trajectory, the tissue loading, etc., gives us all of that data that by cross-checking and understanding the relationships between those data sets, we can start building a picture. And I see that this is the future where podiatry, and particularly biomechanical treatment, will move into the future, getting out of the clinic and going into the environment in which our patients are participating in.
Mm-hmm. Real world answers, real world data, real world answers. Paul, it's always a pleasure. We're going to move on to the next session. I will see you soon, my friend, and to have a great rest of your morning.
Okay, thank you. Same to you.
Take care, my friend.
Okay, bye. Bye.
Good afternoon. Good afternoon, Doctor.
I'm still good morning.
Good. Nice to see you. I saw you in the last session, so I'm glad you're here. I want to introduce Dr. Zheng Lai. Dr. Zheng Lai is a certified physician and wound specialist of the Council for Medical Education and Training and a diplomat of the American Board of Lifestyle Medicine. He's also the founder of the Rochester Clinic, and someone that I've gotten to know recently with the great event we did on lifestyle medicine. And it's come up several times in this event. about lifestyle medicine and the changes. And I am greatly excited to have you on board. I don't know where you just went, but hopefully you'll be back online momentarily. There you are. Okay.
Yeah.
You want to put up your screen?
Okay, share my screen.
Yeah, lower left. Yep.
Great.
Excellent. All right, take it away, my friend.
Thank you. Good morning. Well, I'm still morning. It's an honor to present lifestyle medicine here. This is the second time when I talk about lifestyle medicine and podiatry. And it's a lot of material today. So I'm going to go through, and if you have any questions, ask or email me or come back to see the video. So today I'm going to talk about what lifestyle medicine is and the basic pillar of a healthy lifestyle, and talk about how we relate to podiatry. And I really hope to talk about physician burnout if we have time. Currently, our healthcare system, we are spending 3 times of the healthcare cost per capita compared to other developed countries. But at the same time, so when you look at our GDP, we are spending almost 20%. It depends on which study you see. It's about 20% of GDP we are using on healthcare system right now. And during our current healthcare system, 80% of healthcare costs are in chronic disease, and 80% of chronic conditions are lifestyle related. And so, what does the data mean to us? That means we have more patients to see. Now, more patients who need care because of chronic disease, and we have less time for every patient because we only have 8 hours a day we want to work. At the same time, because there are so many people in the healthcare system, we have less and less reimbursement. That's why we deal with it every year. And then we started to specialize. If we were thinking that if we specialize just seeing one thing, and then we can see more patients. But at the same time, because we're only seeing one thing, we're not treating the root cause. And what all leads to is the physician burnout. I think this coming Thursday, the American Medical Association and the Surgeon General will address physician burnout. So it's a big issue right now. And why lifestyle medicine approach is a good approach, good thing we have to think about, is a whole person care. We look at the whole person. It's just not the foot. I usually like to tell people that the feet don't come into our office by themselves. No, we have to look at the whole person. We're treating the whole person. It's not just the feet. And then at the same time, a lifestyle medicine approach involves a lot of education. We teach patients and let them understand the situation so they can follow our treatment plan. And at the same time, we empower them. If they don't want to do anything we want them to do, it's not going to heal. And then we teach them self-care and prevention. So when we talk about lifestyle medicine, I have to go back to the Blue Zone studies in 2004. I like these Blue Zone studies because right now, if you look at all the literature, even though we talk about evidence-based studies, a lot of research is sponsored by manufacturers. And there's some bias there already. And the Blue Zones project started out as a National Geographic project. So there was no sponsor and there was no bias. And the explorer, Dan Buettner, just want to see where people live longer and healthier. And he identified 5 areas. There's only one in US, that's Loma Linda in California. We'll come back to this one later. So of course, it's not anything else. He want to know what did people eat or what they did, one thing that would make them live longer and healthier. And he couldn't find any single item. That's why he found this whole lifestyle. They talk about the nutrition and active lifestyle, and their stress, their social networking, they have the purpose, they have the passion, they sleep, and they don't drink that much at the time. And no cigarettes like that. So what are the benefits of healthy lifestyle? Before we talk about this, just need to remind everyone that most of chronic conditions we see right now comes from systemic chronic inflammations. It may not be acute or very high level inflammation that we will feel or pay or test for. And they all come from, for example, the sleep, our diet, our GI, from obesity, lack of physical activity like that, even chronic infections. They'll cause all those systemic chronic inflammations. And from this, you can lead to a lot of systemic problems from cardiovascular, diabetes, cancer, depression, all of that. They all come from chronic systemic inflammations. So what is the lifestyle medicine? When I talk to patients about lifestyle medicine, the first thing they thought about was diet. And the reaction usually say, well, I'm eating pretty well. Well, just debatable what they mean pretty well, but that's all they think about is diet. But lifestyle is more than just diet. According to the American College of Lifestyle Medicine, the lifestyle medicine is the use of evidence-based lifestyle therapeutic intervention. They include the 6 pillars that promote a whole food plan predominant eating pattern, physical activities, sleep, stress, social networking, avoid the risky substance, and also social connection, positive social connections. As a primary, it's a primary modality delivered by clinicians trained and certified in this specialty to prevent, treat, and right here, often reverse chronic diseases. And so it's very evidence-based. In 2020, lifestyle medicine has been recognized by American Medical Association as a new specialty. And that's why they talk about the evidence, the training, and certification. But for me, lifestyle medicine basically means it's the way to treat the root cause by examining and making lifestyle adjustments instead of managing symptoms with medication. I really want you to take a pause right here and think about what medication, not just us, any specialty, any physician prescribe, what medications really treat the root cause. Most medications are just managing the symptoms, giving us a better lab results. The only 2 medications I can think of as treating the root cause, number 1 is antibiotics, the second is the cancer medication. But others is really just managing the symptoms. So the pillars of healthy lifestyle is a plant-based nutrition, physical activity, stress management, social connection, sleep, and passion. My clinic developed the 6 pillars before the ACLM came up with theirs. So we had the first 6, and the ACLM didn't put the passion there, but used the avoidance of risky substances. So I usually talk about all 7 together. So when we talk about nutrition, it's really plant-based whole food, and we call SOS free. Is no refined sugar, no or reduced oil, no or reduced salt. So that's called plant-based SOS. When we talk about plant-based, I have to give out this definition. It's a green plant growing up from the ground. It's not a meat processing plant or any manufactured plants. So we get that understanding is the plants, what I mean. So this is coming from the Blue Zones project. So when we talk about Blue Zones, after they identified the lifestyle, and they thought about how about what people eat over there. So when they went back there, they found out that the people there about 98% plant-based. But most important is the whole food. So only 98% plant-based. And then they went into how about the macronutrients, and that's how they came up with this food guidelines, recommending that at least 95% plant-based, 100% would be great. 65% carbs, because the Blue Zone average was about, I think the range was 45 to 65, on the average of 62%. So recommendation is close to 65% carbohydrates, 20% fats, and 15% protein. But then again, I really want to emphasize is whole food, first, and then plant-based. So when you have a whole food plant-based diet, you provide plenty of antioxidants. You can see most of antioxidants come from plants, and then you have a lot of micronutrients and fibers. We like to give people probiotics, but then those germs, what do those probiotics eat? That's called prebiotics. And those prebiotics actually is fibers. So if we don't give them fibers and we just try to eat probiotics by supplements or anything, it's not sustainable. So it's really that you have the fiber has been proved to be very beneficial to the overall health. And then natural oxide, just like you take the nitroglycerin under the tongue, it actually can get the natural oxide from the food, especially dark leafy green. So SOS-free is really reduce blood pressure and then reduce calorie intake. Here's a calorie density comparison. You can look at just oil, the same 500 calories. If the oil is only a little bit, but then it doesn't fill out our stomach. That means we have to eat a lot. And that is a comparison right there. And then another thing I want to talk about is the vitamin supplements. They cannot really substitute the healthy diet. We want to eat our vitamins, not just take our vitamins. And I really want to encourage you to treat them just like medications. I remember yesterday that Dr. Sher talked about the onychomycosis. You want to make a diagnosis. You want to measure before you prescribe. And I think that's a very important concept. It versus a lot of people, I have to say out loud, but like chiropractors, they like to call the so-called functional medicine. They just get patient a panel and then just prescribe them vitamin supplements right now. So I really like to do the lab test and then look at the lifestyle adjustments before I give them out the supplements medications. And then movements. It's a constant gentle movements. It's not really going to the gym. That the Blue Zone explorer Dan Muter once said that there's no gym in the Blue Zone. It is really, you have to encourage them to move constantly, to move around. That will improve their circulation, improve their microbiome. That instead of a lot of patients, when they think about movement as going to the gym, they will say, oh, I go to the gym for an hour today already. And then they'll sit there the rest of the day and then they'll eat whatever they want. So it's really counterproductive by promoting the exercise. So I really talk to them about the physical activity as gentle movement instead of just the exercise. So walking has been linked to the overall wellness, longevity in general. And walking is the most popular physical activity among adults. There's no special clothes, equipment, and it's free. When people walk regularly, they'll reduce their cortisol and they'll release endorphins and produce epinephrine and release serotonin. Serotonin is a big one. I hope we'll have time to talk about more later in the lecture, in the presentation. And then increase testosterone and also the estrogen. And so benefit of walking, but people doing the regular walking, daily walking, they can lower their risk of high blood pressure, heart disease, reduce the blood sugar, especially after meal. Remember, muscle is the largest organ in the body that uses glucose. So by taking a walk after the biggest meal, usually it's dinner, for us, that you just walk, that will reduce your blood glucose a lot. And of course, it can strengthen the bones and muscles, reduce stress, improve your mood, improve appetite, and also improve the sleep quality. Stress is a big one. Stress promotes the release cortisol, which will promote inflammation, increase the blood pressure, reduce immunity, and most importantly, it will degrade the soft tissue. And then right here, I have a reference on the effect of cortisol to various organs. It's just universal in our body. And sleep, surprisingly, or not surprisingly, when I talk to patients about the lifestyle medicine, sleep issue is one of the major things that the patients that they didn't have enough or didn't have a good quality of sleep. So adequate sleep will promote tissue repair. Remember, the body repairs itself in our sleep, especially the deep sleep stages in stage 4, sometimes 3. When you have adequate sleep, you also can decrease your craving. So this decrease appetite. And then you decrease your stress and improve the mental clarity. Social connection, it mostly provides the supports. And then for the passion is the one that we don't usually talk about either. It's the purpose of life, and it motivates the patient to follow up our treatment plan and go through the treatment and have the good results the patient wants. So what chronic disease could be reversed? Here we talk about reversal of chronic disease. We can do more than manage and hope for the best. So what disease can be reversed? Circulation, cardiovascular disease, stroke, dementia, low back pain. When we talk about cardiovascular disease or circulation-related disease, we talk about the coronary artery. You think about coronary artery is about 5 millimeters, and it's pretty much like the half of your pinky toe, your pinky finger. If the artery that size, the vessel that size can be blocked, think about the small arteries, vessels throughout our body. They'll be blocked first. And the research has shown that 10 to 20% of low back pain is actually related to atherosclerosis. And so it's the same issue as erectile dysfunction, PAD, of course, that's what we deal with daily. And neuropathy. Neuropathy, a lot of time can be reversed by cleaning up the circulation system. My clinic, because I have family medicine in the office also, we do have cases that we reverse patients' diabetic neuropathy. And the patient not just came in and then would adapt whatever we say. The first patient we noticed actually didn't change her lifestyle for at least 2 or 3 years after we kept on telling her about 2-3 years. And then one day she decided that it's time. She had to go to dialysis. She thought there was nothing to lose. Changed her diet. Less than 3 months, she regained sensation on her feet. And I never saw her. She was our family medicine physician patient. So when you talk about atherosclerosis, it starts from the small muscles. It usually start with some sort of inflammation here, and then have a tiny scar, and then the cholesterol will attach and then plates. And then sometimes it getting bigger, and then the cap will rupture. You have the blood clots, and then you disturb the flow, and then you have the turbulence right here that will create another clot right here. And then it will be a good opportunity. We'll talk about a TMAO. It's a trimethylamine N oxide. TMAO is produced by food containing carotene or choline. That means it'll be animal products, dairy, like that. It will be degraded. This food will be degraded by the microbiome, that the bacteria in our gut, to TMA. Then TMA will go to the liver and become TMAO. TMAO is very inflammatory, especially to the blood vessels. So TMAO contributes greatly to the development of atherosclerosis. And just like here, going to the left descending, that's the widowmaker that people like to mention. And you have the BRCA right here. So this, I will talk about this case. This was published in 2014 in the Journal of Family Practice. So when you look at the PET scan right here, there's no blood flow. That means the patient will have angina because the blood doesn't go through, doesn't supply the heart muscles here. So this patient changed the diet to plant-based diet for 3 weeks. 3 weeks, no medication. And then you can see right here, the blood store restored right here. And then on this case, you can see all this blockage right here. So the patient, not just the diet, but all the lifestyle pillars, the physical activity, stress, everything. And after 32 months, you look at the blood vessel. So we just think about what type of medication we give to the patient that can do something like this. They'll be lucky not to get worse. But just by changing the lifestyle, especially the diet, the patient could restore this vessel, coronary artery, in 32 months. And in fact, if I remember correctly, this patient was a surgeon at the Cleveland Clinic himself. He got a heart attack after surgery and talked to Dr. Esselstyn at the Cleveland Clinic, and who told him to change the diet and lifestyle. And that's what he did without any medication. So this is a good example of how lifestyle can reverse the cardiovascular disease. And so when you look at the cardiovascular disease, the risk factors, of course, of weight, saturated fat, excessive lipid, stress, alcohol, and inactivity. Remember, saturated fat only comes from animal. Well, the only two sources or plain sources of the saturated fat will be the coconut oil and palm oil. Except these two, all the saturated fat comes from animal products. So PAD, of course, we know this. We deal with this very often. It's similar to the coronary artery. You have the blockage here and reduce the blood flow. Okay, type 2 diabetes. When we talk about diabetes, patients usually think about is carbohydrates. But I really want you to do a research to check out the intramyocellular lipids and insulin resistance. This study goes way back to 1999. There is a positive correlation of, inverse. There's the insulin resistance sensitivity reduced. So the insulin resistance increase as the intramyocellular lipid increase. So those two, you can look at the correlation. That means that type 2 diabetes, I usually like to remind people, is a cause and effect. The insulin resistance, insulin insensitivity is due to the increased intramyocellular lipids that interfere with intracellular signaling inside the muscle cells. So when you have too much saturated fat inside the muscle cells, the insulin receptors do not work. And that's why when you have carbohydrates, your blood sugar will go up. This effect we see is not the cause. The cause is really coming from too much saturated fat inside the body. Okay. So right here, when we look at the diet and type 2 diabetes, here is the Adventist Health Study. Adventist is their teaching has a lot of plant-based whole food. They promote plant-based as part of their teaching, and the most concentrated population, Adventist population, is in Loma Linda, California, and that's why it is the only blue zone in U.S. It's because this Adventist teaching in the diet. So when we look at people, so not everyone in the Adventist church follows a plant-based diet. So some are really vegan, some has dairy and egg, and here some also add some fish. And then there's people who sometimes eating vegan, sometimes just regular diet. And then this one is a regular American diet that we call Standard American Diet, SAD, SAD. And when you look at their BMI correlation, the more animal products the person has, the higher BMI they'll have. There's a correlation. And then when you look at the type 2 diabetes, it is the same, especially when you look at here, a little bit of dairy and fish is a bit higher than vegan. But when you look at starting to have dairy and fish and meat, the type 2 diabetes incidence just jump up right here. And then when you look at another study published in 2020, the meta-analysis of 16 studies with over 1.1 million participants in multiple countries, and look at lifestyle factors of smoking, alcohol, physical activities, diet, and body fat. And so the people with the healthiest lifestyle have 75% lower risk of diabetes compared to those people with the least healthy lifestyle. So that's another proof that lifestyle can really impact the diabetes. And for those people who attended our lifestyle medicine webinar last week, the registered dietitian Brenda Davis gave out a reference on the definition of diabetes reversal from the American Diabetes Association and also from American College of Lifestyle Medicine. Those will be the good reference to see how what the definition of diabetes reversal is. And then people say, but I have genes. That is a good thing to talk about genes. Family shares not just genes, but habits, recipes, traditions. Those are all lifestyle related. And then there are also genes, they are detectors versus some are committees. Well, what does it mean? Some genes are just detectors. You have no question about it, whatever they say. For example, it's your hair color, your skin color, your eye color. It's black, it's black, it's blue, is blue. There's nothing you can argue about it. But most genes, especially gene-related chronic conditions, they are so-called committees. You have a gene, but it doesn't mean that you have it. The committee will make a decision based on what you do. So what I want to talk about is this article in 2016 that compared people who have the gene for cardiovascular disease, coronary disease versus people who don't. So they have two groups, people who have the gene but have a high healthy lifestyle versus people who do not have the gene but don't have a healthy lifestyle. You want to guess which group people have higher risk of heart disease? Yeah, people who don't have the gene but have a bad lifestyle. So that's something we call epigenetic. The gene is the same, but their expression or lack of expression is controlled by the proteins surrounding the gene. And our lifestyle, especially our diet, will control the gene expression. And that's why there are a lot of the so-called nutrient epigenetics that you should look at the nutrition and epigenetics. So let me go back to this. Let me share with my own experience about genetics. I've been treated for high cholesterol since my mid-20s. The physicians rule out the lifestyle, rule out my diet, everything. So they started treating me for high cholesterol since my mid-20s. I got proof that I have high cholesterol gene 2 years ago from a research study at the Mayo Clinic. But way back that time, I've been treated for that. And as I get a bit older and wiser, my cholesterol got even higher. I had to take more statin until 2013. We had a family doctor who was a chair of family medicine at the Mayo Clinic. He took early retirement and joined us. he said he had prescribed way too much medication when he was a male for 35 years. He want to reduce medication by looking at lifestyle. That's why he brought in the lifestyle medicine concept to us. And then he looked at me and said, Jen, how about you look at your diet? And in my mind, I was just like, are you serious? I'm pretty healthy. I eat healthy. I'm Asian. I eat very healthy. And my BMI at that time was 25. It's not that I was very overweight, obese, 25. But at the same time, at that time, my waist kept going wider. At that time, I was wearing size 32 pants. I actually purchased a pair of 34 because it was on sale, and I thought, well, I'll need it sooner or later anyway, so I got 34. But just by changing the diet, not as plant-based as I am right now, just by changing a little bit, I lost about 10 pounds in less than 3 months. But then later on, my weight didn't change much, but the size really changed. I now have to wear 29 if I could find them in slim fit, and all my shirts is small and slim fit. But most importantly, my cholesterol medication has been reduced instead of increased, by reduced. So I have this gene, and I cannot change it, but I can take less medication and have better control, similar to type 1 diabetes. And at the same time, well, I got a high cholesterol gene from my father. I had very strong diabetes gene from my mother's side. So one of my sisters passed away from diabetic complications, and my mom and all my siblings have diabetes, but I don't. My fasting glucose is in the 70s. However, my A1C is 6.0. The family doctor thought there was a mistake with the lab. So I drew several tubes of blood and sent to different labs. They all came back the same, elevated A1C. So he told me not to check my A1C again. Well, I still do. But the point is, yes, I don't need to have the diagnosis of diabetes, but I work very, very hard and still have that elevated A1C. So the genes are really working. It doesn't mean that genes do not do anything. What we like to say is bad genes load the gun, but bad lifestyle pulls the trigger. So gene is not a destination. It's really what we decide. So next I want to talk about weight management. A lot of times patients will come in and say, I gain weight because I have a foot pain, I have ankle pain, I cannot exercise. But don't let patient give you that excuse. You know how much calories will burn in exercise. In regular moderate exercise like weightlifting or walking, on average, a person can burn about 100 calories in 30 minutes. But one hamburger will have more than 200 calories. Not to mention it's just regular hamburgers. We don't count the fries or the soft drink or anything. So weight loss really starts from the kitchen. If anyone talk about, oh, I gain weight because I couldn't exercise, look at their diet first. Our family doctor told us that he didn't want to talk to patients about exercise at all because they have pain, they're overweight, they are not going to exercise. You have to work with their diet, that then reduce weight, and then they'll exercise on their own. So I usually like to tell patients that you cannot outrun a bad diet. No, if you don't change your diet, the weight is not going to change. And then when we talk about diet, I have to mention this cancer. March is Cancer Prevention, Cancer Awareness Month. If I believe we promote a smoke-free environment or workplace because of cancer. But in 2015, World Health Organization classified processed meat as Group 1 carcinogen, same as cigarettes. Red meat is Group 2. Also, if we want to promote a smoke-free environment because of the cancer, maybe we should consider looking at the meat also. So I want to talk about two common conditions we deal with: plantar fasciitis, heel pain, and diabetic foot ulcer. How we treat it. So heel pain is the most common condition, one of the most common condition we see. And when we look at the treatment plan, we look at assess and treat structural issue. Where here I want to mention this in a lifestyle medicine approach, is whole person approach. Look beyond the calf muscle. You know, not only the therapists I work with know what I want. Whenever I refer a patient to them, they know they assess the patient from the foot to at least the lower back, not just their ankles, not just their calf muscle. They know I want more. And a lot of patients, one patient even told me that I have plantar fasciitis, I have heel pain. And the physical therapist was massaging, relieving my lower back, and my pain go away. So you have to look beyond just that one, just really look at the whole person. And then besides the shoes, and we want to look at their lifestyle. So the basic lifestyle I would talk to them is, remember, pain is one form of inflammation. So when you eat food, you want to make sure you avoid the inflammatory food and increase anti-inflammatory food. That alone will cut down the pain. Make sure they do the stretching. I mentioned the lower extremity, not just the ankle. Stress management could also disrupt the balance between inflammatory and anti-inflammatory process. More stress, more pain, basically. Sleep, again, emphasize to them that tissue repair occurs in stages 3 and 4 during the deep sleep stage. So what are the food? Want to avoid refined carbohydrate. Not just avoid carbohydrate, we'll talk about that a little bit later. Dairy, alcohol, all those are inflammatory food. Anti-inflammatory foods will be dark leafy greens and especially berries. And diabetic foot ulcer, that is one we want to avoid, the amputation. So when you look at the standard of care in wound management, when I want to check for the infection, when I look at the vascular, when I offload, when I look at the local wound care, we do that regularly, and we want to manage the systemic comorbidities. So infection is really related to immunity, and the vascular, we talked about that earlier already. So how do we deal with it? When I talk to them about their nutrition, because the wound want to increase the protein a little bit, not a lot, but a little bit. We want to make sure it's a plant-based protein, because plant-based protein do not come with saturated fat, which will compromise the circulation. And we want to increase anti-inflammatory food, just like we use a lot of MMP inhibitor in our dressing. We want to cut down their inflammation. We want to make sure they have enough micronutrients, especially for collagen synthesis. Remember, it's wound healing. We want to promote the tissue regeneration. We need vitamin C, zinc, and copper for collagen maturation. Vitamin C certainly only comes from food, from plants. Zinc and copper, you can have all those plentiful from the seeds, especially pumpkin seeds. We want to make sure they still can exercise, even they cannot walk. Upper body to improve their circulations. Stress management. Again, cortisol will cause inflammation. And then cortisol also degrades soft tissue. When we try to promote tissue regeneration, we don't want cortisol there to counterproductive. So social connection support is very important. A large percentage of patients with chronic wounds have depression. So this is a good time. They need to have a good social network, a good support network. Remind them about sleep, not only the tissue repair. Study has shown that fibroblast migration is associated with circadian cycle. So if they don't have a good sleep, not only the quantity but the quality, they'll impair their wound healing. and passion is motivation. If they don't have the motivation, especially when they have the depression from the chronic wound already, it's hard to ask them to do a lot of things. So I'm going to move a little faster. So right now we do the comprehensive diabetic foot exam. We ask them to do the daily foot inspection. We look at their shoes. We even had the remote monitoring insoles now. We try to prevent the diabetes. But why not start the diabetic foot ulceration prevention from preventing or even reversing diabetes? That will be a much better prevention program. And then when we talk about patient compliance, a lot of time patient no show or they don't do what we ask them to do. What do we do? Well, just put on patient not compliant. That's about it. But at this point, I really want to encourage everyone to look at the social determinant of health. A lot of time they don't do what they need to do, or they don't show up for their appointment, not because they don't want to, but because they just can't. If they are worried about housing, if they are worried about their utility being cut off or their personal safety, they are not going to worry about their foot, their ulcer. If they don't have food at all, how could we tell them what to eat, what's better for them? They couldn't even have basic food for survival. And then also the transportation. They cannot come here for the follow-up simply because they have no transportation. Not only they have no car, maybe they do not even live close to a bus stop. So those will be things that we need to look at it, not just simply say, oh, patients non-compliant. Okay, so podiatry in chronic conditions, we want to really remind everyone that a lot of chronic conditions affect our daily practice. We want to, as a patient, to follow a healthy lifestyle, and so that can be easier for us. Oh, okay, I spent a few minutes talking about physician burnout. I talked about earlier that we have more and more patients to see and less reimbursement and the burnout. Why lifestyle medicine approach is a good approach to combat the physician burnout. First of all, burnout is related to the job satisfaction. If we are not happy with our job, maybe it's working too much, not the pay, but also the outcome. Now, a lot of times, if we go to the field of medicine, not just because the salary, I hope. A lot of it is we want to help our patients. If we don't see the results, we don't see the outcome, it makes us even more frustrated with our job, and it's easier to lead to burnout. So by doing a lifestyle medicine approach, look at the root cause instead of just treating one thing, one local wound or anything. It will lead to better outcome, and that will make us feel better and less burnt out. And the lifestyle medicine also talk about stress management, and another thing is emotional intelligence. Emotional intelligence is basically how we make decisions, how we react to anything that come to us. So emotional intelligence is mostly happen in the frontal lobe. In the frontal lobe here it look at our decision making, our personality, how we solve the problem. It's called the executive center. It's frontal lobe. And there are two things about the brain health. One is the physical health, one is chemical, is neurotransmitters. For the physical health, we want to make sure we have good circulation. We want to avoid harmful substances. It's very easy to say. And for the lifestyle component, how we accomplish the better physical health is really plant-based diet. No saturated fat to compromise our circulation. Make sure we have a good circulation by having physical activities, reduce our stress. Stress has one thing, is the hypertension. And when we talk about hypertension, we have to mention about BBB. Everyone knows about BBB because brain is very important. And so when we do the interval training, I don't know whether you're familiar with interval training, we should. In that short period of time during our intensive training time, we push the oxygen and nutrient through BBB to our brain to increase to increase the nutrient, and so it's good for our mental health and physical health of the brain. However, if a person has hypertension, they have the high blood pressure that the blood is pushing the BBB all the time. They open up the gates, and now the harmful substance or bacteria, heavy metal, anything will go through the brain, and that's why hypertension is a risk factor for dementia. So maintaining the good blood pressure is a good thing for the brain in that. And also the cerebral spinal fluid circulation is just like the sewage system that bring out all the harmful substance from the brain. However, the channel only opens up at night when we sleep, especially in the deep sleep stages, just like any wound healing, tissue regeneration. So good sleep, not only good quantity, but also good quality of sleep is very important for the brain health. And then when we talk about the neurotransmitters, we know there's a lot of transmitters, but the one I really want to focus on is serotonin. It's good for the mood, anxiety, like that. It's made from tryptophans. And a lot of people know that 80% of serotonin in our body is made in the gut. However, the serotonin does not cross the BBB because it's too big. And so in order to get serotonin in our brain, we have to make sure we have tryptophan inside our brain. Tryptophan is just like any amino acid. It crosses the brain, the BBB, by active carrier. So in order to do that, when we increase the insulin level, because insulin is a growth factor, you drive the amino acid away from the brain into the muscles or anywhere to generate tissue. So at that time, the tryptophan will have more chances of getting through the BBB. What I usually like to say is just like a lot of people waiting in a subway station waiting for the train to get on the train. And suddenly someone stand in the back say, ice cream, and a lot of people rush to the ice cream stand, and then now you have a better chance of getting into the train. So, and that is the reason why people are addicted to sweets, because when you have sweets, you have instant spike of insulin, and you have instant spike of tryptophan through the BBB. And just like any chemical equation, you have sudden increase of the substrate, and then you have more end product. So when you drink the soft drink, you feel good, and then you get addicted. And that's the same thing. So the recommendation is really to have a compressed carbohydrates that you can have gradual increase of insulin. So you can have more tryptophan going through your brain, and in a short, not only a short period of time, but a long period of time, gradually up and gradually down. And that will give you better serotonin production and better frontal health, frontal lobe health. And besides this, music is very important in frontal lobe. You have the classical music, especially Baroque music. Rock and roll is not good. Reading is good. Sleep, passion, positive thinking, gratitude are very important too. If you're not familiar with the cognitive behavioral therapy, I'll encourage you to check it out. It's very good for anyone to have a CBT training. And what I do in my office, we call it Pharmacy RX. Right here, you can see my logo. This is 6 pillars all put together. We have a nonprofit called Lotus Health Foundation to promote a local wellness education. We call community wellness. And here is at the beginning of last year, the planning season. This is my clinic. And here's looking at from the parking lot. And that's what we have. And this, we also have the exercise. She is a physical medicine rehabilitation resident at Mayo Clinic. She's doing a lifestyle medicine curriculum from the American College of Lifestyle Medicine. And this is part of her volunteer requirement. She came to leave our patients exercise, stretching like that. And then during the harvest time, we had a master gardener from the University of Minnesota to show people about the produce, what they are, how to plant them. And then my wife would do a cooking demo. And every week, volunteers come to harvest the produce, and we donate to the local food shelf. And we also put the produce in our clinic for patients to pick up. Any patient that have any questions or they don't have money to buy food, we ask them to go out to our garden and pick produce. And that's what we do. And we also have an annual community wellness symposium and gala. And this is our 5th year because of COVID, so it's only 5th year. And that's what we do. And if you want to know more about lifestyle medicine, American College of Lifestyle Medicine or American Board of Lifestyle Medicine. Thank you.
Fantastic job, Jang. Stop screen sharing.
Yeah.
Well, we have a few minutes. I actually want to do a special shout out. We did this lifestyle medicine event last Friday, and it was truly spectacular.
Thank you.
I have it posted. I put the link in the chat. So if anyone would like to view the videos, they're all up there. It was the CME event last week. So unfortunately, you won't be able to obtain CME for watching the videos. But irrespective of that, I think it's very, very worthwhile to check out some of the sessions that are posted. I think, as we're hearing from all the audience, just a great presentation. Dr. Holt was at the event last week. It was truly, truly phenomenal. Thank you for that session.
Thank you.
We do have a couple of comments in here on. We had a bunch of chats back and forth on direct care and co-pays and things of that nature. But we do have something in here I saw on fish. Talk a little bit about oils. Talk a little bit about the different oils, Jen.
Okay, omega-3 or omega-6. 3, in one sense, is anti-inflammatory, and 6 is pro-inflammatory. But 6 has a function of lower cholesterol. So we want a ratio of 6 and 3 at about 2 to 1. So not too high. So initially we talk about fish oil, and I grew up on the island by the ocean. I love fish. There's no question about it. However, there are a few things. Is the fish doesn't produce omega. It is produced by the algae. And then they got eaten and then got into the fish and stored in the fat. But then the problem with the current fish is there are too many environmental toxins, the chemicals, the heavy metals. They all go to the ocean or go to the river. And where they store those toxins is in the fat, the same place we want to have the oil. Also, that's why it's good in one sense that you eat a fish for the oil, but at the same time, you have the risk of eating all those harmful chemicals. And the second thing is when you eat fish, and the fish protein is just like any animal protein. They will increase the TMAO. They will increase the inflammation, especially to the vessels. So even though fish oil is good, but at the same time, we might pick up some other things that are not good for our body. So right now, I do take. There's one of very few things I take. I do take omega, but it's algae, omega-3.
Okay, so Dr. Scott asked, for some of the patients been suggesting blending certain vegetables and fruits. What would you suggest for them?
A lot of leafy greens, cruciferous like kale, like that. Put it there. You wanna add a little bit onion if you can stand it. Just a little bit onion, raw onion is very good for you, and especially after you spin. Onion, the cruciferous, they have a very good compound. However, they have to combine two compounds. One is outside, one is inside the cell wall. So you have to chew it in order to bind them together. But then if you chew it after it's cooked, it doesn't work. So you have to chew it raw, or you have to cut them and then sit for 15 minutes for them to mix up, and then you cook it. So there's a cool shift time. And then I'll put some blueberries, anything together.
Yeah, well, it's American Board of Lifestyle Medicine and the American College of Lifestyle Medicine,
Yes.
right? The American College of Lifestyle Medicine provides a certification for podiatrists, correct?
American College of Lifestyle Medicine is just like APMA, is the organization for all the practitioners.
Okay.
And the certifying is American Board of Lifestyle Medicine.
What about krill oil?
Yeah, it is similar. So it's just coming from. If you want to use the krill, no, why not just use the algae, because they eat the algae to get the omega.
Well, we're going to you please Misty, definitely go in and take a look at that. You have any questions? You want some more information on the lifestyle event that we did last week with Zhang and his team, which was pretty phenomenal. Message me. We'll get you all the links and information you need. We're also going to be doing another lifestyle event in the fall, and we're going to do it on a Saturday. It'll be a CME event, so keep in touch with that. Truly awesome to see you. Great to have you on this panel.
Thank you very much.
Value our relationship, and say hi to May for me, okay?
Okay, sure.
Right.
Thank you.
And we'll move on to Dr. Rogulski's session, and we'll see you all in the next room. All right, Jane, take care.
Bye.
Very highly rated session last year. We're happy to have you back this year. I'd like to introduce Dr. Matt Rogulski, fellow faculty of the Royal College of Physicians and Surgeons in Glasgow, Scotland. He's been the director of the Wound Care Institute for 18 years and is a senior partner at Ocean County Foot and Ankle Surgical Associates. So I'm going to get right into it and turn it over to you, my friend.
Thank you, Rich. And thank you for having me in the company of such learned people. This is a great honor and a privilege for me to talk about not only topical oxygen, but the wound healing cascade, prevention of amputation, and obviously diabetic people in general, since this is only becoming exponentially worse. And I really think that it is the existential threat to health diabetes is. And not only with diabetes, but we think about the rates of it at right now. In our country alone, we have 37 million diabetics. We have 95 million pre-diabetics just here in the U.S. Middle East is growing at 35%. And by the time of year 2030, we are going to be seeing around 25% of the world's population will be diabetic. And around 2045, that is supposed to go to 52% of the world's population will be diabetic. And considering that it's the number one reason the diabetics are admitted to the hospital is for foot ulcer, no other reason. Unfortunately, I think that is it's only going to be getting worse. Now, we're all quite familiar with when people have diabetic foot ulcers, all the problems that are associated with that and the high risks of mortality and obviously the morbidity that's associated with it. And yes, the mortality rates are higher than just about every cancer out there except for pancreatic cancer. And I think that comes from a problem for our patients not understanding what is going to happen to them. I think a lot of them just hear, oh, I have diabetes, I can take a shot. Or I have diabetes, I can eat what I want, doc, I take a pill. And I've had people say that to me, not understanding the full scope that this diabetic problem is going to affect every system in their body. And I like to think of it as an equal opportunity destroyer. It doesn't matter who you are, where you come from, how much money you make, what religion you are, it wants to destroy you and kill you. I come from a long line of diabetics. I carry a copy of the type 2 diabetes gene from a pharmacogenetic study that I did. My father had diabetic foot ulcer. I ended up cutting half of his foot off because he got mangled by people that should have known better. So I am a champion of evidence-based medicine, and that's what I'm going to be presenting today about this, all about the evidence. Yes, we're going to cover good physiological processes because all mammalian physiological processes rely on oxygen for a homeostatic mechanism, but at the same time, what is the evidence for using that? The costs are getting astronomical. Before, we used to say that 15 to 20% of diabetics were going to develop foot ulcer in their lifetime. Now it's up to 33%. Is that a consequence of these people not knowing what's going to happen to them? You know, you'd be surprised. You and I, we talk about to our diabetic patients all the time. And one of the first things I ask them when I see a new diabetic patient is, do you have a cardiologist? Because 89% of you are going to die from heart attack and stroke. So us being these gatekeepers, us in the podiatry community, we can get a lot of these people out to those areas. And I think to those physicians, and I think that it's going to have a significant impact upon their life. We're going to prolong their life. I know I get questions all the time. Do we really believe that if we save somebody's limb, are we saving their life? And that's a really good existential question to think about. Are we really going to be saving their life if 80 to 90% of them are going to be diabetic? 89% of diabetics are going to die from heart attack and stroke. So I think when we look at these rates, when you can see what a diabetic foot ulcer, that's a mortality rate of almost 31%. I've seen some that show 47% is the 5-year mortality rate. When you couple that with just having a minor amputation, and that includes a toe amputation, but sometimes it's needed. You and I see people with hammer toes who get wounds on the distal tip of that hammer toe, and they may have some areas of exposed bone, and people are fidgeting around with it for months and months. And these are areas once you know blood flow and all those other things, that you can proceed partial amputation or whole toe amputation and to resolve that problem. But I've always wondered myself about, if we do save these limbs, are we actually going to be saving lives? Are we actually having an effect upon them? I know that, for instance, in my father, when we fixed his problem and solved his problem, he had many good years afterwards. And yes, he did die from a massive stroke one morning. He got up, he went to the bathroom, he was getting ready actually to go to physical therapy, and then just fell over, and that was the end of that. So it's always a good question to think about. When we fix a wound and we heal the wound and we salvage that limb, do we save their life, or are we prolonging their life? And it also goes back to the education of the patient. As I said, how many of them know they need a cardiologist? I've had patients that never even seen an ophthalmologist. I've had patients that had blood work and they have kidney dysfunction, and the primary hasn't even sent them to get looked at. But see, I think it goes back to that of us educating them, but also for these patients to understand what is going on with them and to be able to retain that. And obviously, when you go to the physician or you go to see a doctor, everybody forgets a lot of things of what they said. You'll come out and your spouse will ask you, well, what did he say about, well, he said something of this. And then later on, when you get home, you forget about, what was that medication he told me to get? Something over the counter, right? Things of that nature. So I always encourage them to write down their questions and then write down their response. I try to write out things for them, particularly vitamins, particular protein, or things that have to go on during this wound healing cascade to be able to help them. And unfortunately, that is a problem. And when they don't understand, when they don't know, I think that their compliance factor is going to be going down significantly. And that's going to have an effect upon their wound healing outcomes and their outcomes in general. And with all these value-based systems that are coming on, the field of wound healing and limb salvage are definitely big areas where I don't know if that is going to apply. But at least for us, I think that we need to be able to convey those messages and give those people information for them to help them to do better and to get them to other physicians as well, because diabetes affects every system in the body. And, and again, with that, when I was posed that question, do we really believe this malarkey that if we save limbs, that we are saving lives? Now, we know that diabetes, well, I should say chronic wounding and cancer have a lot of the same molecular perturbations. Cellular senescence, epithelial mesenchymal transition. There is cancer stem cells and stem cells that we see in wound healing are deficient. But of course, that big one of cellular senescence that occurs, and cellular senescence was supposed to be a checkpoint to limit out of control hyperplasia and august tumor formation. But that is very akin in both cancer, its invasion, and in the chronic wound healing arena. Tremendous amounts of cellular senescence, stem and progenitor cell dysfunction, macromolecular damage, and chronic sterile low-grade inflammation. So when we heal these wounds, they do have a 40 to 50% recurrence. So I always tell my patients that you may be healed, but you are never cured because of the recurrence of the ulcer. Just like in cancer, there's only two types of cancers that are curable, and that's testicular cancer and Hodgkin's lymphoma. All the rest go into remission. So do we say to patients there that we shouldn't put their cancer into remission because maybe we're not having as dramatic impact as we thought we were? Well, of course not. I think that sometimes I try to heal everybody that comes through, and you may think that's stupid, that's naive, but that's what I try to do. I try to think of them as how my father was, very dejected and vulnerable and frightened. So I try to be able to take care of them, especially when you tell them the statistics of what is going to happen to them if they don't take care of themselves. But even when they do take care of themselves, there can be significant problems that can happen because diabetes affects every system in the body. Type 1 diabetes shortens your life by 18 years. Type 2 diabetes will shorten your life by 11 years. And unfortunately, people get tired of it. And my own father got annoyed that he couldn't eat some of this. He couldn't have a little bit of pasta. Could he have some ice cream? They had to pay attention to it every day. He's on multiple medications. He has to see multiple physicians for it. But I think that those are things that we can discuss with our patients and help them to understand that and get them out to the right patients, particularly when we think about dietitian. When you're on Medicare and you have a foot ulceration, you can get 10 visits a year with your dietitian at your local hospital. And you know how many patients of mine have taken advantage of that? And I treat thousands of wound patients a year, probably 2 in the last year. They all say to me, "Oh, doc, I know what I got to do." No, you don't know what you're doing, Fred, because your A1C is 14. Or, doc, I starve myself. I eat 1 meal a day. Well, you're eating something because you're 450 pounds. So you see how how do we change that mentality? And my own father went through that as well because he got so annoyed. But he also got annoyed because he didn't understand what he has to do. So when we can get them out to all these specialists and do those things, yes, it's a little bit annoying. They have to see a lot of people. I think that goes a long way to helping them to understand and accept the reality that they have to do these things or they're going to have big problems. In my residency programs that we teach our residents, and I'm a simple guy, I'm a simple man, and I like lists. That helps me to remember things much easier. And so I developed this. I trademarked this phrase, prepare to repair, and all these things that you have to do each and every time you see your wound patient. We talk about a lot of the different fancy schmancy things that are out there on the market to help heal, different types of stem cell skin substitutes. And skin substitutes themselves, there's 220 skin substitutes on the market. It's crazy. There's only a handful of them that actually have RCT data to show that they heal. The rest are 510K, and that's another discussion that we can get into. But for right now, so I always talk to my residents and other physicians, you got to prepare the wound to repair. You can't put tissue on it until you have done all of these good things. And your LCD that limits you that to 4 weeks of good standard of care before you can go into advanced therapy, and then 12 weeks in a venous leg ulceration. And I'd love to know where they came up with that arbitrary number of 12 weeks of just treating somebody. But at least it gives you that time to do these things. And it may take longer than 4 weeks before you can get tissue or do these things on patients, because maybe they come by public transportation like a lot of my patients do. So sometimes it's hard to see people on a regular interval. But I think when you have prepare to repair, and if Dr. McGuire is listening, every time you use this, Jim, you owe me a quarter if you don't mention my name. But Jim's a great physician. He was one of my mentors in school. Just a wonderful person who teaches a lot of students and has really prepared them to reap success in life. So I thank Dr. McGuire if he's on there. But at the same time, these are all these things that I think you need to do. They're not a lot of particular order, but at least obviously the first 6 you should be doing on thinking and doing at every wound patient that you see. I know some people don't like to debride until they've had vascular assessment, but you can debride liberally why people are out getting their vascular testing. But a lot of these, as I've stressed to my resident physicians, when people are in the hospital or they're coming through clinics or when they're each and every time I see the patient, I go through this in my mind. I want to make sure that I don't miss anything for these patients, because even though you may see somebody that has a venous legal ulceration right in the medial ankle, the medial area of the ankle, right in that gaiter area, they have the skin changes, there's varicosities, the inverted champagne bottle appearance to them, the atrophy blanche that is going on, the hemosiderosis, lipometallosclerosis that you are seeing, and you think, oh yeah, this is a venous ulcer. And then it just keeps going and going, and then finally you biopsy, and now you see it's a squamous cell. Or you send it out for immunofluorescence, and it could be a vasculitic ulcer as well. Good medical history is also something else that you need to take I think, in every time that you see the patient, and to refresh your memory on what their medical history is. But I hope this is something that at least everybody, for any chronic wound that you have, will be able to go through this and utilize these steps. And I think it just helps us to make sure that we cover all of our bases. So prepare to repair. And this, again, is the same way that's going on here with the topical oxygen. Great device. But if we're just going to put everybody into the oxygen boat and everybody's going to do well, of course not. Of course not. Just like biofilm management. We have some of the best biofilm disruptors in the world. Non-toxic, kills everything, no resistance to it. But you just can't put that on it, right? You can't get looking at that hole in the patient. You've got to look at the whole patient of what is going on. You and I see patients every day where they come in and say, I put this on, I put that on, I put this on. That's not how we look at this. This is a multifactorial problem that requires multimodal therapy. All wound healing does, and limb salvage and reconstructive surgery, all that stuff. But a chronic wound itself is a multifactorial problem that requires multimodal therapy. So this cyclical diffusion of oxygen is very interesting. All mammalian physiologic processes require oxygen for their homeostatic regulation. All of them do. And this is another little mnemonic that I have trademarked. So if Dan Davis is out there and you're going to be utilizing this, and please mention my name. Otherwise, you owe me. I like 16-year-old Calumet bourbon, actually. So if you don't mention my name on these, you have to send me a bottle of that, and that's very expensive. But it's an easy way that when I relate to physicians, to my residents, and even to patients, to understand why we are utilizing the oxygen boot, because oxygen does care. It affects every phase of the wound healing cycle, and every mammalian physiologic process is going to require oxygen in some concentration or other. And I think it's very easy to understand what the topical oxygen is going to do for collagen synthesis, angiogenesis, resistance to infection, epithelialization, and that sustained healing, and the simplicity that it is to use it. That's another great thing about this. People can just sit in the privacy of their home. They can watch a ball game, watch their favorite program. They can take a nap, and they're relaxed. They're safe. They feel very comfortable in their home. They don't have to travel to a facility for HBOs and things of that nature. And we'll get into some of the differences. And I'm not saying that HBO is not indicated. We still use it a lot when the right indications are met. But every chronic wound could avail itself of this, because every chronic wound is hypoxic. And when you have significant hypoxia, you don't have the cares in mind. You don't have collagen synthesis, angiogenesis, resistance to infection, or epithelialization. We know that multiple studies have shown in the center of a chronic wound that the oxygen concentration is 0 to 10 millimeters of mercury. We know at the wound edge it's 30 to 40, and in some of that peri-wound tissue is 60 to 80. And I'm going to show you how all these different growth factors, enzymes, cytokines that are necessary function at their optimal activity is anywhere from 150 to over 400 millimeters of mercury. So when you have that normal resting temperature of 40 to 80 millimeters of mercury, these enzymes are only working at 50% of their optimal capacity. Oxygen, as I said, is critical in all mammalian physiological processes, and they do so many things for it. And we look at the acute healing cascade. But in the chronic wound, we know that all chronic wounds are hypoxic because all of those cellular components are dramatically reduced. And we need to be able to utilize redox signaling. Now, a lot of you have heard redox signaling, reactive oxygen species formation. Yes, in a chronic wound, oxidative stress is how diabetes affects things. And there's multiple pathways that are accompanied within the oxidative stress paradigm. But reactive oxygen species are critical for growth factor signaling, for cellular migration, proliferation, epithelialization, collagen synthesis. Okay, so thus you can see that all of those factors that I just mentioned are needed throughout this continuum of care. When we look really at what these levels that are occurring within the wound bed, and we talk about that oxygen, first of all, is critical for energy production and cellular metabolism. Critical for that. These intracellular processes, which are critical, such as biosynthesis, transport, cellular survival, are highly oxygen dependent. Enzymes that you need, ATPase, to produce ATP, chemical energy. Otherwise, without ATP, your cells don't produce fuel and they die, and you die. At the same time, when we look at NADPH oxidase, which is necessary for reactive oxygen species generation and pathologic killing by your white cells. And that functions at a very high, its maximal velocity occurs at 300 millimeters of mercury. When we go back into these other cellular processes that are necessary for cell survival, aerobic glycolysis, beta oxidation of fatty acids, the citric acid cycle, if you remember from your organic chemistry class or your biochemistry class in medical school, these are all highly critically oxygen dependent through oxidative metabolism. So conversely, when you're exposed to low oxygen pressures at 30 millimeters of mercury or less, cells switch their phenotypic metabolism into more of an anaerobic metabolism and activate cellular survival mechanisms in which postmitotic cell division is slowed, and we need that for wound healing, reepithelialization, collagen synthesis, dramatically going to be reduced. And prolonged exposure to those low oxygen concentrations without supplemental oxygen, raising them back up to their physiologic process and to their concentration, results in cell death, tissue necrosis, because cells cannot repair spontaneous decay of cellular components, DNA, RNA, proteins, without proper oxygen concentration. At the same time, calcium pumps, which are used to pump and export proteins produced in the ER and ribosome that you need for cell signaling and growth and migration, proliferation, and secretion, they are highly ATP dependent. So when we can't have proper energy production and metabolism, cells are going to die, and unfortunately tissue is going to die, and then we are going to die for that. So, and again, when we talked about this, the cellular signaling capabilities of what is occurring, we know the signal transduction of growth factors is critically reactive oxygen species dependent, as well as the cascade of leukocyte recruitment, angiogenesis, cell motility, and ECM deposition are all dependent upon reactive oxygen species, in which the rate-limiting substrate here is going to be oxygen. We all know that chronic wounds are hypoxic. I've just laid out that for you, and that is proven throughout the literature. Hypoxic wounds, chronic wounds fail to have a clotting mechanism. And that is dependent, of course, upon oxygen too, because we have to bring platelets to those areas that expose collagen. Platelets degranulate, but platelets are an aerobic cell. They require oxygen to degranulate. Calcium pumps, they have to release those granules out as part of starting into your fibrin clot. The fibrin clot then is going to mature into more of a provisional matrix, right? And then into granulation tissue. And what is granulation tissue? But it's collagen, it's new fibroblasts, and it's new angiogenic formation. That's what makes granular tissue. But we know in these chronic wounds that the center of this is going to be 0 to 10. You're looking at 40 around the wound edge, and in the peri-wound, about 60 millimeters of mercury. So we know that these chronic wounds are hypoxic because of processes that have consumed the molecular oxygen within the wound bed. But at the same time, when you get all this slough and necrotic tissue, those are major impediments. Remember that the oxygen getting to that wound is going to depend upon the vascular supply, the arterial PO2, the local capillary structures, and how are they affected, and then the diffusion distance of oxygen that has to get from your circulatory system out to the tissue and to the cell in that microscopic level. Chronic wounds, we know that all chronic wounds not only are hypoxic, all chronic wounds have biofilm and chronic infection. Think of them as being chronically infected. You have 1 billion bacteria per square centimeter on your body. So when you run a swab over that wound, and I know, listen, I get it about the swab stuff. I'm the same way, but you run a swab over and send it out, and it's going to grow some type of probably an aerobic bacteria. When's the last time you got an anaerobic bacteria on a hospital culture? Because obviously biofilm bacteria are viable, non-culturable. There's persister cell, and there's the genotypic variation of resistance within these cells, and they need special testing, whether it's PCR, whether it's 16S ribosomal RNA, to really culture, because a hospital culture only shows you 20% of what is there, maybe even 10%. I've seen some studies that have shown that. But the biofilm cascade and the biofilm production is there. The planktonic bacteria are consuming all the oxygen within the wound itself, and then 98% of the molecular oxygen that is consumed by your white blood cells is necessary for your oxidative burst, but they're consuming all the molecular oxygen as well. So again, another reason why chronic wounds are hypoxic, because the molecular oxygen has been consumed not only by the biofilm mass, but then also by your intrinsic cells within the wound bed, in particular your white blood cells, to utilize that for their oxidative burst, where they're releasing hydrolytic enzymes and bouncing off the EPS of the biofilm as well, not degrading the EPS, but then destroying the matrix components around. So these, when we talk about wounds being stuck in this inflammatory phase, yes, it's the biofilm, the chronic infection, it's the hypoxic gradient that is being forced there, because without proper oxygen and our oxygen cares, we don't have those physiologic processes we need to move this on to proliferation and epithelialization, because we have our local tissue oxygen concentrations are far below the necessary needs to meet the physiological process. Proliferative phase of wound healing, all cells within the wound bed are going to require proper oxygen level. Now, all cells within that wound bed do produce reactive oxygen species for redox signaling. And again, they do that a lot through that enzyme known as NADPH oxidase, which 90% of its optimal activity occurs at 300 millimeters of mercury. And you can't get there without supplemental oxygen to enhance that. So that proliferative phase, not only for enhancing cell migration, but obviously it is for collagen synthesis. And you have to think about collagen synthesis. Oxygen is the key factor for collagen synthesis, as well as the proper organization of collagen. It's the primary structural component of skin. It's 78% of the dry weight of your skin. It's also the primary structural scaffold of skin, and it structures the matrix components for angiogenesis. Collagen does. Now, when you look at the biomolecular level, it's going to be the hydroxylation of proline and lysine residues, which and also the post-translational modification of collagen synthesis, critically dependent upon oxygen. Those oxygen-dependent enzymes, the rate-limiting step in collagen synthesis is prolyl hydroxylase. That causes those triple helical structures then to be cross-linked, and they form collagen fibers. They're secreted. Then as that pro-collagen molecule, those collagen fibers are then going to be arranged into linear fibrils by lysyl hydroxylase. And finally, those linear fibers then are going to be cross-linked by lysyl oxidase, and that's what gives you that final tensile strength of healed tissue. And yes, it's only 80% as strong as the uninjured tissue is our scar, but that's what gives us the tensile strength through these post-translational modifications and the hydroxylation of those residues. Interleukins that you were going to say as well that are necessary, they're signaling molecules for the differentiation and activation of our immune cells. They also function properly in cell adhesion, migration, the maturation, and proliferation of our immune cells are highly dependent upon the oxygen gradient as well. Interleukin-6 that you've heard a lot about in the chronic wound field is dramatically upregulated when you add oxygen into those high concentrations up to 680% above baseline. And interleukin-6 is a major conversion factor from inflammation into reparative processes. Fibroblasts, keratinocytes, endothelial cells are all necessary as well to lead us into the epithelialization and the maturation of our tissue. Remember, fibroblasts, which are going to produce a lot of our ECM components, particularly in that dermal tissue, their proliferation and protein production occurs optimally at 160 millimeters of mercury, which you cannot get to. That's 2 to 3 times normal concentration without supplemental oxygen. Endothelial progenitor cells, which are key for vasculogenesis, endothelial cells for arteriogenesis, dramatically reduced in the diabetic patient because of chronic inflammation and diabetes itself, stimulating endothelial cells to make a lot of inflammatory proteins, reducing the homing of EPCs and their chemotactic capability coming out of bone marrow. And parasites, which line blood vessels, think those are your mesenchymal stem cells. They look like big starfish. They are going to detach, and then they migrate through through the blood vessel system to areas of inflammation and injury, their homing capabilities are dramatically reduced because they rely on nitric oxide. Nitric oxide is a reactive oxygen species. During redox signaling, it's produced in accordance with proper oxygen concentration within tissue. So at that point, all of these phases of wound healing are dramatically perturbed. Oxygen itself can directly stimulate the key growth factor, vascular endothelial growth factor from cells itself. Now, obviously, we talked about the redox signaling. The reactive oxygen species are key for the signal transduction of growth factor and cytokine. But there's multiple growth factors that are going to be stimulated by oxygen, not only VEGF, but you've heard of PDGF. PDGF stabilizes those matrix components within the vessel wall, particularly collagen 4. And if we don't have proper collagen synthesis, we can't have stabilization of the new vasculature because they become leaky, they become friable, they become permeable, and therefore non-functioning. So oxygen itself can directly lead to the stimulation of VEGF release from neutrophil, macrophage, endothelial cells. Because remember, wound healing angiogenesis requires inflammation. Your white blood cells are necessary not only for cleaning up these necrotic tissue, damaged tissue, and pathogen removal, but they're necessary for stimulating the angiogenic cascade. And they function, obviously, through NADPH oxidase at that high functioning fraction that you need to have proper oxygen concentration for them to function, which is well above 160 millimeters of mercury, optimally around 300. Collagen synthesis, of course, we know the recurrence rates in diabetic foot ulcerations, but at the same time, when you look at Mason trichome stain here, that we have major increases in collagen deposition. And the rate limiting step in the collagen deposition is going to be the concentration of oxygen we have, because the higher the partial pressure of oxygen we have the greater the depth of collagen depositing within that tissue, the thickness of collagen, and the increasing fold or the increasing rate of collagen. I like to use nasal oxygen on my in-house patients at 4 liters per minute. I start a day before surgery, and sometimes 2 days if they'll tolerate, and continue after I have to do a surgical procedure, because studies have shown we increase collagen deposition 2 to 3 times greater when you do that. So think about nasal O2 on your in-house patients that have wounds, that have infection, that have osteo. You're going to do surgery on it. There's some pretty significant papers on there to show that we increase that deposition up to 3 times greater when people are just on nasal O2. So it's something good that you can do while your patients are in the hospital and you're doing all those things. So the topical oxygen itself, this is an FDA-cleared device. It's a CE mark in Europe as well, and we use it for all kinds of things. And especially also, too, it's a great one to use is for radiation ulcers. Radiation ulcer, yes, there's an indication HBO, and I try to get patients into that. But patients don't want to have to travel. They don't want to have to be there for an hour and a half, 5 days a week. And if they can't do that, or they don't want to, this is a great alternative to that. I have a bunch of posters at SAWC coming in spring showing the use of this in radiation ulcers, which is a very difficult wound to take care of because all the tissue and cells are destroyed. It's radiated. It's like a 3rd-degree burn going on there. Tremendous fibrosis, lots of biofilm, chronic infection, lots of inflammation. And there are several differences between the two. Yes, there is clear indication for HPO. I'm not saying that this is going to replace HPO, not in the least bit. Okay. But there are times when people don't want to have to travel, and there's just flat out, they don't want to. You know how these people are. They got to see a million physicians. There are a million different types of medications. Traveling could be another expense, especially with the cost of gas now that's out there. So this gives people that great viable alternative. And not so much are we worried about their vascular supply. Yes, you always have to think about that, right? We always want vascular studies. People have problems. You get them over to your vascular surgery, your IC, your IR people. Great part of the limb salvage team. That is true. But at the same time, we're bathing this at 10 liters per minute. We're getting up to pressures of 800 millimeters of mercury. So you have to think about the vascular supply, the arterial PO2, the local capillary structure, and then the diffusion distance that oxygen has to travel when you inspire oxygen. Here, we're placing it right into the wound at 10 liters per minute. That gets to very high partial pressure of oxygen for these people. And yes, and there are different things that are out there. I mean, they're all not the same. I did some clinical studies with EpiFlow, especially. That was a real pain. Putting that thing in and that portable carrier had to be built into the bandage, and the pressure, they got very macerated from it. So there are multiple differences that you see, and we're talking about this cyclical constant diffusion of oxygen. Simple, easy to use. It's a boot that goes onto their knee. They can sit and watch their favorite program, and they can have their wound being bathed in oxygen, correcting all the physiological perturbations that are going on due to wound hypoxia. And I think that it has these great effects, and we're going to get into each one of those. We went through ad nauseum about the physiological properties that oxygen is going to be able to do for you, and of course the compression and the humidification, because obviously the benefits of oxygen. Remember that oxygen cares, right? So we're going to correct the collagen synthesis problems, the androgenic cascade, the resistance to infection, and the epithelialization. But a great thing about this is you don't have to remove stuff to utilize it. I have people in total contact cast. We're putting the boot right over the top of them. We have people that are multi-layer compression for venous ones. The boot's going right over the top of them. Yes, it can perfuse. And I know you're saying, come on, through a cast, they have tremendous amount of information to show that. Because listen, I don't believe anybody. I have to see for myself. I have to read for myself, and then I have to use it for myself. And I'm telling you what, when you look at the oxygen studies that they have of that under casting, it's pretty amazing to see that this is able to diffuse through there to get to that wound bed. So you don't have to take off the cast. You don't have to take off the multi-layer compression bandaging, and you can still utilize them bathing at 10 liters per minute. Compression, we said edema. Edema slows down oxygenation to your wound tissue. You have these arterioles in the skin, and the more you swell, the more you pull apart those arterioles, greater the diffusion distance oxygen has to go to the wound healing. That's why it's part of prepare to repair, is we got to control the edema factor. You'd be surprised how many people with venous leg ulcerations that I have seen that never had a multi-layer compression bandage. There's level 1 evidence for multi-layer compression bandaging in the treatment of venous leg ulcers. Level 1 evidence. I think there's 4 RCTs to show incredibly increased risk of healing when you use multi-layer compression. And I've known multiple people that have venous, just like I know multiple people have come with chronic wounds and never had an arterial study done, or a diabetic, smoker, who have autoimmune disease, vasculitic processes, or just for their age is a risk factor, obviously, because as you age, your cells become more inflammatory and develop plaque, but never had a vascular study. So again, this gives you about 30 to 40 millimeters of mercury compression. It's a cyclical compression. It helps to move the edema out, which then allows greater oxygenation and shorter diffusion distance for oxygen to go to get to the wound. Humidification, you can turn this on, you can turn it off too, is another good thing. You got a big, heavy draining venous wounds. I like to reduce the humidification for it. Now, when you look in prepare to repair, there I have a section on moisture balance. I hate when people say that they told me to leave the wound open to air. Now, we've known since 1958, people, that we don't leave wounds open to air. 1958 were the first blister studies to show that. You're 90% water. You have to have the proper moisture balance to facilitate cell migration and ECM deposition. That's not to say we let them take showers and put cytotoxic soap and have them bathe the wound and all the bacteria that's coming off their groin and their axilla and all the nooks and crannies around and soaking it in that cesspool and driving that bacteria in there deeper, macerating tissue, because nothing migrates. Good cells don't migrate when tissue are macerated. So there's a very fine moisture balance that you have to foster. But this has the added benefit of adding humidification to the air, because yes, oxygen flowing there can be drying. So you can have the added benefit of moist wound healing. So it's a simple thing. It's easy to use. You don't have to remove dressings for it. You can put it right over your cast. People are right at home. They feel comfortable. They're relaxed. They're eating good food. They're not in some rotten rehab facility eating cold food that's dried out and it's like rubber. So they feel better at home too. So the compliance factor is through the roof to utilize this. That's great. We told you all about the science that it has, and every mammalian physiological process relies on oxygen for its homeostatic capability, and it fuels all these intracellular processes that we need through the whole healing continuum. But can it prove itself? Can it have high quality of evidence to say this is what it's going to do, and this is actually what it has done? Can we do that? So they did a lot of these studies that I'm going to go through before, and which was a great thing. They did the research, they did the studying for it to prove that its utility and its capability of fixing this problem. You and I know that every time we see a rep comes in and they say, "Oh, here's a case series that we did," or "This is an case report," we know that's garbage. We know that's the lowest on the evidence-based ladder. If you don't have anything better than that, what are you supposed to take home from that? Because there's a major risk of bias in that. How do we know that what is it controlled? Are things the same? Did they use this dressing as opposed to this one? We have no idea what is going on. So when you see these individual case report or a case series, you're like, you take it with a grain of salt. Okay, so I just wanted to explain that real quick so people understand, because a lot of companies are doing case reports and showing these individual case series, which are really not that great to prove that something can do. Yes, you do need to do RCTs. I'm not a smart man when it comes to statistics. I hated that class in college. But at the same time, how many times have you read a study, you look at the abstract, you look at the introduction, and then you go right to the discussion? We don't understand the material methods. How are things set up? How are things perpetrated? What's these confidence intervals and the risk ratios and the hazard ratios for all this stuff? So I encourage you to look at this, to go through these, to get a book on statistics. I had to go back to read that because I was writing protocols. I'm doing all these clinical studies. I'm fortunate to be a PI on over 20 RCTs. So you have to, and I've written several. So you have to understand what is going on, how this is being set up, how it's being perpetrated. Is there some kind of bias in this, in the selection, in the performance, in the reporting, in the detection, in the attrition rates? Is there something going on with those? So I encourage you, before we go into that, please, if you get any chance and you want to understand these clinical studies and give you better ideas, and then makes you a better physician when you get that. So one of the studies they did was right here in diabetes care, one of the highest rated studies that was ever performed. Okay, in diabetes care is a well-known journal. It goes all over the world. And this is a level 1A evidence. This was a multinational, multi-country study that was done. 17 centers, US, UK, Ireland, Belgium, Germany, Luxembourg, I think too. But there was 17 centers, a multinational, double-blinded, randomized controlled trial. The sham control was the placebo control, to see what kind of effect. Can it heal? Did we have a secondary endpoint? Did we have improved healing rates? What's the recurrence rate from this? This was a very good study. These are the baseline characteristics, the demographics of these that were done, so that you can see all the things that they went through to give you this high level of evidence to prove that. And this, when you start to look at the healing rates from this in the active versus the sham group, when you look at what is the likely healing, the odds ratio of this. Now, when this was finally adjusted for the classification of the ulceration, the treatment group got the worst ulcers according to the UT score. Okay, so they actually had worse ulcers to treat once that was randomized into that UTC classification. And when you look at the Kaplan-Meier closure estimates, this is how well they think that things are going to do. When you utilize topical oxygen for this in this continuous diffusion way, you were 4.5 times the likelihood to heal over 12 weeks compared to your sham arm. I think that's very significant. And what's the durability too? Because all the times you can do these clinical trials, or people show you these, I put this tissue on, but look how great it looked. Yeah. Well, what's the picture 6 months from now? How does it look? Was there a recurrence rate? Did they get an infection? You don't want to just see that it's healed one day and then that's all you hear about. What is the durability of this? Can we protect that recurrence? Because we know diabetics have 40 to 50% recurrence within a year, even with proper shoe wear, with proper diligence. And so I do a lot of fat injection for these people. But at the same time, we know how high the recurrence rates are. So when you looked at the recurrence rates of these after 12 months, only 6% recurred within the treatment room, whereas the sham group had significant, the normal, I should say, healing recurrence rates that we just see in diabetics. When you look at the real world evidence study that's going on, yes, RCTs are great, but the knock on them, these are medically optimized people. What's it like in the real world when you see people come in with tendons hanging out and bones hanging out, and they're on dialysis, and they have sugars of 14, and their toe brachial indice may be 0.5. All right, that's what we're seeing every day. We're not seeing these medically optimized people all the time in one center. And they publish this in Advances in Wound Care, which is a great journal. I advise you to get that and read that, and you can see. But look at in the prevention of hospitalizations and in amputation levels from that in this real world evidence study. And when you dive deeper into this study and you look at these unmatched and matched individuals, as you can see here, these are unmatched. These are just taking the comers and let's see what happens with these people. The amputation rates, hospitalizations are significantly reduced compared to people that didn't get any oxygen. And at the same time, when they matched these people and in comparison so that they were equal, practically you had the same recurrence of these things and the reductions in hospitalization and amputation as you did in the unmatched individuals. And then, of course, when you look at the logistic regressions for these people, it had a major positive impact upon their quality of life, because when you got, if you did not get oxygen, you were almost 9 times more likely to be hospitalized and almost 5 times more likely to be amputated compared to people that had, and this is consistent, people that had oxygen, this is consistent with what we see in the RCT data. When you look at another meta-analysis done by some very learned people in this field. So when we talked about the topical oxygen for it, and we look at the grade, it got a high grade of evidence for it. We look at these confidence intervals, look at these risk ratios, and these are very significant for the outcomes that are perpetrated by doing topical wound therapy oxygen. When you look at systematic reviews, 530 patients, good Lord, 6 RCTs that they were evaluated to see. Look at the risk ratio. What is the confidence interval for these patients? And when you say that is the only study, that one published in Diabetes Care in 2020, being that only study that was awarded a perfect 100% score because of the rigorous performance of this RCT, the non-biased risk that was there, gaining that proof to show that things can do what they say that they can do. When you look at Thanagamiani's name, love that name. When he looks at his systematic review of diabetic foot ulcerations as well, this got a perfect score, obviously, from Diabetes Care and from the Cochrane as well, because it has that rigorous evidence behind it and that showing that these things can do what they actually say they can do, improving them. And now when you look at consensus things, and I get it, I know the knock on consensus, I'm the same way when it comes to consensus panels. Who's on that panel? Are they speakers for these things? Or do they do research for them? Are they being paid as a consultant for them? Are these the people that are being giving their consenting for this? But these are some very learned people, high publishing capabilities that they have, hundreds and thousands of articles total of all of these people have been published. All these men and women here are very learned people with great publications that they have out as primary authors. So there's something that is going on in this community in order for them to come out and encourage you to take a look at this therapy and utilize it for every patient that has a chronic lower extremity wound. And how about in venous wounds? I think venous wounds are the scourge of the lower extremity market. 93% of these are open longer than a year. 7% are open longer than 5 years. 3% of the world's population has a venous leg ulcer. When you look at over 65, that goes to 6%. It's the most common lower extremity ulceration that you're going to see. And it's very, very difficult to treat because people got to work. Nobody can sit on their butt for 12 weeks, 16 weeks, 18 weeks and keep their leg elevated. Truck drivers, cashiers, teachers, principals, electricians, plumbers. I have a lot of people have venous ulcers and they are very difficult to treat. But here, when we did that's when we look at this RCT that was done and we see that go back to that and see that they have the follow-ups of these show that they continue to heal and another thing with venous leg ulcerations, you got to have a venous reflex study. And if there's incompetency, it's got to be fixed. If there's ablations of greater saphenous or lesser saphenous, there's sclerotherapy that needs to be done. You have to do that because your healing rates are about 20%. If you're lucky to get it healed to stop that venous hypertension, recurrence rates are over 80% within 3 months. So again, get a venous reflex study, do some ablation, sclerotherapy, multi-layer compression bandaging as well, which is often underutilized and not used for these patients. But 15% of this population will have significant arterial disease, so you got to make sure that you get your vascular studies as well. So correlating that all together, when you start to look at the confirmation of these systematic reviews and the meta-analysis, I think that it's overwhelming. You have high level of evidence here to show through RCT data that you have 2 times greater likelihood of healing these wounds than just standard care alone. And that's very significant. That is very truthful, and it's very, very understanding because oxygen affects every phase of the wound healing system. And every phase of that wound healing system is perturbed by the hypoxic gradient that is occurring and stopping these physiologic processes. And it's a great thing to use. I do it a lot. We're using it when we start to graft, when we start to do flaps, and we do things for people because I still think the best skin-to-skin closure is if we can get skin-to-skin closure instead of utilizing graft tissue. But when you can't This is an excellent modality to enhance the cellular signaling capabilities. It's significant to enhance the protein production, the collagen synthesis for that, the removal of bacteria. And of course, it's necessary to enhance proper cell migration of both fibroblast keratinocytes and endothelial cells to bring this wound to closure. It's backed by multiple societies as well, now that are seeing the benefits through the high rigorous studies that have been done, and they are also putting their gradings upon that. So that's why I think it's time that we have to start looking at the role that oxygen does play within all of our physiologic processes, because all of these physiologic processes of wound repair require high levels of tissue oxygenation. So when you think again about how oxygen cares and that it affects all those systems, remember that those biomolecular pathways of wound healing are positively correlated to local tissue oxygen concentration. The maximal activity of growth factors and enzymes and cytokines and those resultant physiologic processes are occurring at a lot higher levels than you would find in normal tissue. There's a positive differential effect that you utilize when supplemental oxygen is necessary, even in ischemic and compromised tissue flow. So when you increase supplemental oxygen in the wound, you're increasing not only the rate of wound repair, but you're improving and increasing the quality of your tissue repair. So please think how oxygen cares, but remember, it's part of the bigger envelope. Prepare to repair. You have to do this each and every time. I'm a simple man. I think this is a simple list for people to understand, for to comprehend, and to utilize every time you see your wound patients, your limb salvage patients, because otherwise something is going to get missed. And with that, I thank you all for taking busy time out on Sundays. It's a beautiful day, and I got to take my daughter back to college, but I appreciate the opportunity to relay the information on what oxygen can do, because oxygen cares. Thank you, Rich.
That's awesome. All right, hit escape.
Hit escape.
Yep. Close that PowerPoint out.
Okay.
Perfect. Wow.
So
do you breathe? Do you take in oxygen, Matt?
I know, right? Well, there's a lot to get to, isn't there? There's a lot to talk about, right?
Cool. All right. So what about chemical compounds that have oxygen releasing property? Is that okay?
Well, I mean, I don't know if it's been studied in RCT fashion, if it has some good RCTs behind it, and it can prove what it can do, and it has that validation. I haven't seen anything about those other ones. I haven't seen RCT data. But I mean, as far as oxygen goes, I haven't seen of any adverse events of putting oxygen into a wound, even at very high concentration. Mm-hmm. So this, I'm again talking about into the wound, not inspired oxygen. So I would just hope that it has some RCT data if you're using it to prove that it can do what it says it does.
Dr. Mannheim commented, can you comment on how frequently the patient is supposed to use 2-2, right? 2-1-2.
Fusion oxygen, right.
That only receives 5 bags per week.
Right. It's 90 minutes, 5 times a week. Now, I've had patients that have done it twice in one day. But at the same time, it's, again, 90 minutes, 5 times a week. And most of my patients are, again, being 70s, 80s, retired. Now, we are having younger patients, and we have patients in their 40s and 30s now that have venous leg ulceration that we've used it on, and they will do it when they come home from work. Yes, that can be a little bit of a time constraint, but it's, again, the compliance aspect is through the roof because you can do this right in the comfort of your own home.
What about Medicare? Do they cover it?
Right now, I know it's on a bunch of Medicaid. Okay, they're going through the Medicaid. New York, Massachusetts, New Jersey, Arizona, Texas. Yes, they are also in the VA system, right? They're in the FSS and all that stuff. Mm-hmm. But they will be getting this through Medicare. That's my hope it is. They have great reimbursement people that are working on that. But right now it's through the Medicaid and through the VA system. But it will get there. It will get there. It's got the proof.
Dr. Cusack asked, do you have any experience with Electra?
No, I think that's some kind of an oxygen releasing dressing. I have not used that. No.
Okay. Is multi-modal topical oxygen therapy covered? Oh, it's covered. We did the insurance. What what documentation is needed to get it covered? You know?
Well, I mean, the patients that I have used it on, they do require your charts, your notes, right? You have to send those in. no matter what you're using for wound healing, you got to have really good documentation. You should be documenting pre and post debridement. What's the depth of tissue, the pre and post debridement size, the depth of tissue you're removing, what's your offloading, what's your multi-layer, how's the vascular status, what is their hemoglobin A1C, what kind of nutrition are they on, what is their smoking history or illegal drug use, all that stuff. So you should really always, normally, no matter what you do, have really good documentation. But they do require your notes for that I've had to submit my notes through AOTI for them to get those things approved. But you should always have good documentation anyway on your wound patients. Even when you order dressings, alginates, collagen, foams, you have to have good documentation for that. So it should just be part of the norm.
How widespread, Dr. Schwartz asks, how widespread is the usage of this device at the wound care center?
Well, right now it's not in the wound care center. People are using it in their home.
Okay.
All right. So that's the beauty of it. And I think the compliance factor obviously is through the roof because you're at home, you're comfortable, you're relaxed, you're not in some dump rehab facility or something of that nature with cold food and nobody talking to you and you're all by your lonesome. So you're using it this at home. This is a home device that you utilize.
During a procedure, sometimes we use sterile H2O2 to reduce bleeding. Is that okay to use on DFUs as well?
Hydrogen peroxide. I mean, in a pinch, when I've had nothing else in the ER or something, I've dumped peroxide on draining abscesses and stuff like that till I can get into the OR and opened up. I know there has been I've heard some things of hydrogen peroxide and gas embolism and all that, but I mean, I used it previously in an emergent position, but as far as I know, it seems pretty harmless to myself, obviously in a wound setting.
Okay. Do you recommend L-arginine to promote, that's right, L-arginine to promote dilation and vascularization of chronic wounds?
When you look at prepare to repair, nutrition plays a huge part of wound healing, a tremendous part. I have vitamin A, C, and D. I do vitamin A for 2 weeks, people, diosmin, hesperidin, and the protein fraction, right? And there are different proteins out there. There's a new one called Expedite. It's a 2-ounce bottle. It looks like a 5-hour energy shot. These are different types of peptides, prolyl hydroxyproline, and then hydroxyprolyl glycine and L-citrulline. So these are designed to attract fibroblasts for healing. And it's only to be used because it has 10 grams of sugar, and you got to watch. But it's designed to be used during that ulcer period. We use that in the hospital. People can buy that now on the outside, but they can also get Expedite gelatin, which is sugar-free. So I do use a lot of that when they're in the hospital, and if they're outside. If they can't get it, we do juvenile lot because that's L-arginine, nitric oxide. Not only nitric oxide is a dilator, but it's a potent stimulator, especially for endothelial progenitor cell. So look at the type of protein that you're using, but protein is needed because their body's under a lot of stress. They're in a hypermetabolic state right now, so they require lots of energy. And if your body doesn't have enough protein, it robs it out of the muscles. So you utilize that to feed your immune system and your healing cells and can make you weaker if you don't have enough protein. So protein is critical for healing of wounds, yes.
Dr. Boyuka, is there only one company that does this, or are there any other vendors?
This right now for oxygen boot formulation is the AOTI people. That's the only one that I am aware of. There was other devices that I shown on those, the Natrox, the EpiFlow, those other ones, but as far as the boot with the oxygen concentrator, it is only AOTI that I'm aware of.
Okay. Do we have any additional questions for Dr. Rogolski? We got about 2 more minutes. So if anybody has one.
Yeah, I mean, I think it's, we talk about oxygen. It's the 3rd most common element in our universe behind hydrogen and helium. Yes, 300 million years ago in the Carboniferous period, it was up to 35%. Now it's at 20%. But, it's needed in every phase of the wound healing cycle. Now you have something that's simple. Every wound is hypoxic. So it's something you can add in your armamentarium that can really help people. Mm-hmm. Listen, I'm as skeptical as anybody else on all the stuff that comes out. People say there's until I can read their evidence, if they have high level, and I can use it myself. Mm-hmm. And we've seen some pretty dramatic things. But again, you have to prepare to repair. You just can't say everybody puts on the oxygen boot, everybody's going to do great, don't have to do anything else. You still have to do all those good things that you've been taught to do and prepare to repair to produce epithelialization. So even when you do all those good things, there's problems. Mm-hmm. Because we don't know all about the wound healing cascade. We really don't know all about it. That's what's fascinating.
And you have patient compliance issues as well.
Huge. This is great. You can sit at home, watch a ball game, take a nap, knit, crochet, I don't know, write a letter, talk on the phone, do something. And maybe there's somebody that are home smoking while they're on it. I wouldn't be surprised. But how easy is it to do right in your house? Just right now, you're comfortable, you're relaxed. You're not in one of these rundown rehab facilities and nobody to talk to and things. Cold food all the time. You're sitting at home, you're comfortable, and I think that has an additive effect as well.
Yeah, and I think you touch on a really good point. It has some psychological advantages,
right? But yeah, you're home. You're not in a rehab facility. It's easy to use. You don't have to travel to a place to do it. You don't have to rely on somebody to bring you or public transportation. You're right in your house. They come to your house. They bring the concentrator. They bring the stuff. They show you how to use it. They sit there with you for your first treatment, and then they supply you with the boots and everything. It's great. They're going to have some new innovations coming out where the patient will be able to talk right through it to somebody that's watching them. They're going to have some things they can watch and see how many times the patients actually use the device too. So there's some really cool things that are with it. And you as the physician, all you got to do is order it. Have good documentation, why you need it, what's going on with the patient, do all those good things and prepare to repair. But this is something that could be used by every patient that has a chronic wound on the lower extremity.
As always, fantastic to see you. You're the best.
Sir. And thank you very much. I was very honored to be here in the company of such learned people. This was great, Rich. And if anybody, my email was on there, mrogolski@comcast.net. If you'd like to talk about things and discuss stuff, call me an idiot. It's okay. I don't mind good debate. So please feel free to email me anytime.
Matt, always great to see you, my friend.
Thank you, sir. Have a great day.
All right. Be well.
Thank you.
All right.
Awesome.
So I want to thank all of you for hanging on for 2.5 pretty long days. I know this probably seems kind of light at this point. We got an hour left and it's going to be 3:00 and we'll be done. And yes, John, it's the final lecture. But I just really want to express my gratitude, my appreciation. I thank all of you for being involved with the No Nonsense seminar, for being engaged, for participating, for everything that you guys have done to make this a success. We can't do it alone. Yes, we need great speakers, and yes, we need the platform and all of it. But we don't have an event without the attendees. And yes, Corinne, we're going to be doing some additional events. We have a 6.5 credit CME lymphedema event coming up next month, actually with the ILWTI, the Lymphedema Wound Care Institute. We're going to collaborate. We're doing a biomechanics event. We're going to be doing a large event as well. We're looking at doing a 25 CME event in the fall, similar to the No Nonsense. So keep in touch with us on that. The best way to learn and know what we're doing is click follow me on this platform. We send out invitations and emails to everything we're doing. Make sure you're connected with us either on LinkedIn or wherever. Also, if you've enjoyed the event, if you have learned something, which I hope you all have, feel free to share about what we're doing everywhere. I want to share this with the world. I want to get us up. We had, close to 500. I want to get up to 1,000 podiatrists online. But without further ado, I know you guys don't want to hear me. You've heard me now for 2.5 days. I'd like to introduce Ian Griffiths. He's Director of Sports Podiatry Limited in the UK. And I'm going to load up his lecture because it was recorded. And opioids and child abuse. Yes, the other thing is I want to say, if you have ideas, input, expertise, comments, send them to me. We look at everything that's going on. I don't know if I told you that we do have 2 MOC credits for this event that were approved as well. I know some states need MOC credits. Your certificates will be handled by us. Don't worry about that. If you've gone in and watched sessions that you've missed, just send me a message. I'm very accessible. I don't really know that either, Pardis, but it was requested. I think it's something in Ohio. But I'm going to load up his presentation. Any questions, any concerns, anything that comes up, and I'll get back to everybody. As you see, I am accessible and responsive. So this is only going to be a 45-minute presentation, and then we'll put up a my email. I'll give you my personal email. It's richdubin@gmail, RICHDUBIN @gmail.com. If you have an idea for an event, or you have something that you'd like to message me, email me, my cell phone number, I'm very accessible as well. It's on all of my information. So any way you need to get in touch with me, please do. We really want to hear from you. We want to know that we're delivering the best education that we can in the best format that we can. As a matter of fact, I was just talking about a financial event. So there's some things that we have on the table coming out that we'll keep you apprised of. Again, the best way to find out and learn what we're doing is to keep in touch with me, follow us, sign up for LER, whatever it is that you need. Just make sure you get all our messages. We don't bombard you with promotion. We just keep you abreast of what we're doing on the educational front. So that's where we live. So I'm going to key this up. I'll be back on after it's done and can answer any other questions.
Hi there. I'm pleased to meet you. My name is Ian Griffiths. I'm a podiatrist and university lecturer in London, England. And I'm so sorry I can't be there live, and I've had to pre-record this. But I'm still hoping it encourages some discussion and some chat. And I'm going to leave my details at the end so you can get in touch with me and ask me any questions that you may have. It's an intentionally, I wouldn't say controversial topic, but it's a topic that when I've spoken about it, it often raises a few eyebrows, and that's a good thing, I think. And I'm going to be talking about whether we should be considering colour when prescribing foot orthoses. And this is very much a question. So as it will become clear, we don't have enough data to get too excited about this being something we should definitely be doing. But I think we have enough research in the world of colour psychology away from foot orthoses that we can then see how that may apply itself to what we do, and ask the question as to whether it's something that we haven't been considering that perhaps we could or we should, and the reasons for doing so. I do hope you'll forgive me throughout, and I ask for your forgiveness in my British spelling of the word colour through the presentation, and I hope that won't upset anyone too much. So let's progress the slide. When I'm sure I'm no different to anyone that when I'm prescribing foot orthoses in clinic, it's always, almost always, if not 100% of the time, in the context of a human entering my clinic who's in pain, and their pain is clearly got to a level or to an intensity where it is starting to interfere or prohibit their ability to perform something that's important or meaningful to them. And that's the kind of solution they're looking for, some kind of way that they can get back to doing the things they love. And when we make a decision that foot orthoses are one of the tools that we're going to use, usually as a smaller part of a wider approach, a multimodal approach. But nonetheless, we make a decision that they are going to be prescribed. We are, really gauging their success or our clinical outcomes on whether they change that pain experience in that human, whether they allow that human to return to their meaningful activities and tasks. And I don't think it's unreasonable. I don't think it's controversial for us to say that we are not in a position where we are absolutely certain before the fact who is going to be a good candidate and respond well to these devices and who isn't. I don't think that's unreasonable to say. And even when we do give them to individuals and we find that they've had a good experience, they've had a reduction in their pain levels and they've been able to return to their functional tasks, we can't always be absolutely certain the mechanism of effect that's occurred there. We know that orthoses have worked. We can fairly easily measure whether they have worked, but we don't always know how they've worked. And I think we can all agree that understanding that as best we can, or better than we do, is going to help us identify good or bad candidates before the fact, and hopefully help us manipulate the way we design these things to further improve our outcomes. And I think we all have that common goal that that's something that we would love to do. So when we're making clinical decisions about how to design these things, and we've certainly spoken to our students about this, and we sort of say, okay, tell us what your thought processes are. Have a think about what you're trying to achieve, and have a think about how you're going to write your prescription and design this thing to best give it the chance of working or helping who you're giving it to. And it's not uncommon when we have these discussions that students are often giving really deep thought to what sort of material should I use? Should I use carbon fiber or EVA or polypropylene, and the different material properties and the pros and cons of each, the different stiffness or load deformation characteristics, and how they will generate different orthoses reaction forces, all completely reasonable thought processes. The addition or the inclusion of an extrinsic post or an intrinsic post at the rear foot, and the implications that has for the bulk of the device and whether it fits into a running shoe or a football boot. And again, the intrinsic versus extrinsic post will dictate, they will modify the stiffness of the device further forward, as well as research has shown us. The geometry or the morphology of the shell and what that should look like and why. And ultimately, when it comes to the top cover, most decisions are usually, how long should it be? Should I end it 3/4 length at the distal shell so I can give people versatility in fitting it into many shoes? Or shall I bring it full length and make it more cushioned and think about what material I should use and how durable it should be, and whether any forefoot additions should be included within that? When we ask both students, but also we've done surveys, we did a survey of over 800 podiatrists in the UK. When we ask them whether they consider the colour, the overwhelming majority say no. They just don't consider it. And when you ask them why is that, they just don't think it's that important. And I'm not saying that's a wrong opinion to have. It just seems to be an incredibly quick throwaway comment when we give so much thought and attention to lots of the design features of these things. And we've got a fairly easily modifiable design variable, which is the color of the top cover. And we seem to have very, very quickly dismissed it as being important in any way, shape or form. And what I want to get people thinking about is whether we should be so quick to dismiss that. And if not, then what are the reasonings for even considering it in the first place, and what might guide our decisions on various colors as well. So why color? Well, like I say, outside of the world of podiatry, the big wide world out there, there is an incredible amount of published research on color and color psychology. And it is undeniable, it is not even up for debate, that color has a significant influence on human thoughts and cognition, on human emotions, and on human behavior. And this happens every day around us, whether we are conscious of it or not. And there are various things around us that are doing this by design to exploit our reactions to color, as we will come on to talk about. So color has a significant influence on all of these facets of essentially what it is to be human. Why do we care about this when we're giving foot orthoses to humans in pain, like I've already said? Well, because pain is not just a reliable barometer of the status of our tissues. A contemporary understanding of pain, as I'm sure many people know, and it's widely accepted now, is that pain is a biopsychosocial experience. It's complex, multifactorial, emergent, and individual. And it's occurring within the human body, which is a biopsychosocial ecosystem. Just a fancy way of saying, as a human, we exist within the biological, the psychological, and the sociological domains at all times. We are being influenced by, and we are having an influence upon, and we are interacting with facets of all of these domains at all times. That is what it means to be human. And pain is a biopsychosocial experience, meaning it is not just dictated by our biomechanics or by our tissue loads. I'm not saying those things don't contribute, because of course they do, but our thoughts, our feelings, our behaviors, our level of understanding, our previous experiences and our expectations, all of these things have been shown to have a really strong correlation with our pain experience. And if color can change these things, and these things linked with pain, I don't think it's unreasonable to think that color may have an influence on pain. And we're going to come back to that concept shortly. Like we said, we ask students, we ask practicing clinicians within the UK setting at least, what they're thinking about when they're prescribing orthoses for a human in pain. And it's very, very biomedical. It's really thinking about the design features of this thing and how it may well influence the biomechanics. And it doesn't seem to be considering anything else about this device that may well be influencing some of the other variables. Not to mention, of course, when we talk about the social things like religion and cultural context, and color has a really strong cultural meaning in different parts of the world as well. And color seems to be the variable, quick and simple to change, that may well be having an influence on psychological and sociological variables, as we're going to come on to talk about. This was a famous quote. It'd be really impressed if you know who this is. And this was someone saying, "Colors, like features, follow the changes of emotions." This was from Pablo Picasso, who knew a thing or two about color. And he is not the only artist through time and through history. Many artists have gone on record quoting just the strength and the importance of color and how it can significantly influence human thoughts, human feelings, humans' emotions. And I think, that isn't an unimportant thing to consider, yet in the medical field, we're not always thinking along those lines. It shouldn't surprise us if we think about all the senses we have as a human, and we look at the amount of information that the brain processes, and then we look at the data that tells us 85% of the information processed by our brain comes from our vision. So it's an incredibly important facet of of our worldview and how we interact with our world. And let's not forget that although orthoses clearly have influences on the biomechanics of a human, and we're not suggesting they don't, when we first put them in a shoe and they feel strange and odd, but hopefully comfortable, it shouldn't be uncommon, and I'm sure most of our patients will tell us that after 2 weeks, or perhaps a bit longer, but after a certain period of time of wearing these devices, they will get used to them, they will adapt to them, they will find them comfortable, we hope. And they will ultimately say to us, "Oh, I feel good, I've forgotten they're there. I don't feel that they're there anymore," which is a great sign to suggest to us they have adapted to them and they are tolerating them well. When they don't feel them anymore, then the only reminder they get they're there is every morning when they're looking down at their shoes before they go to work and they're putting their shoes on, the only thing they can see is the top cover. They can't see the rear foot post, the shell, the posting. They can't feel it anymore because they've adapted to it. They can't feel these things, and the only thing they see is the color. And I think we have possibly been underestimating the potential value for that, which we'll come back to in due course. Here's another famous quote. See if you can get this one. I'll be even more impressed if people get this one. But it's just another artist just really highlighting and using color to express emotion and express feeling and thought. The rest of the world was black and white, but we were in screaming color. If you got this, then you are a fellow Swiftie, as Taylor Swift fans allegedly call themselves. Taylor Swift, an incredibly well-known and successful artist, and clearly has a penchant for color. This is the majority of Taylor Swift's albums that she's released, and her reference to different colors in the lyrics within each album. And again, I think you can clearly see she favors red and then possibly blue and then possibly gold. But an artist, once again, just really using the power of words and the visualization and the emotions and the responses that colors evoke in other people through her art. There's one Taylor Swift album missing there, and I'll be reading, to prove you're a true Taylor Swift fan, if you stick in the comments the album that's missing, then you can prove to everyone what a genuine Swiftie you are and join us all on Reddit. I'm not a Taylor Swift fan, I should just add. Taylor Swift aside, what else do colors mean in the real world? Colors are often used, both in nature and by design, to highlight warnings. In nature, there is a phenomenon called aposematism, and this is animals and creatures and mini beasts essentially using color to give warnings, usually to predators, to say, you don't want a piece of me. If you eat me, it will not be good for you. They are trying to defend themselves by using color to warn things away from them. And again, when we're walking around and we see little creatures and beasts of various colors, it may well make us think twice about their level of toxicity or how poisonous they are. In the built-up Western world around us, these similar warning colors are often used by design to, again, exploit our reactions to these colors and get us to behave or conform or act in a certain way. So red is often used to catch our attention and as a warning and as something we must obey. And yellow and black often catch our attention as something that is potentially toxic or dangerous. We just wouldn't have the same responses to warning signs or labels in different colors. So this is going on around us, and it's something that we have just as a society sort of begun to accept, and we now interact with these colors on a daily basis without really thinking too much about it. It's automatic for us. There's also slightly surreptitious or more subtle colors used, particularly by people in marketing, to get us to respond or react in a certain way. And the food industry is renowned for using this, particularly the fast food industry. And they have what they refer to as the ketchup and mustard theory, which is exactly what it sounds like. It's the color red and the color yellow. So the color red is the most studied color in all the published works. And we're going to be talking a lot more about the color red as time goes on. And the color red is known to increase heart rate. It is known to increase appetite as well. The color yellow is often thought of being a color that instills joy, because people associate it with the sunshine, and it instills our sort of our happy-go-lucky nature. Now, when you combine red and yellow, what you often find is an increased appetite with an increased feeling of joy and kind of impulsiveness. People are more likely to buy fast food when they see red and yellow together. Now, I won't mention any brand names, but if you think about a vast majority of the fast food chains out there, a lot of them have red and yellow as the prime colors used in their logo or even in their restaurants. So this is the use of color to get us to buy products. And again, you go into any marketing journal and look at color, and it is really heavily published upon the importance of various colors in various brands and how they portray certain things as well. What about in sport? Let's bring it back to our world a little bit. And this is more, rather than injury, more sports performance, but it's interesting nonetheless. Hill and Barton in 2005 took a look at all the data from the combat sports, so boxing, taekwondo, etc., from the Olympic Games the year before, so Athens 2004. And often in Olympic sports, being amateur, as I'm sure you know, in the combat sports, they're given gloves or head guards or protective padding in taekwondo, and they'll often be red and blue. What Hill and Barton found is that competitors that wear red won significantly more gold medals across the combat sports in Athens 2004. Of course, could just be coincidence, but then many years later, Dries Kamper and colleagues repeated a sort of a combat scenario with boxers, red and blue, and they found that red competitors consistently had higher heart rates. And when they did pre-contest strength tests, once they were in their kit, the competitors wearing red consistently scored higher on pre-contest strength tests as well. So there seems to be some competitive edge to the color red over the color blue. And across the literature, red is often referred to as the winning color. in soccer, or I'll call it football, and I hope you know what I mean, but in Premier League football or Premier League soccer, over the course of history, there has been a disproportionate amount of teams that have won our Premier League that wear the colour red as well, so often referred to as the winning colour. I don't know what you do with that information other than make good decisions if you're a competitor yourself. Colours can work against us, though. What this study showed is that goalkeepers that were facing penalties from opponents who were wearing white shirts had a much higher expectancy of saving those penalties. And I hope the irony of an Englishman sitting here and telling you that teams that wear white are going to do poor in penalty shootouts, I hope that doesn't that isn't missed on you. Particularly painful for me that our national soccer teams' away shirts are red. And I just don't know why they haven't cottoned on to the colour psychology of this. But clearly colours can work in our favour or against us when it comes to performance or expected performance. Trying to bring it back into our world a little bit, and we don't have loads of research on orthoses, but Wang and colleagues from China are some of the people that have done the only work I can find at present. And they looked at basketball players, took a group of basketball players with red insoles and white insoles and looked at their comfort levels and their joint kinematics and their joint kinetics when they were performing a drop landing task. Now, what they found is the red insole was dramatically more comfortable. And although there was no kinematic difference between red and white, there were altered joint loads between red and white, leading them to conclude that for uninjured players, red may be preferable for improving comfort, it may be preferable for improving performance, and it may even have the ability to mitigate injury risk. And this is from something that once they've seen it and they've put it in their shoe, once their foot's in and their laces are tied up, they don't see it anymore. How on earth is something that they've just momentarily glanced at having such a profound effect on some of these variables? Well, maybe the answer, maybe we can glean the answer to that from the pharmacology world. Because once again, when we take tablets and pills, often we only momentarily glance at them before we consume them for them never to be seen again. Now, what we have strong evidence showing us is the color of drugs, or even the color of the packaging of drugs, influences people's perception of what that drug does, and it also influences how effective they are at doing that. So if you show people red and orange and yellow drugs, they will often assume that they are stimulant. And if you show people blue and green drugs, they'll often assume that they are calming or tranquilizing. And if drugs are those colors, they are more likely to elicit those effects. And the pharmacology world is very smart in knowing this. And as such, if you're ever prescribed an antidepressant or if you ever describe something that needs to sort of, perk you up, it's far more likely to be red. And if you ever describe something for anxiety, it's far less likely to be red. They're going to use colors either in their drugs or if not their drugs, their packaging to really lean into people's perceptions of what that drug does and to furthermore influence its effectiveness. And again, it's just a momentary glance before it's never to be seen again. So I think we can sort of say that this may be that momentary glance. And even though people aren't seeing their orthoses once they're in their shoes, if they're glancing at it every morning, just that reinforcement of that color and what that color may well mean to them. So like I say, if we've got data that shows color affects the perceived action and the effectiveness of drugs, why are we happy to assume it definitely doesn't, affect the perceived action and effectiveness of orthoses? I'm not saying it does. We don't have those data, but we don't have data that says it doesn't either. Now, this was a study done in a university in the southwest of England, a very small study, and it wasn't peer-reviewed or published. So please review it in that context. But ultimately, they took a group of individuals with pain and randomized them into two groups. One group were given black top covers and one group were given green top covers. So what you need to know is that these orthoses were identical in material, shape, geometry, etc., just different colors that they could see. The individuals in the group with green top covers got better quicker and got better more frequently. Now, we don't know why. If we were to hypothesize, and it is just a hypothesis, I would say that if we think about the color or the attachments and the thoughts and the meaning that we often associate to these colors, when you ask people to think about the color black, they often think about death, darkness, decay, the plague, skull and crossbones. These are some of the things that we've elicited from our work. When you ask people about the color green, they often think about health, vitality, grass, organic, nature, the pharmacy sign, the first aid box. And it may well be that these associations with certain colors are what may well influence their perception of what these devices do and their effectiveness in doing so. That said, when we go back to the survey that my colleague Dr. Spooner and I did with those 800 people that said they don't really consider color, when we asked them multiple questions and we said, if you don't consider color, what color do you give and why? The vast majority just said they gave black. They gave black because it looked sleek and professional and elegant. All of those things are true. And because it essentially blended into the shoe and the patient couldn't see it. Well, I think it's fascinating that that's the angle that we're taking without any evidence to suggest that we may have a tool at our disposal here, making patients aware of it and eliciting thoughts and feelings and reactions may well be to our advantage. But in the research we've done, it seems that people are looking to allow this thing to camouflage into the shoe. And maybe we're missing an opportunity for this thing to elicit improved outcomes. So what about pain, color and pain? We've already said color can influence humans' thoughts and feelings and emotions. And we've already said that thoughts, feelings, and emotions are very, very strong correlates of pain. Well, these are a couple of studies here that have looked at color and its influence on pain perception. So this particular study, they attached a stimulus, a painful stimulus, to the forearm of subjects. And this was an identical stimulus applied again and again and again in randomized orders. But before they applied the stimulus, they showed them a card. And this card either had no color on it at all, it was blank, or it had one of 6 colors: red, orange, yellow, green, blue, or pink. Now, what they showed is that color has an effect on pain perception in so much that if whatever color you show someone, if you show someone a color before a stimulus, they report an increased pain intensity compared to when there was no color shown to them, the blank card shown to them. So any color that they see just before the application of a stimulus means the intensity increases. But if that stimulus is immediately preceded by the color red, the pain is the most intense of all the colors. So the exact same stimulus is perceived in a completely different way when you look at colors. And when you look at the color red, it appears more painful. So pain completely being influenced by what our visual apparatus are taking in at that time. Similar study, but this was on temperature. So this was a probe that was at a fixed temperature and applied to the back of the hand, and subjects were asked to look at a box, and the box either showed them a red light or a blue light. And they were asked to quantify what they thought the temperature of this probe was on an 11-point Likert scale. So a 0 to 10, a bit like a pain scale essentially, but it was for temperature. And what you found is a difference of over 5 points on an 11-point scale, depending on which color they were looking at. It won't surprise you to hear, if you have a stimulus applied while you're looking at the color red, you rate it as much hotter than if you have that same stimulus, exactly the same temperature, applied when you're looking at the color blue. So what we're taking in through our visual apparatus, color-wise, can influence our perception of pain, our perception of temperature, when the stimulus is identical. Now, commercially, when you look at companies that sell insoles on the internet, it seems, and I don't think it's by chance, I'm absolutely certain it's by design, it seems that they are using this understanding of color psychology to their advantage. When you see people that are looking for warming insoles because they have poor peripheral circulation, cold feet, they've been diagnosed with Raynaud's. When you go onto Amazon or other websites are available and you type in warming insoles, those insoles themselves, or if not the packaging, will be heavily colored in reds and possibly oranges and yellows as well. You will not find a warming insole that has the color blue, because it does not make sense for that. It makes sound so obvious when we say it out loud. And likewise, if you're looking for an insole that reduces foot pain, inflammatory foot pain, plantar fasciitis, you will often find that they utilize the color blue within that insole, completely blue top cover, or you think about the silicone insoles or silicone heel cups that have the shock dot for the plantar fascia. on the medial calcaneal tubercle, that will always be blue. It will never be red. Commercial companies selling orthoses, to strangers are utilizing the color of psychology to elicit perceptions, reactions, and possibly even outcomes. Yet we as clinicians, as prescribing professionals, are seemingly quite happy to write it off as unimportant and irrelevant. And I just wonder whether that feels right to anyone now that we've said that out loud. Still on the theme of colour and pain, and there's been a fair bit published on this, and I think it's quite interesting. Not just the colour that we look at affects the pain, but when you ask patients to describe their pain as a colour, you get really interesting feedback. Now, when I've said this to groups of people before, I've often got raised eyebrows, and I don't mind those. That's absolutely fine as a reasonable reaction. But people often say to me that I'm not asking my patients to describe their colour as a pain. They'll think I'm strange. They'll think I'm weird. But is it really that different to asking your patient to describe their colour as to describe their pain as a number? Pain is a complex and multifactorial, personal, individual experience, and we're asking them to boil that down to a number, which we seem happy to do. But if we ask them to describe that as a colour, for some reason that feels weird to us. And again, some patients, when you ask them, tell me your pain on a scale of 0 to 10, they find that very easy to answer, as I'm sure you've experienced as well. Others find it quite difficult. They and they are, and they just can't seem to conceptualize what number speaks to them. And I would encourage people, if you've got a patient that's struggling to give a number to their pain, go, okay, let's try something different. What if I ask you to describe your pain as a color? And they may find that an easier thing to answer. This study did just that, looked at people with knee osteoarthritis, and it showed that when people have pain that is very, very high in intensity or acute or inflammatory, it's not uncommon, unsurprisingly, I'm sure, that they describe it as red or perhaps orange. When pain is much lower in intensity, but really persistent, dull, aching pain, not uncommon for it to be described as black or as grey. And the absence of pain, very, very regularly described as blue and green. And I think this is a really fascinating area when you start asking patients to describe their pain as a colour, because it would make sense to me that whatever they say, and it's important that it's their free decision, but whatever they say, at the very least, we probably shouldn't make an insole the same colour as someone's pain. In the same way that if someone had a very, very hot foot, we might want to avoid red, or they had a very, very cold foot, we might want to avoid blue. If someone describes their pain as black, should we give them a black top cover just because that's the top cover we give everyone? Really interesting when we ask patients, clinicians, what colours they often prescribe, and they say black because it's elegant. They say, I give purple because it's the colour of my brand or the colour of my clinic. But if we haven't asked the patient what that colour means to them, we could well be eliciting a response that we don't want to. So again, we can do these things side by side. Not uncommon that we ask people some kind of pain scale 0 to 10, so a numerical pain rating scale or a visual analog scale, but we'll also ask them to describe their pain to us as a color. Really important that you give them free choice and don't give them, I'm showing this color scale on the bottom here as an example of what not to do. This is a color scale that seems to almost predetermine on their behalf what color is bad and what color is good. And that is not the way we want to present this. We need to make sure we ask them as a free choice, what color is your pain, and choose it accordingly. What color speaks to you? What color does your pain sort of feel that it manifests as? Don't give them this. This clearly is showing them that red is bad and green is good, and that may well not be the case for them. And it sounds really obvious, but just to reiterate the point we're making here is that these things are incredibly personal. They often may be influenced by culture, and they may well be contextual as well. So it is not up to us to project our thoughts and our feelings and our perceptions or beliefs or favorite colors onto patients. Just because our clinic is a certain color, if we give them that color, that may well be the color that they would describe their pain as if we'd bothered to ask them. And if you think about, again, the way that we interact with color in the world, and we do this on a really, I guess, subconscious level as well. There are times when we intentionally avoid color because we are worried about the response that they may elicit in other people. Think about how when you put your house on the market, you may well redecorate it in very neutral colors to increase or widen the net of people that may well be looking to buy. Or when you're going to weddings, funerals, job interviews, you're far more likely to dress in blacks and whites and navy blues rather than elicit what may be inappropriate or unnecessary responses to the color you're wearing in other people. So we do this completely subconsciously. We need to do it in the clinical setting as well. Do not project our thoughts, feelings about color onto other people. Give them completely free choice, and we'll talk about what that looks like just shortly now. So hopefully you're still with me and you agree that color is well studied, not necessarily in podiatry and in foot orthoses, but the way humans respond to color in many, many facets of the built up Western world is very, very clear. What might this look like for us in the real world? And might being a word that's doing real heavy lifting here. This is just a thought experiment by me, a hypothesis, just to see what you think. And also to highlight, and I've not said this yet, and it's important for me to say this, also to highlight that this consideration of color does not replace anything we already do. We still do everything we already do and everything we've always already done, and color is an addendum to that. And here's what I mean by that. Here's scenario one. Let's imagine a runner comes in to see us in clinic and they are currently uninjured. They are performing well. They are coming in with the goal of getting an appraisal of where they're at, doing anything they can to further maximize performance and to hopefully minimize or mitigate injury as best they can. That's their goal. They come to us and what they want to achieve is, I want to be a better runner, I want to be faster, I want to perform better, and I want to try ideally and not get injured in the process. So we don't do anything different to what we always do in these situations. We take a strong subjective history. We take a good, perform a good objective examination. All facets of performance and injury risk will come into here. We will often ask them about their sleep, their stress levels, their diet, their recovery, their strength training. We will look at them orthopedically, look at their flexibility, again, strength deficits. We will perform some kind of biomechanical evaluation, appraisal of their footwear, appraisal of their foot mechanics. And all of this will come together and it will form the advice that we give them, which is, we've identified some strength deficits. Why don't we work on your gluteals and your soleus? Because we know they're important for runners. We've also identified that you're not sleeping enough and that you're not recovering well. Your training isn't organized well. We look at your running volume, frequency, intensity. We can organize that a bit better. We do all those things that we've always done. We provide a summary of their biomechanical findings, and we say, perhaps at this moment in time, you may be a good candidate for foot orthoses. We think alongside all the other things, something in your shoe may well further optimize your mechanics and help you achieve the goal that you're searching for. And they say, great, let's do it. And at this point, we've not described anything that all of us aren't doing on a regular basis already. The difference, of course, is normally at this point, we would then take a lot of time and a lot of thought and attention on what prescription we were going to write, how we were going to design this, what material we were going to use, what posting we were going to use, etc. And then we may well just slap on the top cover that we always use, black, because it's the one that the lab give us, or purple because it's the color of our clinic, whatever. And all I'm saying here is at this point, on top of all the things we've already done, maybe we just take a few extra seconds to think whether color might be important and to entertain the idea that it might be. And if so, what color are we thinking about here? Well, again, they're uninjured. They are looking for performance improvements and injury minimization. And what most of the research points to, loosely albeit, is that red is the winning color. Red is a color people associate with performance. Red is a color that increases heart rate. Red is a color in orthoses that is shown to be more comfortable. So it may well be something to consider. Now, again, bring them in to the discussion at this point and ask them if there's any color that speaks to them, if they have a favorite color. And what you may find, if all going well, that, let's say you're having this consultation on the west coast of the US, and they say, well, actually, I'm a Niners fan. Great, we're in business here. I'd imagine a Niners fan would quite like a red insole, and red is a color that in the context of an uninjured runner may well bring about some of those other common goals. So it's a very, very small extra few seconds of thought just to slap a top cover onto all of the other things that you've already done. And it may well have an influence on that patient's perception or experience or outcome with those orthoses. Of course, it may well not. But these are the thought experiments that I want us to all work through. What about a different scenario? What about someone who comes in who is injured? And this is certainly a bigger percentage, I guess, of who most of us are seeing on a daily basis. So a runner comes in and they're injured. So once again, nothing at the start of the consultation changes. We still do the things we do every day, the things we've always done for many, many years. And that is a good subjective history, a good objective examination, all of the other things: sleep, nutrition, recovery, strength, appropriate analysis, biomechanical evaluation, footwear appraisal, foot mechanics appraisal. But of course, alongside that, we would often ask them very specific questions about their presenting complaint. So we may well say, what's the nature of your pain? If you had to describe your pain, give us some adjectives that describe your pain. What adjectives would you give? We may well say, where does it hurt? How long has it been there? What makes it better? What makes it worse? All of these really, really common questions. And then we may say, if you're, on a scale of 0 to 10, what would you score your pain? And all I'm saying is, we've always done that. We don't not do that. But on top of that, we take an extra 30 seconds to ask an additional question, which is, what colour is your pain? Well, if your pain was a colour, what colour would it be? And see what they say. Now, at this point, we are hugely hypothesizing, but what Dr. Spooner and I, and he's my colleague in the UK here, we've been doing all the surveys together and doing this research together. What we are currently thinking, or the process or the lines we're thinking along, is that if someone says to us their pain is a certain colour, we choose the colour for the insole on the opposing side of the colour wheel. And this is a colour wheel here, by the way, first invented by Isaac Newton. So he wasn't just great for his physics, he was into colour as well, of course. And the colour wheel is an important thing. If you're going to ask the patient what colour their pain is, you either give them a completely open question with no visual cue, or if you're going to give them a visual cue, make sure you show them a colour wheel. Do not show them a colour spectrum in a line, because that will once again make them think that, be like the 0 to 10, that one end is good and one end is bad. You don't want to preload any kind of thought process upon them with regard to what colour is good and bad. A wheel gives them completely free choice where all colours seem to have equal meaning. So show them a colour wheel and ask them to pick a colour. Vast majority of people will usually pick red, as probably is already obvious, sometimes orange. But if someone comes in and on the colour wheel they pick red, then what Dr. Spooner and I think is maybe we should pick colours on the opposing side of the colour wheel. And if we think about what the research tells us, red is more described as inflammatory pain, blue and green are more calming and tranquilizing. It makes sense, and they're all on the opposite side of the colour wheel, that if someone comes in and we decide as part of their advice, do this strength work, do this rehab, eat a bit better, sleep a bit better, and also here's a pair of insoles, or here's a pair of foot orthoses as part of that wider approach, your colour is described as red. Opposite of that is green. Why don't we give you a green top cover? Green is a calming colour. Green is a colour people associate with health, with vitality, and it's sure to win. And if we were on the east coast of the US, let's say we were in New York having this consultation, and they happen to be a season ticket holder at the Jets, I'd imagine that process may go really rather well. They've come in, we've done all of the things we normally do, we've made all the sensible biomechanical decisions we normally make, and all we've done at the end is we've picked a colour that is the colour of their supporting team and happens to be the opposing colour on the colour wheel that they describe their pain as. If we're in New York and they happen to be a Giants fan, I suspect you may want to favour blue. I don't know, but it's a discussion you're going to want to have. So once again, even when you ask them what colour their pain is, don't just pick the opposing colour on the colour wheel, involve them in the discussion. And if they say, I just really don't know what colour my pain is, just say to them, is there any colour you'd prefer your insoles to be? And they may say, purple, green, orange. But the point is, include it in the thought process. Up until this point, it's been completely excluded in thought, it's been disregarded as important. Like I say, the survey we've done, people say they don't, we've asked the practicing clinicians, do you offer color to your patients? And over 80% have said no. And when we ask them why, they say it's just irrelevant and it's not important. Interestingly, whilst we don't have evidence or published work to say it is important, which is reasonable, we don't have any published evidence to say it's not important. So it's really interesting to see that we just landed on that it's not important, when it really doesn't take much more thought, it doesn't take much more time, and it doesn't replace or usurp, or it's not superior to anything we already do. It just tags on to the normal foot orthoses process and clinical reasoning that we go through. So that concludes my talk. I've put a QR code here that you can, if you capture this QR code, it will take you to a page which shows you how you can get in touch with me, my email address, my social media pages, and I'd really encourage some discussion about this. Again, apologies I can't be there for real-time questions, but I really am keen for some feedback. Now, again, I've talked to enough people about this, and I'm fairly thick-skinned that it doesn't have to be. I'm not only suggesting I want feedback of people that think that this is great and that they agree with me. I know that this is not a topic that people are immediately on board with. It doesn't feel like good science. It feels woolly. But hopefully I've presented enough science. And if we conclude by saying all of us agree that we don't understand orthoses mechanisms of effect as well as we could, all of us want to understand them as best we can, because all of us want to improve our outcomes for our patients as best we can. And hopefully what I've presented is that color has a significant ability to influence the way people feel and think and behave. So is the color of this device not something worth considering? I'd really love some messages on social media or some emails from people that sort of have some thoughts on this. And I'd also love your take, because most of our research, or all of our research at the moment, has been within the UK. So it's great to have the opportunity to speak to an international audience. And I'd love to get your take on what you guys and girls are doing the other side of the pond. I mean, is this something you're already doing? Is this something you're already really considering? And if so, what's your experience with it? I'd love to hear that. Is it something you've never done before, but now you've heard it, you think that, that makes sense. I may think about it. Or is it something that you immediately think, this is utter nonsense? All three of those responses, by the way, are completely reasonable and completely valid. I just love to engage and interact and discuss things further. So please do snap the QR code, reach out to me, and let's have a chat about these things. But I'll close just by saying once again, thanks to Rich and to LER for the really kind invitation, and many thanks for your attention as well.
Well, I hope you all enjoyed that. I thought that was a great way to sort of close out, 2.5 days of this event, which I thought was pretty phenomenal. I'm going to put up the mini survey that we have. Where'd it go? Oh, there it is. Survey at the top to tell us how well we did, what you thought. Please leave comments. If you really love what we're doing, tell your friends, tell everybody. I would like to get 1,000 podiatrists on an event. This was by far our largest, and I'm very proud of that. I'm also very grateful for all of the speakers. I'm grateful for all of you in attendance. We couldn't have it without you. I've already shared that. I just have an immense amount of gratitude and appreciation for all of you that follow us, that stay connected with us, that are part of all our events. And I just love what, somebody told me, I think I shared this or I shared it on LinkedIn, when you love what you do, you never work a day in your life. And, I hope that you all can say that. I know I can at this point in my career. I'm having a blast doing this. I've just met some incredible people over the past few years. I mean, I've been in this world for over 30, but really have met some really great people, and just want to keep bringing the best education available to you. I know it was a long weekend, obviously. I think we tallied up about 28 hours or 29 hours. I'm all in, 25 CME. We'll take care of it all. Thanks for all the great comments. I really appreciate it. I'm truly humbled. by how far we've come in the past 2.5 years. It's pretty incredible. Our first LER Expo event was in June of 20, and now we are about 40 events in, and I think they keep getting better, and keep getting a little more diverse. Matter of fact, in a couple of weeks, we're doing a non-medical related event called river cruising. So if I've never been on a cruise, but if you ever had an interest in river cruising, it's a free event. It's going to run 3 nights in a row. It's only an hour and a half. We're working with a couple of real higher end river cruising. We're going to do European river cruising, exotic river cruising, and domestic river cruising. Kind of interesting. As I've mentioned also, we're doing a lymphedema and wound care event. That'll be in April. Just keep an eye out for what we're doing. We're talking about doing a financial estate planning. I mean, we have all types of access to all types of experts, and we just want to, keep bringing content to the community. I think we're really bringing a really good value, and we bring a lot of free events, a lot of free CME events. We also bring obviously a lot of paid CME events, but keep in touch with what we're doing. Keep in touch with me. Connect with me. LinkedIn is great. Through the platform is great. Any email me. Thank you. I think we've had some attendees attend close to 20 of our events, which is pretty awesome. So, well, thank you. Thank you for all the great comments. It's Sunday at almost 3:00. You've definitely earned your credits over the last couple of days. And I really, once again, just tremendous thank you to all of you. I really, really appreciate all the support, all the positive comments and feedback. And I don't know what else to say. So I'm just going to leave this open for a couple, so you can click on the survey, say whatever you want to. We really appreciate all the comments, all the feedback. As you can see, I answer every email, every message I get, I respond. So, that's important to me, and I try to put that at top priority. So, stay well and have a great one. Take care. So I'm going to come back for a minute. I'm getting a lot of private messages over regarding CME. So if in fact you missed a session or two, couple, three, whatever the case may be, you can go back in. All you do is log back into the platform. You can watch. It'll say, instead of saying preview or join, it'll say watch recording. I believe almost every recording is up there right now. With the exception of, let's see, maybe even Matt Rogolski's session is up there. Let me just check real quick. Yeah, even Matt's session is up. So the only session that's not recorded yet is this one, and that's because I haven't entered, I haven't exited. So if you need to message, if you need to watch one you missed, you know what you missed. please feel free to message me and let me know, that you missed. So Bart, we leave the recordings up. We do not take them down. If you attended either last year's conference or the 2021 conference, you can literally log back in your dashboard, and you can go in and watch all of those videos for the last couple of years if there was a session that you wanted to refer back to. We leave it up in perpetuity. We don't take anything down, and we don't, for all the attendees that paid to be here, we do not charge you again to go back in and watch the videos. The only thing is you don't get any more CME unless you attended the event live. But really, I think that's it. I mean, if you have a question, again, just message me. I'll answer it. That's what I do. And yeah, you could absolutely. There were some really good sessions last year as well. You can go in anytime. Any event that you've taken with us, if you go back into the platform, you can access any one of those, any one of the recordings for any event, and you can watch them. We do have many of the recordings also on lerexpo.com. So if you want to log on to lerexpo.com, you can see all our past events. You can see a couple of upcoming events. But the best way to stay abreast of what we're doing is to follow me here in this platform or to connect with me on LinkedIn. And the River Cruise event is simply just go on to LER Expo. Actually, I could put that up as a matter of fact. We're still fleshing out that agenda. River cruising is pretty cool. I've never gone, but I've learned a lot about it in developing this event. I'm doing it in conjunction with a friend of mine that owns a publication called 55 Plus. And it's going to actually be really, really informative. Working with a virtuoso travel agent who's like the top. There's only, I think, 200 of them worldwide. And we have Viking on there. We have Alma Cruise Lines on there. We have a couple of really high-end river cruise lines. So if you've ever been on one, cool. If you're interested in learning about it, cool. It's kind of a nice little way to, de-stress and learn about, river cruising. Let's see. If you go to lerexpo.com, I think it's up there. Let me see. lerexpo.com. Upcoming events. All right, that's not posted yet, but if you're following me, you'll get an invite to it. If you're a subscriber to LER, one of our emails, you'll get an email to it. So anybody that wants to be messaged on that, let me know. A couple extra on the phone. You will be all set. Everyone's all set. We're not looking to, you were there, you were there. So CME certificates usually take about 2 weeks. I just got that question in the back end. Usually about 2 weeks. We tally all the records, all the attending records, then we tabulate them, we send them off to CPME, and then we get the issues. We'll issue the certificates. That'll also go into a dashboard. So we have a program that we use. You can log in, download your certificate. We also put a badge in there that you can share on social media. We encourage you to do that. Tell your colleagues if you like what you experienced here and you really enjoyed the conference. Tell everybody about it. The last one from Pete's. Oh, Greg, you didn't get your send me an email, Greg, and we'll make sure that you get that. That should also be in your dashboard. I know you've been to a couple of our events. We did a pediatric foot and ankle event in January. That was pretty incredible as well. I will make sure to get out some info on accessing your certificates. So we'll make sure to get our team on that so you can easily log in and get your certificates. Anyway, I'm going to call it a day. Go grab a bite to eat. I hope you all enjoy the rest of your weekend. I think I've answered every question that we had. And have a good night. Until next time.